Yes, I hear you.
Thank you. All right, you good.
Okay, I know the suspense was building. Now I feel like I had to give a really exciting talk. Okay, so welcome to the afternoon session. Thank you, Uli, for letting me speak. So today we're going to talk about monitoring devices in heart failure, certainly inclusive of CardioMEMS, but not all about CardioMEMS. My disclosures are listed here. So today we're going to describe the remote cardiac monitoring that's available to the heart failure community. So over the last 5 years, it's really increased to a significant component of what we do to monitor heart failure patients. We're going to review the current CardioMEMS data, which is an implantable hemodynamic pulmonary pressure sensor system. And we're going to talk about the pros and cons of remote cardiac monitoring. And I abbreviated remote cardiac monitoring, which you'll see in the subsequent slides, as RCM. So the most important piece of information is that remote cardiac monitoring is a tool. It's not a treatment. And so it's only as good as the person who's monitoring it, what the indication is to put it in. So we're going to tell a little bit of a story about remote patient monitoring. The most important thing to know about remote patient monitoring is in the patient selection. So what are our goals of why we want to monitor patients closely? Is it to decrease heart failure hospitalizations? Is it to decrease mortality? Is it to improve quality of life? What are the costs associated with monitoring a patient? How long do we monitor the patient? And do we implant devices, or do we think about non-invasive ways of monitoring patients? So this slide tells us a little bit about the important components to consider when we want to talk about a patient for remote monitoring. One, we want to identify, we want to assess who that patient is and what our goals is of providing the procedure. We want to establish an infrastructure with a coordinator to review the information and who's going to review it, and then who's going to actually implement device strategies and treatments for that patient. And we want to make sure that there's a reliable person on the other side that's going to continue checking the device and doing subsequent readings year after year. So we want to provide proper patient education to those people as well. And taking into account all of these issues will help us to identify the best patient possible and provide the best outcomes for that patient. So I'm going to tell the story a little bit about how remote patient monitoring became so popular in heart failure. In 1995, in the New England Journal of Medicine, Dr. Rich published an article looking at the benefits of using telephone monitoring, which is something that we still use today. However, it's quite antiquated. And we use telephone monitoring to identify patients' symptoms before they come to the hospital. But unfortunately, it wasn't a one-size-fits-all treatment. We couldn't figure out what information was relevant to gather from the patient. Was a weight increase pertinent? Was a change in diuretics helpful for that problem? And so there's been tons and tons of trials since then, some small, some large. These are the 5 largest trials that looked at using telehealth monitoring. And basically all these trials were neutral, unfortunately. And you can see in the Mayo Clinic study, which was 205 patients, that actually having more contact with the patient may actually increase healthcare utilization, because we weren't focusing on what's important to assess from the patient. Is it the weight? Is it the blood pressure? Is it the heart rate? Is it the pulse oximeter that tells you that information? And so patients were getting sent to the ER perhaps unnecessarily for this reason. So what we learned from these articles since 1995 is that we need to find a smarter way to monitor these patients, and perhaps telephone monitoring and perhaps just getting vital signs from home is not enough. So what is available right now in the 21st century? Like I mentioned at the beginning of the talk, we have a lot of implantable and non-invasive devices that we can use to monitor patients. So I want you to be familiar with the nomenclature. CIED refers to cardiac implantable electronic devices. An example of this would be something like a defibrillator. So defibrillators would contain remote monitoring basically through thoracic impedance. And I'll remind you that thoracic impedance is basically where there's resistance to flow of an electrical current between 2 points. And an example of this would be Optival or CoreView. The problem being that a patient has to get a defibrillator and have a criteria for a defibrillator in order to have this technology available to them. So subsequently, other things were looked at that we could maybe combine information in patients. Something like HeartLogic, which is a technology that was put out by Boston Scientific, perhaps has information where we could gather not only information from their defibrillator, but also information on respiratory and heart rate control and patient activity. And by using all of this conglomerate of information, perhaps we can come up with an algorithm that tells us the patient has a high risk of readmission. Some of the other things that are attractive are some wearable devices. Why? Because wearable devices are non-invasive. An example of that would be the HMFS device, which is a heart failure monitoring system put out by Zoll. It's basically a patch that the patient wears, and it also uses thoracic impedance technology, but it's not implantable. The REDS vest would also be an example of that. The SMILE study looked at the benefit of that. And these are, again, tools that tell us the odds of being admitted to the hospital based on trends that we see in thoracic impedance. Some of the invasive tools that we know about are CardioMEMS, which we'll talk about in the subsequent slides. The Endotronics device that was studied recently by Cordella. This is a tool that not only uses an implantable PA monitoring device, but also has information on non-invasive tools such as weight, heart rate, pulse oximeter, and blood pressure. So the patient goes home with basically a tool that's used for monitoring and has the implantable device, and all that information is put together to try to figure out if a patient needs to be optimized on medications. You may have heard of the VLAP, which is a Victorious trial. This was a trial that was recently published looking at a left atrial wireless system. And that was implanted in 30 patients. It was really a safety trial, and it did show that the device is probably safe to use. And then there was a first in man, the FIRE-1, which is an IVC filter device. That was only put in 9 patients in Europe, and that basically looked at the changes in the size and the shape of the IVC, may be able to tell us if a patient's volume overloaded. So that's the first device that we have that looks at right-sided pressures rather than left-sided pressures, as the subsequent other 3 devices do. So these are some of the implantable devices that you'll be seeing down the line. I think there's going to be a lot more information looking at left atrial pressure devices and certainly IVC devices because they're so novel. Some of the other things you'll probably hear about is there's a study looking at changes in voice parameters for patients called the MonteHeart system. And that's basically going to tell us using an app on the phone if the patient has changes in their speech that detects size of volume overload. But above and all, it's unclear now. More and more devices are coming out between wearables, implantable devices, non-invasive hemodynamics. Which data is actually important for us to know? So who are the right candidates, and what do I choose? What kind of device if all these devices become FDA approved? So the first important information, identify who needs the devices. Make sure the patient's sick enough to warrant the device. Otherwise, there's not going to be cost savings. So a patient that's NYHA class 2 or 3 might be somebody that needs to be considered. Somebody who has symptomatic heart failure, evident by an elevated BNP, somebody who's been hospitalized in the past year, somebody who has a decreased quality of life, but also the logistics behind placing one of these devices. Is the patient reliable enough to answer the phone or to follow medication instructions? Is the GFR good enough they're going to respond to diuretics? Is it a patient who's headed towards dialysis? These are all the things to consider when we're choosing the device and the duration of the device. An implantable device obviously would be in longer. A patient who has algorithms on their defibrillator has kind of add-on therapy, but it's a trend over time. It's not a daily monitor. A patient has a wearable may only have that device approved for 30 days. So that might be somebody who's been discharged in the hospital recently. All these things need to be taken into account to choose the right patient population. So we're going to talk a little bit about CardioMEMS. Where are we? Where have we been? So CardioMEMS has been FDA approved since 2014. The CHAMPION trial was the first trial that looked at the benefit of using CardioMEMS. And that, to remind you, is 550 patients. It was all chronic heart failure patients, irrespective of ejection fraction. They were all on optimal medical therapy, and it was a 6-month trial. So what that showed us is that there's a decrease in heart failure hospitalizations. There is a decrease in mortality, primarily in the heart failure with reduced ejection fraction subgroup. However, the trial was not properly studied to look at mortality. It was really looking at heart failure hospitalizations. And what that showed us is that there's a 37% reduction in heart failure hospitalization using the PA pressure monitoring system versus traditional therapy. Then there was a post-approval study, which was a real-world study looking at 1,200 patients. It was 1 year. It also looked at heart failure hospitalizations and all-cause hospitalizations and showed a reduction subsequently. Then there's the European trial called the MEMS-HF. That was run in the Netherlands, Ireland, and in Germany, and it basically proved the safety and feasibility of using a pulmonary artery pressure sensor system. And then there was a famous GUIDE trial, which everyone remembers because it was just published recently, that really looked at increasing the inclusion criteria for CardioMEMS to a class 2 population, perhaps getting rid of the heart failure hospitalization, just using a high BNP as an inclusion criteria. It was 1,000 patients, and they did look at mortality, heart failure hospitalizations, urgent heart failure visits. And interestingly enough, the trial occurred over the time of COVID. And so when they looked at the total composite of these endpoints after the COVID epidemic, there really wasn't a massive difference between the control group and the intervention group. And so they did a pre-specified COVID analysis that looked at the time when the device was going in before COVID. And what that showed us is that there's a decrease in heart failure hospitalizations, but when they controlled for the time during COVID, that decrease was actually much less, and it was similar to the control. And so the idea was that perhaps patient behaviors during COVID really influenced changes in pulmonary pressures. So I'm just going to show you a video. Of the implant. Actually, please. So for anyone who's not familiar with the way that this device works, it's put in through ideally a femoral vein, but can be put in through an IJ as well. Clearly, we have enough safety data that shows that the device is safe to implant. So the device goes in through, ideally, the right femoral vein. It's a 12 French system. Goes up through the right atrium, through the right ventricle. Baseline right heart cath is done first, up to the pulmonary artery, ideally placed in the left pulmonary artery, just because of issues with it having a posterior position. You want to get it as parallel as you can to the spine when you place it. So in AP projection, you're going to see the 4 nitinol loops come off, and the device endothelializes within 30 days into the pulmonary artery. You want to make sure your pulmonary artery, when you do your angiogram, is between 8 and 15 millimeters, ideally. Otherwise, the device may rotate in the body. If it's greater than 15 millimeters, the device may cause thrombosis if it's less than 8 millimeters. So we do a pulmonary artery angiogram with the balloon up, because a balloon tip catheter is about 10 millimeters. That's giving you the proper size. And the device is MRI compatible after a month. Patients that are really ideal for it are patients that have less than 1 PE or perhaps never any pulmonary embolisms, can tolerate dual antiplatelet therapy for 1 month, which is what they have to take, and patients that are able to formally do a reading every day. The reading takes 15 seconds. And the reading takes 15 seconds and it gets wirelessly uploaded to a portal system. And then the portal system is checked by the physicians and subsequent staff. So what I want to show here is a meta-analysis of the 3 trials that we have that look at invasive pulmonary hemodynamics. So we talked about the Champion trial, we talked about GUIDE, and this is all the HFrEF population. That's why I mentioned GUIDE has 1,000 patients, but 530 of them were with heart failure with reduced ejection fraction. And then you might remember the laptop HF trial. So that was a number of years ago. The trial wasn't complete. It was stopped prematurely due to safety concerns. But the data we have on that show that there may be some benefit of using the device. It was a left atrial pressure sensor. The data was sent to a Palm device, and then patients were actually given instructions on that Palm device for what to do with their medications. But the limited data we had did show that there was some hemodynamic monitor was successful, and that it probably would have showed a benefit in decreasing heart failure hospitalizations. But unfortunately, the device just wasn't safe. So we have this VLAP system now that is probably something that has less safety concerns that we'll see. But the point of why I wanted to show you this is because consistently across the board, heart failure hospitalizations were less in heart failure reduced ejection fraction patients, both in GUIDE, in Champion, and in the laptop trial. And again, these were over really a series of 9 years. And they all show consistent results that using invasive pulmonary pressure censoring will decrease hospitalizations across all of these trials. This is actually our data looking at patients who were admitted to a quaternary care center. It was 77 patients, 34 of them had cardiomems, 32 of them were monitored by usual care in a disease management program, so still being monitored by a heart failure program. And these patients were used as their own control. So 6 months prior to implant of the cardiomem, 6 months after, we looked at their hospitalizations, and you can see 100% of them were admitted to the hospital. That was their inclusion criteria to get the PA pressure monitoring system. And then only 16% of them post-implant were admitted in the subsequent 6 months. Also in this paper, we showed very nicely that the quality of life scores were quite improved based on the Minnesota Living with Heart Failure questionnaire. So if I'm showing you all this good data, we're going to keep out of the hospital, there's all these different tools we can use, then what are some of the pitfalls and why do people criticize remote monitoring? And a big problem is the issue with patient adherence. So I think it's very important, depending on which device you choose to put in, whether it be an implantable device or a non-invasive device, that you remind the patient it's a monitor and it doesn't deliver therapy on its own. And so identifying who the right patient is, that they have enough risk and they're sick enough that they warrant some kind of device is important, that this is going to be something that you have to have commitment to actually doing every single day. And you want to make sure you don't wait until the patient's too sick. It's very hard to change the trajectory of somebody who's already stage D, already has CKD5, or is headed towards dialysis with medications, right? The device doesn't make things work better. It makes the treatment strategy smarter. So it's important to remind the patient they need to check the device. They need to make sure we know what to do with the information. So setting a goal for the patient when you put in a CardioMEMS is very important, knowing what we're working towards and what a deviation from their pulmonary diastolic pressure should be, and then having a plan for how to interpret the data received. I think one of the reasons we've had such a successful program is that before we had the 300 patients, we said, this is going to be our system. Before we implant any patient, we want to make sure we have enough staff. We have enough staff 7 days a week. We have enough people that can monitor the device and know how to do the information before we start implanting patients. I see way too many programs that have 5 patients and say, well, we're fine, but what's going to happen when you get to 200 patients if you only have a nurse that can call the patients every other day? So there has to be a system that's in place that can work regardless of how many X amount of patients you can get. Because theoretically, if I told you that it's any patient that has New York Heart Association class 2 or 3 that's been admitted, that's a high BMP, that's a lot of people in theory. So in conclusion, patient with a hospitalization for heart failure in the prior 12 months or an elevated BMP or having class 2 or 3 heart failure should be considered for some type of remote cardiac monitoring. The decision that you make, whether it be implantable or not implantable, really has to be based on the individual. It may be cost effective for hospitals by preventing admissions, as I've shown you. And it can obviously be invasive or non-invasive depending on the duration of the time you need to monitor the patient. But the practical side of implementing remote cardiac monitoring is complex, and the division of responsibility needs to be delegated before any implant should occur. And I'm happy to take any questions.
Let's do the turnover. And
okay.
Stay there, but let's do the turnover. Go ahead.
I'll read your own and transport.
You just bring it. Sasha, use a microphone because people online won't hear you.
Hi, Rita. Really good.
Hi, Sasha.
Talk. Thank you. I just want to ask you, because in addition to CardioMEMS expert, you're transplant and LVAD cardiologist. So what do you think about utilization CardioMEMS in managing the LVAD patients? Anyway,
yeah, great question. So recently there was a trial that looked at this exact question, the timing of when to implant a patient. It's called Intellect 2. It's a small trial. Sponsored by Abbott. It looked at when to implant the device to the patient, who's the right patient for it, and do patients do better after they get implanted and they get CardioMEMS? And the short answer is yes. So we know that patients don't get rid of heart failure with getting LVAD, right? And a lot of our patients now are potentially destination patients. And so optimizing their fluid status is very, very important. A lot of our patients have pulmonary hypertension when they go on for LVAD therapy. A lot of our patients have mixed pulmonary hypertension. CardioMEMS really helps us to decouple that pulmonary hypertension, to manage their pulmonary venous hypertension, and more importantly, to speed optimization them. So, a lot of us like to bring patients to the cath lab after LVAD therapy, optimize their speed with a right heart cath. They think it's a great idea. And you have this tool available to you every single day. You're not going to change their speed all the time, but you're getting them on the right medications. You're going to make sure that their RV is hanging in because you have that information. So I think CardioMEMS is really helpful after an LVAD and potentially can be used as a bridge even before an LVAD to sort of tell you the timing of when a patient gets sick enough to warrant more important therapy and more advanced therapy.
Rita, question from White Plains, complex question, can brief answer. Any role of artificial intelligence in managing, in remote patient monitoring?
So great question. And absolutely, there's a tremendous role for this. I think the first way I'd use it is now that all these tools are coming out and it's an arsenal of information, how do we choose the right patient? And this is where AI, I think, is so important in choosing the right patient. In our little anecdotal experience about using a small system hospital, it's been arduous to even figure out in the community who is the right patient, who monitors these patients. Does everyone put it in? Does the referring cardiologist monitor it? AI can sort a lot of that out. So I think it's extremely important. I see that's where it's headed. I think that we're going to be able to define what tools are right for the patient based on using AI and when the right time to maybe put in something invasive versus non-invasive. Should we use a wearable for a period of time and then say this warrants now invasive hemodynamic monitoring?
Yeah, I agree completely. I almost feel it should be we're waiting for it to come up with him it should be restricted to heart failure cardiologists to implant.
Yeah, I completely agree. I think it actually
interventional cardiologists are fair to introduce. I showed you a picture earlier.
No. So it maybe goes to my question, which I was going to ask, right? We'll address that. So there's so many, as someone who's interested in device development, there's so many monitors right now being developed.
Yep.
And I get to see a lot of them before they come to use. And people are monitoring everything. They can monitor pressures.
Correct.
They can monitor impedance,
what information is important?
interstitial fluid.
Yep.
I saw one now. Electrolytes.
Yep.
Right. So for you guys as the heart failure people, if you could choose one monitor, okay, what would you measure and where would you put it?
Yeah, I always give the same answer because I get asked this question all the time. So pulmonary diastolic pressure is very important as long as we're choosing patients who are mostly post-capillary pulmonary venous hypertension, right? It's going to give you a pretty good assessment of their wedge and CVP. If I could have those two pieces of information, now the question is where would I put it, right? How do I get that information? You can't get it from one
I know
spot.
where to put it.
So what if I gave you a device that I could put in the atrial septum and give you left atrial and right atrial pressures? Wouldn't that be better then?
But you're putting a device in the septum. So based on that, there may be a change in physiology just from putting a device there.
No, but there'll be no hole.
Okay, there'll be no hole.
There'll be no hole.
Then that would work. Yeah, those are the two pieces of information that help you the most.
Then I'll give you direct left atrial pressures. And isn't that, and even
That was my answer. That was
Yeah.
my answer.
And so that's where my question goes to, is our heart failure specialists only going to be doing it? Because accessing the left atrial septum.
Well, that's what I was about to say, Azim.
That's
So
the
that's the
challenge.
one issue is that, we put this device in, right? And I wouldn't say we're not interventional cardiologists and we're not structural people. So accessing the septum is a whole new skill set. And remember, look at laptop, right? That was accessing the septum. It was unfortunately prohibitively dangerous. There was too many complications. So if you want to put it, and only information is only as good as the initial implant that you do, right? So I can just say, well, somebody else can do it. That's fine. But we all know we're very specific about how we do our right heart caths and the information that we gather and setting that goal at the time and the timing of when we do the implant. All those things make a huge difference, right? I could do this implant in anyone who's volume overloaded. How am I going to set their goal, right? The information has to be at the right time.
Okay, great. Let's move on to something that only Dr. Latif can do, so he can stay in his lane. So thanks so much. That was great. I would like to introduce the panel. On the left is Evan Ho, who is the Director of Structural Imaging. Azim Latif already spoke and has Director of Interventional Cardiology. Steve Forrest is Cardiac Surgeon, Director of Lung Transplant. We're now going to switch to other devices, particularly MitraClip. And Andrea Scotti from Interventional Cardiology is going to show us two very cool cases for discussion.
Good afternoon, everyone. I'm going to show you a couple of cases we did in our center here in Montefiore. The first one is a case of severe functional mitral regurgitation, in particular in the setting of being outside the COAPT criteria. So let's start by saying what is COAPT, just to remind everyone. The COAPT trial was the randomized controlled clinical trial that was performed to assess and compare transcatheter mitral valve repair with edge-to-edge repair technique using the MitraClip device compared to medical therapy alone in patients with secondary mitral regurgitation and heart failure. On the upper left, you can see this was the original trial. Now, recently, the 5-year data has just been published. What we can conclude from this trial is that transcatheter edge-to-edge repair is safe and effective in reducing heart failure hospitalization and increasing also overall survival up to 5 years if we compare this to optimal medical therapy alone. This was a real paradigm shift in the treatment of mitral regurgitation. And as you can see, this was adopted in the American guidelines for both secondary and primary MR in case of high surgical risk. So what is like being outside the co-opt criteria? Because of course, all of this, as in every trial, this applies to people, to patients who meet co-opt inclusion criteria. So let's look at who doesn't meet the co-opt exclusion criteria. In literature, just to make this easy, the co-opt exclusion criteria have been categorized in these three big groups. The first one is hemodynamic instability, which is defined as systolic pressure below 90, cardiogenic shock, need for inotropic support, or MCS. There is another category of severe left ventricular impairment with low ejection fraction or dilated ventricles or a stage D heart failure. And then there is another category which includes right ventricular impairment, severe pulmonary hypertension, or severe COPD. So what we know is that not all these co-opt exclusion criteria are the same. We can see that there is a trend for better outcomes, so lower rates of death or heart failure hospitalizations at 2 years when the group of right ventricular failure, pulmonary hypertension is met compared to hemodynamic instability and left ventricular impairment. And what we also know is that, of course, this is reasonable. Having more than one criterion leads to worse outcomes compared to just one. So why this is important? This is important because what we know from multi-center registries, mostly from European centers, up to half of the patients who are treated with the mitral clip device, they don't meet the co-opt inclusion criteria. You can see here 49%, 35, 47%. These are percentages of co-opt ineligible patients in real world practice. And in the bottom left, you can see how these patients are stratified according to having one or more than one criterion. We also did this multivariable Cox regression analysis trying to understand who are the best candidates when patients do not meet co-opt inclusion criteria. And this is a list of predictors we can use. So the absence of hemodynamic instability, which seems to be the worst criterion among the co-opt exclusion criteria, absence of AFib, COPD, a low NYHA class, a younger age, of course, a low creatinine, and also smaller ventricles. So now let's start with presenting this case. This is a case of a male of 85-year-old, a past medical history of diabetes, hypertension, and a cardiac history of non-ischemic cardiomyopathy, AFib on Eliquis, and not severe coronary artery disease. On the right, you can see the medications. He had very low blood pressure. It was followed by our Professor Hardy, and this was the best we could get with medical therapy. And he was presenting to his clinic very often because of peripheral edema, shortness of breath, orthopnea. He was in stage D, NYHA class 3B heart failure. So first thing, the dosages of diuretics were increased, and he was admitted in the heart failure unit. So if we think about the co-opt exclusion criteria we saw before, stage D advanced heart failure is an exclusion criterion according to co-opt. So this patient wouldn't have met any, wouldn't have been enrolled in the co-opt trial. So we moved forward. We did all the workup we usually do, transthoracic echocardiography. He had a 20% left ventricular ejection fraction, a left ventricular diastolic diameter of 62. It was dilated. As you can see in the upper right, this ventricle was at a very bad left ventricular function with severe MR, moderate TR, and severe pulmonary hypertension. On coronary angiography, there was some disease, but no real target lesions to be treated. And in the bottom, you can see the right heart catheterization with the mean PA of 26, a wedge of 16 with a V wave up to 30, and the transpulmonary gradient of 10. So next, we did a transesophageal echocardiography. As you can see, the MR was functional or secondary mitral regurgitation. It was graded as severe. There was, as you can see, this tethering of both leaflets leading to this central jet, A2P2. The mitral valve area was 3.6 with also some mitral annular calcification. So at this point, we went into our team, as we always do, we had to decide what to offer this patient. He was, again, an 85-year-old male. Medical therapy, we already said, was not enough to treat this patient. He was not deemed like the best surgical candidate, so we decided to move forward with edge-to-edge repair. If we look at the predictors we saw before, we can say that in this patient we had 4 out of them. So let's see which was the result. So this procedure was done with just one device, the MitraClip device, because at that time the MitraClip was the only commercial available device, and also even today for secondary MR. The target lesion was A2P2, as you can see in this beautiful MPR. The MitraClip is right above, below the A2P2 segment. And this was the result after grasping both leaflets. As you can see, the MR was reduced to mild. There was a really mild residual jet on the medial side of the MitraClip. And there was also a very good tissue bridge that we defined by all this tissue of leaflet going across the MitraClip device. So the result after the procedure was great, but of course we care about seeing if this result is maintained even after a follow-up. And this was the 3-month follow-up, which was demonstrating an amazing result, not only in terms of reduction for the mitral regurgitation, that was mild to moderate compared to severe at baseline, but also the left ventricular ejection fraction improved from 20% to 45%. And that was what we call left ventricular reverse remodeling, a reduction also in the diameters and the dimensions of this ventricle. So in the last clinical follow-up, the patient was not in stage D anymore, stage C, NYHA class 3 with significant volume overload improvement, and he had no heart failure hospitalizations in the year after MitraClip. Thank you.
Thank you, Andrea. This is a great case. Let's go. I think we can discuss at the end of the second case, just in the interest of time. I think this was a beautiful case, pretty straightforward, reverse IV remodeling after the mitral lesion was fixed, and the patient was prepared for the procedure, most importantly. Azim, you did the case. Do you have any comments?
As is opening the next slide, so maybe use this one. Just maybe make a brief comment, right, about coap versus non-coap. So if you choose a patient, you treat a patient who has the typical coap criteria, then we know they more than likely will get a decrease in hospitalization, an improvement in symptoms, but also you'll prolong their life. And that's what COIP showed us, is that you can actually prolong the life of somebody with secondary MR in addition to GDMT if you choose the appropriate patients. This patient wasn't a COIP criteria. So when we have the discussion with a patient like this, we're very clear, we're not doing the procedure to make them live longer. We're doing the procedure to make them feel better and to improve their quality of life. And I think as long as you're clear with the patient about what the goals of therapy are and putting a device into them, you can get good outcomes. And patients have realistic, not just patients, but also referring cardiologists have realistic expectations.
That's a great point. In this case, we'll have more discussion. So go for it.
Okay, so let's see the second case. This is a case of severe MR in the setting of severe left ventricular dysfunction. Again, another case followed by our heart failure program. It's a very young female, 20-year-old, with a very high BMI that I would like to highlight in this case, BMI of 48. Her previous cardiac history, we have to mention this dilated cardiomyopathy with a pathogenic titin mutation with an ejection fraction around 18%, a previous implantation of ICD because of a long QT syndrome, and paroxysmal AFib on Eliquis. As you can see on the right, medications were optimal. There were ARNI, beta blocker, SGLT2 inhibitor, spironolactone, and she presented because of worsening shortness of breath. She was not able to walk for 5 minutes or more. She was very fatigued, very severe weakness. So she again presented to our heart failure unit, who started all the workup to evaluate for heart transplantation. This was the transthoracic echocardiography. As you can see here in the upper right, the function was very low, was measured at 19%. It dilated also left ventricle, as you can see on the volume, based on the volume and diameters. Severe MR with a pulmonary systolic pressure of 60, with mild right ventricular dilation and moderate dysfunction. Several right heart catheterizations have been performed for this patient. This was the last one we had with a PA pressure mean of 38, a wedge of 27 with a V wave up to 37, and a cardiac index of 1.6. So again, just to evaluate what we could do for this mitral regurgitation, we did the transesophageal echocardiography. The mitral regurgitation was graded as severe. As you can see here, there is just a tiny jet on the medial side of A2P2, but the big jet was on the lateral A2P2 side. It was very eccentric. As you can see, it was going towards the posterior wall of the left atrium, with this tethering particularly pronounced on the posterior leaflet. So again, in this case, what could have we done? Heart transplantation. This was not the best option based on the very high BMI, LVAD, or edge-to-edge repair. We all know the answer.
Andrea, let's pause for a second here, because this is now a good discussion point, I think. So we have Dr. Gonzalez here from Spain. I'm curious. So 20-year-old, BMI is 48. You have a transplant program. EF is 19% outside of coapt, and the MR is severe, ventricle is big. What would you do? What would your interventional cardiologist say?
She has a mutation in Titan.
And she has a Titan mutation, which we, to be honest, only find out later.
Right.
We know it now.
So that helps remodeling, especially if you give heart failure medication. So I would, depending on the situation of the patient, I might wait and see how she does with heart failure medication.
She's fully medicated.
She's fully medicated. How long?
6 months.
6 months. Okay. Then I would probably go for mitral valve transcatheter edge-to-edge repair, because obviously LVAD with the obesity is also complicated. And as a first approach, you can always do LVAD if mitral repair fails. And it's much easier, it's safe in most cases. So I would go for that first.
Okay, just to go through the motions before Azim, Steve, cardiac surgeon, non-ischemic cardiomyopathy here. Yes, 20%, 20 years old.
Yeah. So I'm thinking of, in a 20-year-old, sort of the 10, 20-year plan on her. And I know from our experience that the only way she's going to have a long-term success is really with heart transplant, which she's not a candidate for. And so I'm thinking, what options do we have to get her to lose the weight, which includes bariatric surgery and possible LVAD, which we've definitely approached in patients like this.
Try the clip first, or waste of time? What about mitral valve repair surgery?
So I think a surgical mitral valve repair is going to have her come out with a temporary device, and then we'll be putting the LVAD in probably 2 to 3 weeks after the valve repair. So surgical valve repair, I would say, is out. And so I think we're just kicking the can a little bit with the edge-to-edge, with the transcatheter approach. But when I'm thinking of the 20-year plan, I think I would say LVAD and bariatric surgery.
Okay, clip and weight loss. That was. And now Azim, we kick the can to him actually and say, what are you going to do about this? Can you do this? Is this too high risk?
Yeah, I mean, you can do everything. I mean, I can put a stent into anybody, I can put a TAV into anybody, I can put an edge-to-edge device into anybody. The question is, what happens to them afterwards, and will they improve, or will I make it worse? And one of the concerns when I treat a patient like this is, what's the risk of afterload mismatch? Because if I take away too much mitral regurgitation, some of these patients end up needing support devices afterwards, and they may still go that route, right, where they're going to need some sort of exit strategy. The other thing is, there are risks just to what you said of doing the mitral clip, because if we put too many clips in and we cause mitral stenosis, that does make it more challenging than for an LVAD. You probably then have to replace the mitral valve at the same time, because doing an LVAD in somebody with mitral stenosis is not a good idea, I guess. So we'll, in a younger patient, knowing that there's an exit strategy and that, we work together with heart failure and with the surgeons, that we know we can offer her something if she has severe acute afterload mismatch, we would try and clip her, not trying to get a perfect result, but getting a good reduction in MR.
Yeah, this is great. I know not getting a perfect result is not a bad idea here sometimes. So then we discussed this in real time, and I asked Azim, and then Edwin is usually in the room for the procedure. Can you just put the clip there, hold it, and see if she has after all mismatch? So what did you say? What do you say to that? This guy doesn't ever do anything in his talk, so
Yeah, so I mean, I guess
is that a possibility?
well, I mean, one of the advantages, of course, with these transcatheter therapies is we are doing it, of course, on a beating heart. We have sort of live physiology. It may be a little bit too sort of acute and early to tell. I mean, can we get some hints? Maybe. I don't think we can say, you know, with certainty that we can predict it, but certainly we can see sort of the live response in physiology whenever we're altering the mitral valve hemodynamics.
Okay, great.
There was
Question?
There was another comment, but I also think we should get a comment from Danny, who's looking a little bit shocked at us, like we're nuts to even consider this, Danny.
Danny wants to operate this patient. He's like, give me the Wolfer now.
Nothing shocks me coming out of you, Azim. No, I think that the concept that's evolving, and I'll touch upon it in my talk tomorrow, is the concept in young people of net prolongation of life, right? And this 20-year-old patient, how are we going to give him the most years we can? And you obviously don't start with heart transplant, even though that's the tendency in most programs. So you start with the least invasive thing here, the TER, which makes sense, and see how she does. Am I able to optimize your GDMT once you have flow going the right way, which is a question to you, Andrea, for the first case. I'm very surprised you went from EF of 25 to 40 without an up titration of medication, like I guess you did, or allowed to. So, and then go to LVAD, plus minus bariatric surgery along the way, and leave transplant sort of the last course. Understanding the LVAD median survival now has improved tremendously with HARMONY-3. So that's the concept, the whole idea of net prolongation of life in young patients.
Yeah, you can use this.
I'll just add maybe a third option, because whenever I hear Titan mutation in a young person, I'm thinking about recovery as an option. And what, you know, with the newer temporary device that you could keep in for 8 to 12 weeks, I wonder, you know, one thing you could consider is putting an Impella 5.5 in and see what happens over 4 to 6 weeks with her function, and see if she becomes a better candidate for edge-to-edge repair.
Okay, so what happened? Also, Danny Goldstein made a very important point. He always makes points about medical therapy. I think it's intentional. That the concept also to put a clip to facilitate medical therapy. It's a very important concept. Put the clip, the blood is a little bit better, and now we can move and help reverse remodel the ventricle. Do you want to quickly wrap it up, what we did?
Yes. First of all, just to reply to Dr. Goldstein, in the first case, also medical therapy was improved after the mitral. This was also why there was such a big improvement in the left ventricular reverse remodeling. In this case, we followed all this discussion. Actually, we made the same exactly discussion in our team, and we decided to, as you mentioned before, to proceed with the mitral valve transcatheter edge-to-edge repair, which could have been a strategy as a bridge to something else, given the young age of the patient. So we knew there were other options. And in this case, given the very large anatomy, we opted for a 2-device procedure. As you can see, the first one on the left side was placed in A2P2, and then we placed a second device right lateral to this one. Both leaflets were grasped, as you can see in both MPR, and this was briefly the final result with these tiny jets next to these MitraClip devices. As you can see, both devices in the 3D on the upper right at a very good tissue bridge with the trace residual TR here. I'll show you again the follow-up. At 1 month, as you can see, there was an improvement with a reduction of MR from severe to mild. And also, even in this case, we didn't experience any afterload mismatch. Actually, there was an improvement in the left ventricular ejection fraction that you can see here, even if it's just a 4-chamber view, from 19% to 35%. And also, she was able to do on the pulmonary exercise test, she had a VO2 of 14 with an NYH class of 2. This was already at 1 month. And she started also losing weight, 10 pounds less in this follow-up visit. Thank you.
Perfect. Great. So we can change over to the next talk. This was great. Any questions while we change? First of all, Andrea, fantastic. Also, the slides are beautiful. We used his template for all the presentations, so thank you so much. Sasha and then Snehal. Let me give you the mic.
Oh, yeah, sorry. So great presentations, Andrea. So question to you guys is that these are, as you pointed out, Azim, the mitral clip is a therapy not for, to salvage somebody from a disaster in the short term, but long-term benefit. And we do right heart cath in all these patients, but I'm not really sure how we use this data. What if we used it in the sicker patients, meaning the more dilated LVs, the lower EFs, and say, okay, they got preserved hemodynamics, because hemodynamics can look like anything when you look at EFs less than 20%, to say maybe these patients actually still could get a benefit.
Yeah, I think that's a good point. I think we still don't understand how to distinguish, the super responder from the patient who gets just a little bit of quality of life benefit. We've looked at so many different things, anti-stolic dimensions, dobutamine echo, looking at reserve, looking at biochemical markers, and we still don't know. I think using right heart cath is probably more important. Certainly, most of the data came from Europe, where you'd be surprised. I mean, before I came to Montefiore, I did very few right heart caths because in Europe, we don't use it as much in the interventional community. Probably in heart failure, maybe, but just in general, it's not used. When I talk to colleagues even and say, before putting in an impeller device, do the right heart cath, it's not something I did. I have to be very honest, 5 years ago when I worked in Milano, but I do it now. So I think there's an opportunity to study this better and work together to use the hemodynamics to maybe try and figure out who are the super responders.
Yeah, and in her, actually, she, in the initial right heart cath, she had a wedge over 30, was very sick, got a better, and we really optimized her. Because we were both ambivalent about whether this should be done. Great. How's the talk coming up? Oh, Steve.
Quickly, Sasha.
I was just really wanting to say similar thing what Dr. Patel took to front. But for first case, I think the significance of hemodynamical analysis is extremely important, because he's labeled as stage D, severe pulmonary hypertension. And when you do the right heart cath, you take away echo images. That's not true anyway. I think the right heart cath for that previous case will say that he would kind of fit in co-opt criteria, because we know the survival really depends on the filling pressures, not on echo.
There was no right, you didn't have to do a right heart cath for co-opt.
Yeah.
Right, it's interesting. So I think we've underused hemodynamics. I really do.
Yeah, so you may want to answer after this, but I believe both those patients had at least a moderate, maybe moderate severe right-sided disease or valvular disease. So I'm curious how, with your armamentarium, how you treat these patients now with multiple valvular disease. So maybe we'll approach that after this.
We'll let Edward answer the question at the end of his talk.
Try. So that's a good segue, actually. So we'll change gears a little bit. So we'll move to the right side of the heart. Dr. Yorde is going to talk a little bit about Triluminate and some of the results related to that. So really this first sort of 6 minutes or so is a little bit of a primer, just to kind of get us all ready to think about the tricuspid, and then just sort of see, how we're evaluating and how we think about etiology, mechanism, physiology, and why there may or may not be benefits. So just to start, these are my disclosures. And then so the learning objectives for today. So really what we're looking at is to think about sort of what the anatomy of the tricuspid valve really looks like. We're learning so much more about this valve all the time, and there's really a lot of variability and complexity. So it's not as simple as just saying, oh, there's a valve here and it's leaking. And then we'll just look at some of the standardized views and why we use them in terms of thinking about etiology and physiology. And then that will hopefully lead us into a nice conversation about edge-to-edge repair with Triluminate. And so just a quick sort of background. So why the imaging matters. So just like with other valves, of course, observational studies definitely tell us that the worse your TR is, the worse your prognosis. And that's in both isolated TR and when combined with other valvular, other heart disease. And then even though, surgery, we know tends to be underutilized for this valve lesion because of some of the risks associated, there are a lot of investigational devices that are becoming, hopefully available soon, but really in clinical trials right now. And so we always try to think about these patients about, are they going to benefit? What kind of device they're going to benefit in? And so that's where the imaging really counts. And then, different centers and organizations will have different ways of looking at it. We have our sort of internal algorithm a little bit, but really at the end of the day, it involves mostly echocardiography and then sometimes some additional advanced imaging. And we look at some key anatomic factors, especially when it comes to edge-to-edge repair, like in the Triluminate trial. So we'll start with just thinking about the anatomic evaluation before we go into mechanism and physiology. So I always like to start with this first because, we're all sort of taught in medical school, this is a tricuspid valve, 3-leaflet. It kind of always looks like this, big anterior leaflet. And what we know more and more, the more we look at this valve, especially maybe in higher prevalence in those that actually leak, is that these valves are extremely complex. So we actually tend to see valves with more than 3 leaflets. Probably the most commonly seen morphology I've noticed in ones I've screened are the 4-leaflet valves, but sometimes you'll have 5, 6 leaflets, rarely sort of 2 leaflets. And this can be really important, especially for things like edge-to-edge repair, because now the geometry of the valve is very complicated. So if you're trying to just pinch it together, unlike the mitral with 2 leaflets, now you're trying to really pull leaflets in the right direction. And so we always want to have a better and detailed look at the valve in all these imaging modalities. So first we'll start sort of at the basics with transthoracic echo. All of our patients get these all the time, of course. So advantages, readily available, non-invasive. We can actually see the tricuspid valve really well. It's probably an underappreciated modality just because it's such an anterior structure. So I'll quickly just go through common views that we all know, again, just as a little bit of a primer. So we always think about these parasternal views. So the long axis would usually cut between anterior septal, anterior posterior leaflets. We already get an idea about mechanism, tethering. Is there a huge gap between the leaflets? And then when we go into the short axis, it really tells us about location of the jet. Usually tricuspid regurgitation is secondary or functional, and usually that happens in the middle of the valve. But we do see that there can be jets that sort of bias one way or another. And that's why, again, these views can help us in really significantly. When we move to the apical views, we usually, again, just kind of ignore and just say, okay, there's a tricuspid valve here. But we can get some sense of where we are in the valve and what leaflets we're seeing by just looking at some of the other landmarks around that. And then again, what we're trying to get a sense of is from one end to the other of the valve, how tethered are the leaflets, how far apart are they, and what's sort of going on in the context. I'll move into sort of a little bit of the right-sided evaluation at the very end of the talk. And then again, underappreciated, but TT is a great a modality actually used for 3D imaging because of the anterior position of the valve. And then here, as I mentioned, the morphology can be complex. You can usually see that actually very, very clearly. And then we'll just move on very quickly to transesophageal echo before we move into mechanism and physiology. So we often will screen these valves with TEE. Of course, you get rid of any acoustic shadowing from the chest wall. So you often can get very good pictures, but it can also be very challenging in its own right. And essentially, we end up using 3 key windows, so esophageal and shallow transgastric views. And then I'll show you examples of what those look like. So the shallow transgastric on the TEE is probably the most important view for us. Again, just because morphology counts so much, this is where we see all the leaflets at once, and we can understand where the jet is and how big those gaps are. When we think about edge-to-edge repair, we always want to make sure those gaps are not too large and that it really looks like there is leaflet to actually approximate where we see a significant jet. From there, we then also want to, of course, look at the leaflets themselves. These are views that we'll also use during the procedure. I haven't included examples of that because it's a very sort of niche area. But what you'll recognize here is this basically the parasternal short axis, but flipped upside down because we're looking at it from the back of the heart. And again, this tells us about the location of the actual jet itself. And then what we usually do when we're screening these valves is then we biplane this. And the reason we do that is because then again, we understand all the way from anterior to posterior what's actually happening. Gaps, tethering, do we see sort of really big problems when it comes to edge. And these all become very important because it gives us some idea of how much reduction we can expect to actually get and whether or not we'll then see clinical benefits. We also do lots of 3D analysis on the TEE that gives us a lot of, again, the same information just as a confirmatory source. So thinking a little bit about etiology and physiology. So we try to divide TR into different mechanisms. The vast majority of cases are these secondary or functional. And then it's very important from a physiology point of view, whether that's that atrial subtype or ventricular subtype. And I'll show you why. We also have CIED related, which are ones where we have pacemaker ICD leads, which is very common. And then primary, where there's leaflet abnormalities, is much less common. So this is just a quick example of what we call an atrial secondary or functional TR. This is when usually the main mechanism is annular dilation, right atrial dilation. People used to call this isolated TR. And we usually see that the right atrium is more dilated than the RV. With that said, over time, the RV will dilate as well. And the leaflets will close at or near the annular plane. The reason we care about this a lot is because a lot of these patients may not have significant pulmonary hypertension or even left-sided valve disease. And a lot of their symptoms really can be driven by the TR, and they may have really quite a dramatic benefit. So we often do like to see these patients and see, is there something we can do to help? On the TE, again, we see the same morphologic characteristics that help us confirm that etiology. On the other hand, we have a subset of patients where they have this ventricular secondary or functional TR. And in these situations, these patients often have significant left-sided heart disease or pulmonary hypertension, severe RV dysfunction, things that often will cause dilation of that RV free wall and causes very severe apical tethering. So the morphology on echocardiography looks very, very different. And we see the leaflet tips tend to be quite far away from that annular plane. And a lot of times the gaps can be very, very large. On the T, again, we see the same characteristics. And these patients usually need a much more detailed evaluation. We work very closely with our heart failure colleagues, like Dr. Murthy in the audience here. And of course, really try to decide, is this a valve problem? Is it more of, an actual cardiac problem? And are we going to help this patient? Primary TR, again, much less common, but we do see leaflet abnormalities, sometimes because of biopsy, trauma. In this case, here we see some leaflet prolapse. And then we can even see situations like here with endocarditis where we're really missing a piece of leaflet. And then the reason these become very important for us is, again, eligibility. For edge-to-edge repair, it may not work if, of course, you're missing half of your leaflet. Very quickly, I do want to mention CIED-related TR. We're seeing this more and more now, especially relevant in the heart failure patients who often will have cardiac devices. And there can be different morphology of this as well. Sometimes you'll see leaflets impinged or pressed to the side. Other times they're actually adhered, like in this situation. And that can be very difficult to repair, especially when we're thinking about edge-to-edge devices. We use a slew of different imaging modalities, TT, TE, a lot of these 3D views to try to understand the position of the leads and how they're actually related to the leaflets themselves. Like in this case, you see it's really pushing down that septal leaflet against the septal free wall there. And then we can, of course, do some reconstructions as well to further understand exactly how involved this valve is with the lead and whether it's eligible for repair. A quick plug for some of our multimodality, other modalities for imaging. So in this case, with the lead, we can also look at it in great detail with CT scans. And we think more and more this is a particularly relevant modality when we have leads that are in place. At the very end of the talk, I do want to just quickly talk about severity because, of course, this plays into physiology and mechanism. This is not meant to be exhaustive. It's not a full echo talk, but of course, we have a lot of different parameters to try to judge how severe a jet may be. We use qualitative, semi-quantitative, and quantitative parameters. And as you can see, a lot of them are actually borrowed from the mitral side. On the right side specifically, there's still limited data in terms of how we really define it. What we do know is now we've expanded our grading for severe. So we subdivide severe into severe, massive, and torrential. Some people argue this is a little bit academic, but we do know that it actually helps prognosticate patients. And sometimes it helps us evaluate what the change may be within a procedure. It may go to torrential to severe, which still looks bad visually, but the patients may still actually benefit. And then the very last points I wanted to make have to do with RV systolic function, because just like the mitral, we always want to think about the context of the valve disease. So most commonly, of course, we think about TAPSE, RVS prime. Those are the very common echocardiographic parameters. Just a reminder, those are longitudinal function and regional parameters. So they don't always give us the full grasp of what's going on with the ventricle. We try to do strain analysis on all of these patients. It's still a regional longitudinal parameter, but gives us more idea of what's happening with the free wall, especially in pulmonary hypertension patients. And then really global evaluation of RV function, I think is where we need to be heading sort of in the future. And that may tie into patients that have significant benefit from therapies and treatment as well, because what we know is visually we'll often see that the RVEF looks like it drops. So this again is sort of like what we talked about the mitral afterload mismatch, but we see forward flow actually improve. And a lot of times some of those low output symptoms likely improve as a result of that. So key messages, I know that was a really quick whirlwind, but just to sort of set things up for Dr. Yorde, hopefully tricuspid valve anatomy varies really significantly. We have lots of different mechanisms. Usually it's secondary or functional, but important two subtypes, which is the atrial and the ventricular. And then the RV function evaluation remains very difficult, but I think might unlock some of the sort of keys in the future with who gets clinical benefit and who does not. Thank you.
So Uli, maybe let's go on with your talk, and then we can maybe just tackle tricuspid together, the imaging, the physiology, and the management.
Okay.
Yeah?
We can get some time.
Okay. While we bring up the presentation, are there any questions on, I think, obviously Edwin gives a very detailed description of what's involved in really evaluating the tricuspid valve. I have to tell you, when I started getting involved in this probably about 7 years ago, we knew nothing again, because there was no dedicated imaging views on the tricuspid, and we really didn't understand the prognostic significance. So maybe while that's coming up, any comments on Steve's question? Patients who present to us with mitral disease, but also have concomitant tricuspid disease, maybe what's our approach?
Sure. So maybe I'll comment at least from our valve clinic and our point of view. So we know that because a lot of the patients with significant TR, it's secondary or functional. Some of that is often coming from the left-sided valve disease. So, we do expect that there could be some change after you treat the left-sided valve disease. So usually, our approach, I guess the advantage of transcatheter is you don't have to do everything all at once for the most part. And so we do have the opportunity to treat the left-sided valve, see what happens. In a lot of cases, because they're sort of later stage patients with severe angiodilation, they don't really remodel that well. So oftentimes it remains severe, but sometimes it may at least improve a little bit and maybe makes, for example, gaps smaller and a little bit easier to treat from our end.
Great. That was just terrific, Edwin. So I'm going to talk about the triluminate study a little bit because Emma, I have to say, 10 years ago, I could have cared less. I never knew anything about it because there's nothing we could do. Then slowly, of course, the clips came around, and now we have COAPT, we have talk about survival benefit. I never thought much about TR because if it's there, it's there. If it's not there, great. But what are you going to do about it? So now we can do something about it, and we're beginning to answer the question, should we, right? So I entitled my talk, Triluminate Study. It's the first randomized trial, tricuspid valve H2H repair catheter-based versus control in about 300 patients. And I'm going to share the results with you, and then you can decide whether this is enough or should be enough for the FDA, I should say at this time, to say this is an approved therapy, you can sell it, and we will pay for it. No. Wait. Yeah, that was one. That one, yeah. Great. Excellent. I'm going to try to match Edwin's amazing sophistication in his talk. Probably won't, but he speaks usually at international meetings only. So thank you for joining us today on your home turf. Very good. Yeah, sit down. I'm just going to a couple of minutes and then we can all sit. Very good. So the Triluminate study, I'm going to be brief on this. Randomized clinical trial was just published in the New England Journal about just 300 patients, and half got tricuspid recurrent, half didn't. And the main result you can see here, it works. The tricuspid regurgitation goes away in 95% of patients with this clip. So that's great. Then the trial had a hierarchical endpoint. Let's first look at death in the two groups. If death is the same, let's look at heart failure hospitalization. If heart failure hospitalization is the same, all the heart failure specialists are going to go back to sleep. But then there is another endpoint of quality of life, KCCQ score, and I'm going to explain that to you a little bit because that's exactly what happened. This trial was positive, meaning the group that got the clip did better, but they didn't live longer and they weren't hospitalized less, but they had a higher change in KCCQ score. This is why this trial is positive. And you can look at any subgroup, age, sex, severity of regurgitation, kidney disease, yes, no. CLIP was always better for improving quality of life in all patients. And when you look at subgroups, you can see that patients with TR, I never know how to pronounce that, were more likely than the control to improve the KCQ over 15 points. And if you asked me about that 4 weeks ago, I wouldn't really know what that means, but I'm going to explain it to you now because I had to give a talk elsewhere. So 50% in the TIR group versus 26% in the control group improved their KCQ score. It was better across all subgroups. For patients who had a prior heart failure hospitalizations, for all comers, it was 50% who got over 15. If you had a prior heart failure hospitalization, 63% got better, indicating that sicker patients were more likely to improve with the intervention. Similarly, when you looked at New York Heart Association class 3 or 4, if you had that, you were more likely to improve your KCQ score. And similarly, if the pre-study KCQ score was less than 50, which is bad, you were more likely to improve. So kind of the sicker, the better, if you look for an improvement. The one fact that leads me to believe that in the end, this may work out, although it may be premature for a paradigm shift, is that the more tricuspid regurgitation was reduced, the more did the KCCQ score change. So this is something that is very important. The patient probably didn't really know how much they improved. An objective lab looked at it, but the ones where it was more reduced had higher improvements. So the KCCQ score, what does it measure, right? It is a multi-domain score. It looks at symptom frequency, symptom stability, symptom burden, physical limitations, social limitations, quality of life, and self-efficacy, which is the term how well the patient understands their own therapy. So the KCCQ measures symptoms, physical and social limitations, quality of life. And in clinical trials, what panned out was more important is the change or how many patients changed a certain amount in KCCQ rather than what happened to the mean. And here you can see what changes might mean or the clinical significance. It is generally accepted, and this is why the FDA allows this as an endpoint in heart failure trials. Generally accepted that a change of more than 5 is small, but it's clinically important. A change of 10 in KCCQ is bigger, moderate change, and definitely clinically important. Change of 15 is quite large. Okay, so the question now is, I'm going to skip this in the interest of time, what we see with drugs. But let's go back to the trial. Here, I showed you this again. The improvement in KCCQ of over 15, which is a very large change, occurred in 50% of the patients who got TR and in 26% of the rest of the group. And it was more common than in patients who did not get the clip. So when you just look at that, that is a really big change that occurs in a lot of patients. The problem with that is that these patients had a procedure done to themselves and they knew about it. So you can call that, it's not a placebo effect, but it's a different effect where you come out, you do something, and I just feel great ever since you put that clip into me. There was no sham control. You're going to hear about some other trials later where there is a sham control, where the patient is sedated, you put them under, they wake up, and did you get it or not? Well, we can't tell you, we tell you in a year. And then nobody knows. So this is a definite limitation. So when we look at Triluminate, it's a great study. It's a rigorously conducted study, but I think that it falls a little bit short of me saying I'm going to send everybody for a tricuspid clip. So what is it that I want to see. Other thing that has been shown with tricuspid valve interventions is that because you lower renal vein pressure when you take the TR away, kidney function tends to improve. There are multiple registries that show that renal and liver functions improve when you clip the tricuspid valve. This is a study, I think, from Germany, where they showed that GFR improved or at least was stabilized. Now, why is that? You just learned that from Carles Diaz, that if you improve the CVP, if you improve renal vein pressure, you may unload the kidney and you may stabilize this, cardiorenal syndrome that occurs over time. So what we want to see, I think, in the heart failure community, this is just a paper we published from here, where we showed the importance of CVP for renal and liver function and gastrointestinal function in TIA. What we want to see, what we saw is that the KCCQ scores improved significantly and clinically meaningful in Triluminate. Of course, there is no sham control. We are now working on data from the same trial. It's a randomized trial. It's 1 year. It's relatively healthy patients. And we will see what happened to the GFR in the device group and what happened in the control group. And if the registry data from before are right, then the control group will continue to see their renal function deteriorate, whereas the clip group, hopefully, will either stabilize or get better. And I think that'd be my opinion, what I think we're waiting for. And I think this is something that also the regulatory authorities would ask for. So I'm just going to end there. Any comments from the panel or from those who placed the clip? We can discuss it now, or questions from the audience. And then we can switch over to Dr. Vukulic's talk.
Can we get the microphone to Snell and to...
I can ask maybe the same question about the tricuspid as the mitral, about were the hemodynamics done before Triluminate? I wonder if...
Yes, very good question, actually. The hemodynamics were done. And I can tell you, it's published in the paper, that the mean right atrial pressure, mean CVP of interest in the study was 11, right? And this is an interesting thing, because we did see patients that we cleared that had a CVP of 5 for a tricuspid clip, which seems counterintuitive to us. We actually looked at that. We were looking at it, kind of not public, but it didn't seem to make a difference on the effect of the valve. So I mentioned earlier, exercise right heart cath. We need to do exercise right heart cath in patients with tricuspid regurgitation also, to see whether patients who have a low CVP, when they just lie on the table and they say, I'm sick and I have this tricuspid regurgitation and they're elevated BNP, what happens to them during exercise? And is that something that we can influence with the valve? Of course, all of this is speculation.
So, I mean, we should also mention that we didn't check right atrial pressures after the clip was done, right? So we only have baseline hemodynamics, no post hemodynamics. And maybe just 2 other comments to mention about the data. One, don't forget that this was done during COVID. And every single study that's looked at heart failure hospitalization during COVID has been negative, because patients, even in the treatment group, did not want to go to hospital. So that puts a little bit of a bias into it. The second is that if you look at, I think, and you saw it on his subgroup analysis, almost half the patients were NYHA 1 or 2. So I kind of wonder, in someone who's got TR with NYHA 1, how much we're trying to benefit that patient, and will we ever show truly heart failure, hospitalization, reduction, or mortality benefit? I don't think so. And then maybe the third point just to think about is that when you looked at the mortality benefit in COAP, you only started seeing the curves separated at 1 year. It takes at least, probably a good heart failure study needs to be at least minimum 2 years or longer for the primary endpoint. The other heart failure studies will be. So maybe will we see a difference if we follow up these patients longer? Unfortunately, we'll never know from Triluminate, because sadly, whoever designed the study allowed crossover at 12 months. So everybody's crossing over now into the treatment group because patients want to feel better.
Yeah, great point. Longer term data are coming. Danny, are you finished? Danny has a question, and then Joe, or the other way around, doesn't matter. Actually, anybody who asks more than 25 questions today will get a personal microphone next time.
So you started the talk asking whether the FDA should approve it or not. And if I was in the FDA, I would say no. why there was really negative hard endpoints, right? This is subjective KCCQ where there was no sham, there's no blinding. So the echocardiogram, there's the vicissitudes of reading a clip in a tricuspid valve. And frankly, the fact there's no change in hospitalizations is perplexing, right? If you get rid of the TR. So I think there's a lot of uncertainty there. And there's the Hawthorne effect that you talked about feeling better because you had something done. So my vote would be no. We need more data.
Yeah, I would be on the same page, but the FDA has accepted this scheme, of course, with the KCQ of 15, which the FDA accepts, and which is good for other things. So from their perspective, it's a positive trial. Usually they ask for 2. Great point, though. Joe?
Yeah, it's a question of how you see this cup half empty, cup half full. When I first saw the data, Danny, I also kind of had this cup half empty. I was hoping there was going to be heart failure hospitalization reduction, and there wasn't. The cup half full part is, we have this patient, we have a number of patients. There's a patient who was the father of one of our colleagues, who's not in the room right now, who we clipped. Okay, and he came to see us at 1 month, but we got rid of all of his TR. One of the issues here is that half the patients still had moderate to severe TR. Okay, so we didn't get rid of all the TR. And we got rid of all of his TR. And the guy keeps coming back and says, "You've changed my life forever. And I've started living again." He's never been hospitalized. Okay, I'm not sure we're ever going to show a change in his mortality. But the difference in quality of life is so huge for him that it's dramatic.
I got it. Immortality is not going to be, that was not going to be some different hospitalization. It's facts, anecdotes. Go have anecdotes. Plural of anecdotes is not data.
I agree. But again, let's remember that there's no guideline indication for surgery in these patients, right? For isolated tricuspid valve surgery, there's no guideline indication. This is the first randomized study in patients with TR. There's never been a randomized study, not in surgery, not in medical therapy, not in anything. So I think we've got a lot to learn.
Yeah, that's a good point. Brings us to the next. Oh, wait. No, John,
just very fast one.
Yeah.
Did you look, because
no anecdotes though, please.
No. In patients with right heart failure, NT-proBNP is not really a good marker of congestion. Did you look at other markers such as CA125 in these patients?
No, not in Triluminate. Yeah. Those are, the point is here, the phenotype definition for enrollment in Triluminate, I think in the future we will look at this differently, but it is a landmark trial.
Just one question. Yeah.
Yep.
How did you evaluate the RV function? Is there a cutoff for RV function prior, like coact?
So no one really knows how to grade RV dysfunction in the setting, especially of severe TR. So actually all the trials struggle with it. They say they'll exclude severe RV dysfunction, but it's a bit subjective depending on the core lab.
Okay, Dr. Vukovic.
Hi. So we're going in similar new approaches to therapy of heart failure. So the problem with heart failure is that the treatment still becomes challenge or stays challenge despite advancements in the pharmacological and device-based therapies, especially for heart failure, preserve ejection fraction. So main mechanism how you develop symptoms in a heart failure, especially left-sided right heart failure, not right heart failure like in Triluminate, is really dyspnea, which is driven by the elevation in the left atrial pressure, which is a consequence of elevation of LVEDP, which leads to elevation of pulmonary capillary wedge pressure and gives you that symptom, which is limiting significantly your quality of life. So intra-atrial shunt devices represent a new class of devices for treatment of heart failure with unique mechanism which directly address hemodynamic problem, which is causing dyspnea, which is elevated left atrial pressure, which can potentially, by decreasing pulmonary capillary wedge, improve exercise tolerance, symptoms, and clinical outcomes. So you see there is a slew of new devices because there is definitely need unmet, but I'm going to focus on atrial shunts anyway. So what's really the mechanism? How left atrial pressure induce symptoms of heart failure? So elevated left-sided filling pressures induce, including left atrial pressure, are known to correlate with poor outcomes. The poor outcomes are really not correlating as much with the low ejection fraction as much they're correlating with the elevated filling pressure or how filling pressures are elevated. So let's not trick you, like when you have ejection fraction of 10% versus 20%, there is really no difference. The filling pressures are making the difference how you're gonna do the hemodynamics specifically anyway. And that was also demonstrated in Champion trial, which Rita addressed, which when we have the way that we manage patients to hemodynamic target, which in Champion trial was pulmonary and a pulmonary arterial and diastolic pressure, which is really a surrogate of LAP because LAP is transmitted to the diastolic pulmonary arterial pressure. And that led to decreased number of heart failure hospitalizations and improve outcomes. And what is most important is that outcomes were both improved in HFrEF, for what we have some therapies, but also in HFpEF for what we do not have therapies anyway. And as I said, it's really important to address unmet need in heart failure with moderately reduced ejection fraction, with LVF between 40 to 50 and HFpEF when it's more than 50, where we really come to the only therapy which is really evidence-based in this moment is SGLT2 inhibitors and partially the Entresto. So you can see really, this is the mechanism that in HFpEF, decreased relaxation and compliance lead to elevated left ventricular filling pressures, which leads to elevated left atrial pressure. However, we need to add there left atrial disease by self, which will increase the problems, and that leads to elevated pulmonary capillary wedge pressure, congestion, and signs and symptoms of heart failure. So our only way to fix it is either to improve relaxation and compliance, which we don't really have the greatest therapy, but we can partially help it with decreasing preload with diuretics or SGLT2 inhibitors. But other way is to cut the corner and just decrease the left atrial pressure, which will lead to decrease in pulmonary capillary wedge pressure, pulmonary congestion, and then improve on symptoms and quality of life. And where is this rationale coming for, or this idea? This idea of selective left atrial decompression as therapeutic strategy for heart failure, it's really coming from different type of other patients. And my favorite is Luttenbacher syndrome. And I was very happy when I realized that I know what Luttenbacher syndrome is from the med school and from the taking of boards. But Luttenbacher syndrome is unique situation when we have a patient who has atrial septal defect and then developed later through the life rheumatic mitral stenosis. And what was always confusing is that people with rheumatic mitral stenosis who at the same time have existing ASD have less symptoms or develop symptoms much later than patients who do not have it. So that was one of idea. Another idea was palliative treatment of refractory heart failure with the percutaneous balloon septostopy. What we do on patients on VA ECMO who are not offloading, so we can create a shunt anyway. And that really is kind of ideas which are coming. On the other hand, we have opposite situation when closure of atrial septal defect in patients with unrecognized LV dysfunction because of overflowing LV can develop severe elevation with left atrial pressure and pulmonary edema. What is more important, the hemodynamic rationale for left atrial decompression with AS. And this is really where we can, again, as a heart failure specialist in US comparing to Europe, really emphasize the significance of hemodynamic and especially exercise hemodynamic testing of the patients, especially patients with HFpEF and have heart failure with moderately reduced ejection fraction. And on the left-hand side, you can see the study where they compared 39 patients with a HFpEF versus normal controls and with hemodynamic measurement of pulmonary capillary wedge pressure. And you can see on baseline, the difference is not large. A lot of these patients with HFpEF at baseline, when they're at rest, they have pulmonary capillary wedge pressure of 10 to 12, which we really do not consider really significant. But you can see the drastic, the separation of curves with just feet up which is just increasing the preload, and then with some exercise and really, really strong elevation and more than 30 millimeters of mercury with the peak exercise, which also tells you when you have a patient which you are not sure about dyspnea, one of the ways is really to evaluate them in addition to questionnaire, which Dr. Shin mentioned today, is really to consider if there is no other solution, just to go for exercise hemodynamic testing, which we have capabilities here in Monte, and we are decently good in that, and that can help us to diagnose most of these patients and then help maybe to approach it. So these data were also used. You can see on the right-hand side, there is a hemodynamic monitoring from Burkop, where they did the computational assessment. What will happen with these patients if you put the shunt and different size of intraatrial shunt in the patient? And you can see at rest, by the computational, you can see that there is elevation of left atrial pressure over right atrial pressure, but not drastic, but that drastically changes with exercise when left atrial pressure and indirectly the pulmonary capillary wedge pressure, which will give you the symptoms, goes up to the 30. And however, on the second row, you can see what happened if you put the shunt. You can see that separation of the pressures are not significant as much. There will be some increase in CVP and a little bit higher increase in pulmonary capillary wedge, but not drastic, which will give you symptoms. And this is a consequence which you can see in third row of increased flow through the shunt. And then it was also the question, what size of the shunt? Because we know if we have too large shunt with QPQS more than 1.5, you will develop pulmonary hypertension and RV failure to the time. And that's probably one of the indications for Dr. Latif to close the existing shunts anyway, if QPQS is more than 1.5. And we saw, like, they analyzed the different sizes of shunts and found that shunts 8 to 10 millimeters in diameter are the one which we hit the sweet spot where the elevation of the pulmonary capillary wedge pressure is very close to minimal increase in CVP, so the effect is really beneficial. And this was also confirmed, this computational study was then confirmed in lab HF1 study in direct measurements when you had a control group of patients and patients who have sham and the patients who have intraatrial septal device placed. And you can see while in control group with the same exercise, there is increase in pulmonary capillary wedge pressure. In the patients who has a shunt placed, there was smaller increase after in a blue line, which is comparing to red line after the placement of device, which showed there was a benefit. And it was approximately 5 to 7.5 millimeters of mercury decrease, which was significant, and that will lead to symptoms. And again, I'm saying at the Monte, we have, this is the one of the device we use for exercise testing. We have our hemodynamic cath lab, which allow us to diagnose and better assess patients with the HFpEF. So because of need unmet, which HFpEF, there is really a slew of devices. V-Wave shunt, this is probably most evaluated, and that's intraatrial shunt device from Corvia, and AFR, which is atrial flow regulator, which can change the size with Occlutech. And what we here in Montefiore are involved into the outflow trial is really the aperture transcatheter atrial shunt system, which is new approach, which is trying to avoid some pitfalls of classical intraatrial shunts, which is now left atrial to coronary sinus shunt. And this is from Edwards anyway. So there are multiple studies. This is probably the study which really was probably most important, and it's called Reduced Lap Heart Failure. This is with Corvia intraarterial shunt, when 1,000 patients, of whom 626 were ultimately randomized to either atrial shunt device or sham procedure. And this is what Dr. Yordi was mentioning. The problems with Triluminate is there is no sham. Here we have a sham procedure, so we are kind of avoiding the effect that you had something done, and that and that is really benefiting you anyway. And all this is again the group of patients which probably have the highest need for therapy, and that's heart failure with moderately reduced ejection fraction and HFpEF. Ejection fraction was more than 40%, and they all have exercise testing. So to be included, you really needed to have pulmonary capillary wedge pressure more than 25 millimeter of mercury. And what is also important for later analysis, these were patients who don't have pulmonary hypertension in our classical sense. So they had less than 3.5 Woods units of the pulmonary vascular resistance. And it was in multiple sites. And again, it was very important because it's really addressing HFpEF population. 62% of patients were women, and they were more than 72 years old. And you can see here on the left side, inclusion criteria, exclusion criteria. The problem with the trial, it was when you look and overall, it was stone cold normal. So there was no significant difference. So the composite endpoint, which was cardiovascular death or non-fatal ischemic stroke in 12 months, total number of heart failure events at 24 months, and then the same what Dr. Yordi was addressing. So I don't need to really bother myself explaining. KCCQ score was again no different at all between those two groups, which was kind of really big disappointed because this was really well conducted site. So of course, we should not give up that easily. We have the patients we need to do. But because the worrisome that something will be wrong, there were several pre-specified subgroups, which demonstrated when looked later in post hoc analysis that there is some differences. And you can see the patients who were likely to benefit more from shunt were women. And then the patients who have smaller size right atrium, which also tells you probably the size of state of right atrium and right ventricle, and then the patients with lower PA systolic pressure. So the patients who really did not do well, it was patients in the highest tercile of the pulmonary hypertension. So that led, and this is probably most important, to post hoc analysis, which was really nice paper by Borlag et al., which tested characteristics of something which was even new for me. I really didn't understand that concept. We don't really look at that, but I will now start looking at more. And this is a latent pulmonary vascular disease, which was defined that pulmonary vascular resistance more than 1.74 Woods units at peak exercise. We never really looked that much into that. We specifically look in pulmonary hypertension and pulmonary vascular resistance as a transplant cardiologist pre-transplant, but we look always at that in the kind of state of rest anyway. We don't consider it dynamic, which probably we should, because this also tells you whole idea about shunts was also partially that that these shunts would not cause a problem with overflowing the pulmonary system, because pulmonary vasculature is very different than systemic vasculature. Its capacitance is much higher, it vasodilates much more endothelial cells, and it can adapt more. But that will not be the cause of patients who has elevated pulmonary pressures from elevated LVEDP from prolonged period of time, which will cause them plexiform changes or mechanical changes. And these are probably these patients who will first of all have it. So when they specifically separated the patients who had that latent pulmonary vascular disease from patients who don't have, which was interestingly half-half almost, the patients who do not have a latent pulmonary vascular disease or pacemakers, they have a significant clinical benefit, not just in KCCQ, but also of heart failure hospitalizations and overall. So it was considered at that moment like positive trial. And this is really the device we are here employing in outflow study. This is aperture transcatheter shunt device. And you can see how it's done from the right internal jugular access. You can really cause cannulation of coronary sinus, and then you follow with a special catheter which allows puncture from coronary sinus to the left atrium, and then you balloon this to the 10 millimeter size, and then you put the device which keeps it open in 10 millimeter size, and you are avoiding limitations on direct transeptal approach, which was existing even before, as Rita said. And the one of the most important is you are avoiding or decreasing the risk that you're having a transition of DVT or the venous clots from the right system to the left system and causing stroke, which will be probably the most devastating consequences. And paradoxical embolization, and of course, technical complexity and risk of really significant problems with the direct septal. And then, of course, you don't want to have too much septal defect if you want to reverse it or things like that. So you can see it here, and this is outflow. This is early feasibility study, single arm, open label trial. Again, the problem with this study will be because it's not sham, it will later need additional study with sham testing, which we learn importance now. And here we approach it comparing to the LAP-HF2, where it was specifically looking at patients with not having pulmonary hypertension. Here, the study is addressing two cohorts, patients who have pulmonary hypertension, PFR, more than 3 and less than 8 work units, and patients who do not have it with pulmonary vascular resistance less than 3. And it was also addressing it through whole spectrum, not just in heart failure with preserved ejection fraction, but also heart failure with reduced ejection fraction. And again, importance, it was looking in exercise before enrollment that pulmonary capillary wedge pressure at rest more than 15 or at max exercise more than 25 and exceeding the right atrial pressure. And I had the video here, which disappeared. So, but it was really nice video how Dr. Azim is really accomplishing that. And really, you can see really how it a shunt is created between the left atrium and coronary sinus, and the device is keeping the shunt open and the leaving there. So outflow had early after LAP-HF results too, which were a little bit problematic. There was early presentation of some of the data with first 87 patients who were involved, and mean age was 71 years, 53% were male, baseline mean ejection fraction was 59%, and 90% of patients were quite symptomatic with New York Heart Association class 2. What was a little bit questionable is that device success was achieved in 78, but then again, this is 78 patients, only 90%, which is again kind of expected for early feasibility study. So I presume with there is a learning curve which need to reach. And in this group of patients, you can see there was significant improvement in mode hemodynamic measurements because they were measured before and after procedure. So there was decrease in the pulmonary capillary wedge pressure of 7 millimeters of mercury in total cohort, but it was achieved both in patients without and with pulmonary hypertension. And there was significant improvement in KCCQ class score anyway. So at the end, that was very interesting that at 6 months, 68% of patients achieved New York Heart Association 1 to 2 status, which is really the minimal symptoms. And it was 23-point improvement in KCCQ score, which we learned from Dr. Yordi is really, really significant anyway. So, and more importantly, that with exercise, that what we look specifically, there is 7 millimeters of mercury decreased pulmonary capillary wedge pressure, which I would, as a heart failure cardiologist, consider significant, really, really significant anyway, which was followed with, as expected, the increase in 6-minute walk distance from 257 meters to 297 meters. And at the same time, RA pressure, which is very worrisome with this device, was not significantly increased. There is also additional study for relief HF. This is, again, Ventura intra-atrial shunt, which will include 400 patients with symptomatic heart failure from HFpEF to the HFrEF. And again, because of LAP-HF2, there was presentation of preliminary 97 roll-in patients, which show significant improvement in KCCQ at first month and sustained and 12 months. And this is just smaller device. So there is really a lot of these devices. So the questions which are arising still is, there is what is significance of invasive exercise hemodynamics and baseline? So it seems that every new study will really need to focus on performing exercise hemodynamics before, because it seems that it can drastically affect who should we select as a responders potential. The second question is because the device sizes or diameter of shunts varies from 5 to 10 millimeters. What is the optimal size? Because at 8 millimeters, we have the QP-QS ratio 1.3, which is considered relatively tolerable. Is it at 10 millimeters too much? And that will cause RV failure or RV dysfunction. How atrial fibrillation affects this effectiveness of shunts, and who will have more benefit? Patients with HFpEF, of HFrEF, and the most important in long-term safety in context of development, pulmonary hypertension and RV dysfunction in these patients. Well, they may be in first year benefiting it. Question is what will going to happen in longer term, because we know that patients with the shunt, the children through the time develop pulmonary hypertension and RV failure. Thank you.
That was a terrific. Can you switch over? That was really great. I really enjoyed that. So just I want to mention on the last, the negative study, the big plus study, big disappointment for the field. The question is, why is that? Is it shunt position? We are very fortunate that we are involved in the next phase study. Sasha just showed the outflow. I'm going to ask Azim about that in a second, about the placement issues or not, because we've done several here. Sandhya Murthy has really led that. And we will be in the next study that has a sham control that is about to start, where we are in the leadership. Great. Any questions from the audience before we move on? Or Azim, maybe can you just speak briefly to maybe even Edwin? How is this different from putting an interatrial shunt? Is it more challenging? Is it easier? Do you just stick it in a tube and deploy it, or just?
Yeah, I mean, so making a hole in the interatrial septum is not difficult at all. That's clearly an easy procedure, but I agree with Sasha. I think we all have concerns. We all have concerns about creating an ASD, paradoxical embolism, right to left shunting, how big the shunt needs to be. And so a left atrial to coronary sinus shunt takes away a lot of those issues. There also may be specific benefits of shunting into a vein and venous capacitance that allows you to decompress the left atrium even more. I think one of the things that for me was fascinating was watching you guys do the right heart cath on these patients, because we all talk about HFpEF and these patients coming in, and I never really, as a cardiologist, understood it. Or how important it was until you guys started doing the right heart cath and you started sending me pictures, and we saw these wedge pressures just shooting up and pulmonary pressure shooting up. And finally, I started understanding why these patients get so symptomatic. I don't know if this is the right solution, but we have to study it, and we're going to be doing it in a way that even Dr. Goldstein will be happy, because we're doing sham control studies, which I think when you're looking at things like symptoms, and you don't have hard endpoints like mortality or heart failure hospitalization, then I think you have to have a sham control study to understand, changes in symptoms. Dan, you had a comment.
In the last iteration of the left atrium coronary sinus, has there been any study on the effect on the coronary vasculature and the potential for ischemia, given the increasing coronary venous hypertension, I guess?
Yeah. So far, we've not seen that. I mean, most of these patients have essentially normal coronaries, these HFpEF patients, but so far we've not seen it. It's amazing what the coronary sinus can accommodate. We've been involved now in a couple of different devices in the coronary sinus, anything from, there's a device called Reducer, where you create a stenosis by putting a stent into the coronary sinus that creates a stenosis to increase coronary sinus pressure and venous pressure for patients with refractory angina. And it's shown very interesting data. There's a sham control study showing improvements in angina. And there's an ongoing US study to look again about its impact on angina and doing exercise testing. And then we've also looked at retrograde perfusion, to decrease the infarct size in STEMI. So I think more and more we're delving as interventionists into the coronary sinus to see if we can use it as a way of impacting even the myocardium. But I've not seen negative effects just yet.
Great. Again, for me, super exciting that we can talk about these things and then not just show other people's papers, but sit here and say, how was it when we did it? You know, which is super cool. So I'm going to go quickly through background. It's a little bit show and tell study that we're doing here. Reverse remodeling is a major goal in heart failure. We know from multiple studies that if heart gets smaller and the EF goes up, that's good. When we see that early, people tend to have less heart failure hospitalizations, people will live longer. So reverse remodeling, improved outcomes, an extremely well-established concept in heart failure. How can we initiate that? Biological, mainly drugs, or physical. And there have been many attempts to do physical remodeling, and I want to show one of them to you today. Principal concept is Laplace's law. You make the radius of the ventricle smaller, you reduce wall stress. You reduce wall stress, you may induce better conditions and biological reverse remodeling. Surgeons are here. I have tried this many times with mixed results. The coapsis study actually showed some interesting results. I'm not going to go into detail, but this Laplace law, we've been chasing this with many procedures for a long time. So the question is, can we do this less invasive like everything else? Can we do this transcatheter? And here's a new device that many of you are already familiar with because we have used it several times here at Montefiore, so-called AccuCinch device, which is a transcatheter device. You can see the cartoon here. I was at a meeting last week and somebody said, you know, I'm going to show you the obligatory cartoon. This is good. The obligatory movie. So here we are inside the left ventricle looking from the apex. We're looking at the aortic valve there. Something's going to come in. That's our catheter. Guide catheter goes around into the ventricle, swapped out for something else, swapped out for a wire. And now little anchors and sliders are placed around the heart and the heart is made smaller. This takes about 2 hours nowadays and can be done in research, study. This is a case here at Montefiore where Dr. Lateef astutely placed this device in one of the first cases. You can see here the device is placed, and we can talk about the state, and then a little bit of a slack is reintroduced, and then all the equipment is taken out. Here you can see just an X-ray measure. Here's where the device was sitting in purple before it was cinched and brought together. And then it's about 9 millimeters in along the LV curvature. Here is a reconstruction of a contrast CT of a heart before and 12 months after. In pink is before, in blue is after. You can see these two little indents up here. That's where the device sat, but you can also see that the entire heart has gotten smaller over a 12-month period. This is what this looks like. Up here you see a cadaver model where the device is placed. Here is a patient many years ago, early compassionate case. The patient died 10 days later. But this is the autopsy, and you can see that after 10 days, the device already is significantly endothelialized and integrated into the myocardium. Here's a patient who had a heart transplant 3 months later. This is the postmortem native heart, and you can see the device is completely covered and sits under here. So you have some sort of a tissue girdle that is built over the device. This is because of the suture, this is the actual cable. It's really a suture that is penetrated with tissue. What results do we have? This device has been placed about 250 times worldwide. I want to focus in on patients that didn't have valvular heart disease when they got the device. Initially, this was conceived as a mitral regurgitation device with a kind of low angioplasty, and this progressed to being a ventriculoplasty for patients who have an EF of 20 to 40% and not more than 2+ MR. And here are the results of 41 subjects that were pooled from various studies. A typical heart failure population, I'm going to spare you the detail, but the ejection fraction is 29%. They all had symptomatic heart failure. They had large ventricles, 200 cc ventricles, 6.5 centimeter diameter. And the device was placed, like I said, about 2 hours, about 14 anchors used on average. And then as for safety, very important, definitely device related was one case where there was a pericardial effusion that had to be drained from anchor placement probably somehow. And then this is a 20 French arterial sheath. There were 3 femoral access complications, 1 infection, 1 thrombus, and something I don't remember, but they all resolved without sequelae. There was 1 stroke in these 41 patients that was adjudicated as possibly related. This was a patient with AFib that had a patient 7 days post-op and was not on anticoagulation. And here are results. I've talked to you about KCCQ. I talked to you about the 23 is a huge number, so a big hurrah. I also talked to you about the Hawthorne effect and no sham or anything, so take it with a grain of salt. 6-minute walk, you are familiar with 50 meters is a lot in heart failure. 50 meters usually is considered clinically very significant, but again, the patient knows I got this device, there's coaching, everybody's excited, you're probably much better now, and they walk more. But here are blinded results from echocardiography over a 12-month period. You have an initial reduction of about 10 cc's on the 200 that you start with. This is probably from the physical cinching, but there's no further cinching, and the device stays just like it is. And now you see a progressive reverse remodeling that has to be, it's not mechanical, so it has to be biological reverse remodeling that is induced. So as a heart failure specialist, that is extremely exciting. So this data was actually just published in the Journal of Cardiac Failure. There it is. And actually a total of 50 patients, a little bit more, but in principle, exactly the same result. So we are super excited to have started the 400-patient global randomized study. I'm actually one of the global co-PIs. Other one is Mark Reisman from Cornell. And we have actually identified 11 patients here already. Just got word today, I don't know if you saw it, that we have our second patient who will be randomized this week to the device. This is a big study that will go on. You heard a lot about medical therapy. There's a very stringent screening for medical therapy, CRT, all kinds of things the patient might need. They have gotten everything that is indicated and good before they can enter this study if they still have symptoms. This is a screening process. You have to have a certain thickness of left ventricular wall, which can be an issue sometimes. And of course, just like TAVR, they have to be able to get that 20 French sheath into the artery. Study is ongoing. We have 350 subjects consented. We're enrolling currently, and this is for patients with an EF of 20 to 40% and not more than 2+ MR. And I stop right there. This is Caution's heart failure, and hopefully we'll lead this. We're about to have the 50th randomization. Hopefully we can complete this in the next year and a half. So I would be happy to take any questions, and we can turn over for the next presentation. Silence everybody.
So, Uli, I mean, maybe some hypothetically, I mean, why are we seeing the biological effect? I mean, is it why does restriction or change in diameter at one level resulting in a change in LV remodeling? I mean, is it stimulating some sort of biological process?
Yeah. So we have to do what we would do in the study, as you know, is hemodynamic studies. Before and after, but we're kind of also with COVID, we're delayed, we're just getting out of the gate. We have to see what is the acute effect of this amount of cinching, because it doesn't seem to be all that much, right? Completely, although you go down 1 centimeter, so it's not trivial. And the only explanation is that you change the neurohormonal milieu following the Laplace law. You have less stress, you have less excretion of adverse hormones, and then, heart can reverse remodel. It's not as dramatic as taking away mitral regurgitation, but you do change the loading, not the loading conditions, but how the heart can see an increased load.
All right.
Joe.
So the surgical trials
Negative.
did not show anything. Why do you think this can be better than the surgical? Because the risk is lower of the intervention, or why?
Yeah, very good. So, surgical trial, one is stitch, right? Stitch, little bit different phenotype, right? Because you cut out an ischemic scar or almost really usually an aneurysm, so a bit different substrate. A T-star operation, where you had non-ischemic cardiomyopathy, a little bit more like that. Great fanfare when they first did it, didn't pan out in randomized trials. I can't really give you a definitive answer. Clearly, this trauma to the patient here is, compared to a cardiac surgery, a bypass on all of that, trivial. So maybe without that insult in the beginning, the concept works. I was also very skeptical, but I think the reverse remodeling results are just, don't lie. We'll find out.
Thank you.
Who has the mic?
He's got the mic.
And then we'll pass
Ask your question and then we'll pass it on. Go ahead.
Okay, so I think like what I was always concerned about this was when I was a medical student.
Can we just wait for the microphone because people can't hear you online?
Oh, thank you. When I was a medical student, I was so like excited about Baptiste. And what I know, like from the biology standpoint, we all know, to simplify, that dead meat don't beat anyway. So is there a way to select the patients better who doesn't have fibrosis or fibrosis which can develop recovery anyway? So
no, Manaf. It's the wrong talk. Sorry, Sasha. It's the wrong talk. Needs to be Manaf. Where's Manaf? Asafin. Just you can throw it should be on here. I'm sorry, Sasha. I was spacing out on the seat. Just repeat the question. Now I'm listening. Medical student, Batista.
Medical student, Baptiste, yay, not working. But dead meat not beat. You know that we said that in transplant. So I think the selections of patients, is there any way that we can select the patients better from whom we will expect recovery, that they still have viable muscle, which is not fibrosis or things like that? Because I think that's a crucial thing, that you can expect recovery.
That's a great question. You're up to 16. This is what the beauty of this study is, because everybody gets a CT contrast at baseline and at 12 months with the 3D reconstruction of the ventricle, and a model is actually built. So we're going to learn a lot about what the ventricle looks like. That will get better.
I was thinking about MRI, for example, here, to look into the fibrosis of the tissue.
Yeah.
Do you expect, because like when they
I get it. Yeah.
Of the end-stage heart failure, very often there will be really nothing to recover.
Yeah.
Just too late.
Jamil?
Along the same lines, do you see or foresee a difference in response between ischemic and non-ischemic?
So in the early experience, we didn't really see a difference, but it was also a relatively small sample size, the 50 patients, right? You can only say so much. I think about 30 were non-ischemic or some 35 and 15 ischemic. Intuitively, non-ischemic
should do better.
But that's why we're doing the study. Good point. So it's a 400-patient study, so we will find out.
Another question, technical, possibly to Dr. Latif. I see that they are placed more towards the base of the heart. Is there a reason why that is?
That's a great question. I think that's historical more than anything. So it was actually even higher. So this device has been around for a long time. It was initially, the company was called GDS, or Guided Delivery Systems, and it was invented by an interventional cardiologist as a device to decrease mitral regurgitation. So as an annuloplasty device, but subannular. Okay. And then with time, as they developed the device, they had to learn about how to get around, how to navigate, how many anchors to put in. We started realizing that the reduction MR wasn't as great as we were hoping. There was some reduction, but we were seeing all this improvement in quality of life and symptoms that was out of keeping with the MR. So it's kind of historical, but what we have done is gone a little lower. So before it was as subannular as possible. Now we try to be within about 10 to 15 millimeters from the annulus. That's just historical. we've thought about, should you put another layer as well? So put one up there and put a second one further down, could that result in better outcomes? That's something still we've got to figure out. So Manaf, you're going to take us through a different type of percutaneous or hybrid ventricular. Yeah, sorry.
Question.
There's one last question.
Yeah, very, very quickly. I know, as you said, that you all started trying this device with MR. Have you checked the MR in this position for these patients with PCM after the implantation, other than the left ventricular remodeling in your study so far?
So in the current study, it's a heart failure study. So we're excluding patients with severe MR. We're only including moderate to mild. You do see those who have moderate, you do see some improvement. I don't think it's an annuloplasty effect. I think it's a negative remodeling effect. So the LV becomes smaller, and as a result of that, you're probably getting some pulmonary muscle displacement and less death, is what we think. So Manaf's going to take us through a different type of ventricular restoration therapy, but now specifically for ischemic cardiomyopathy.
Yeah. Good afternoon. Thank you for the invite. My name is Manaf Asaf, and I do interventional cardiology and structural heart interventions here at Montefiore. So I'll be talking about a novel kind of hybrid, minimally invasive approach to perform something called ventricular restoration, which we'll talk about in ischemic cardiomyopathy. So obviously very well known to this audience, ischemic cardiomyopathy, the most common cause of systolic heart failure. Remodeling, again, is very important. Be louder here. Remodeling is associated with reduced ventricular contractility, dilation, and geometrical changes that increase wall stress and make the heart less efficient. This meta-analysis very nicely showed that even with primary PCI, more than half of patients who have an MI and get PCI have an infarct that involves more than 18% of their myocardium, and a quarter of them have an infarct that involves more than 30% of their myocardium. And if we stratify them in these quartiles based on their infarct size, the patients with the largest infarct size have the most mortality and heart failure hospitalization, which should be no surprise to any of us. Specifically, the end systolic volume we'll be hearing a lot about in this context is associated and an independent predictor of heart failure and mortality, with patients who have volume indices over 60 doing the worst. Again, the concept of Laplace's law and wall stress, the more dilated the ventricle, the more wall stress. And we know that akinetic and dyskinetic myocardium after MI is associated with this increased wall stress, as well as other adverse events like ventricular arrhythmias, sudden death, and mural thrombi. A little bit about how this happens, again, involves increasing wall thickness as the myocardium tries to compensate in a cardioprotective way for the loss of muscle, which over time becomes loses regulatory mechanisms and becomes actually decompensated and leads to heart failure and death. In this sub-study of STITCH, which was actually authored by Dr. Mitchler, they looked at patients who underwent CABG alone versus patients who underwent CABG and ventricular reconstruction. So basically excision of a akinetic and scarred out piece of tissue. And what they found was very interesting. In these patients in red who underwent CABG alone, there seemed to be a difference in mortality when compared to patients who went CABG plus ventricular restoration, but only in patients who achieved, as you can see on the left side of this curve, who achieved a systolic volume index less than 60 or 70. In patients who didn't achieve that, who didn't get a lot of remodeling after the surgery, that was not the case. And when you look at the left side of this curve, patients who achieved good reduction in their end systolic volume indices, we see a hazard ratio of 0.33 in relation to patients who underwent CABG alone. So when it comes to death, so a significant mortality benefit on top of CABG in patients who undergo restoration or excision of scar in patients who achieve a good result in terms of low systolic volume. So that sets us up for the rationale for a minimally invasive way to achieve the surgical result. So this is a company called Bioventrix that performs this live procedure, a Revivent TC. It's basically a hybrid procedure that involves transcatheter and mini thoracotomy approaches, no need for cardiopulmonary bypass, and uses anchors and tethers to exclude this scarred out akinetic portion of the myocardium. We'll see a little animation, again, the requisite animation. So done in a hybrid OR, there is a jugular approach. Catheter is advanced into the right ventricular apex. And then through a lateral mini thoracotomy approach, a needle is advanced through the lateral wall of the left ventricle, through the interventricular septum. And then a wire is advanced, which is snared from the right ventricular catheter. I'll fast forward a little bit. Basically, then a tether is introduced into the right ventricular side of the interventricular septum, and then an anchor is placed on the lateral wall, and those two anchors are approximated. Let's just fast forward a little bit here. We see a short axis view. There's the anchor on the RV side. You'll see now an anchor coming in from the lateral LV wall. They're approximated. This plicates the ventricle and excludes the akinetic portion of the myocardium. This is repeated 2 or 3 times to exclude all of the scarred out myocardium and achieve this surgical-like result of a plicated ventricle. Here we can see the same patient before and after the procedure. And although we haven't improved the contractility or given the patient any more heart muscle, we can improve the dramatically increased efficiency of the ventricle as it ejects the blood. There's less dyskinesia, there's less stasis of blood, and more forward flow. The appropriate patients are patients with scarred out anterior segments of their, or anteroapical, anterolateral left ventricular wall, dilated left ventricles, and patients who have a low ejection fraction and are symptomatic with NYHA class 3 or 4 symptoms, despite medical therapy. This device was approved in Europe, and for the CE mark trial that gained them approval, the patients were about 61 years old, mostly male. They had 100% procedural success, and between 2 and 3 anchors were placed. You look at the safety profile, they had 2 ways of doing it. Initially, they started with an RVOT snaring, which was not very safe or had higher complication rate. When they switched to this apical snaring technique for the second half of their patient population, we have very low in-house mortality, 1 patient, very little bleeding, 1 patient, no stroke, no VSDs, and overall a very acceptable safety profile. In terms of heart outcomes, we had a sustained reduction in LV and systolic volume out to 5 years in patients who underwent the procedure, and also a sustained improvement in NYHA class. 6-minute walk test was improved in up to 2 years, but not significant at 5 years. Ejection fraction, again, improved at 2 years, not quite significant at 5 years, but there is a trend which is interesting. No change in mitral regurgitation. In terms of the U.S. study, the U.S. pivotal study has just finished enrolling. It was a prospective randomized trial, 2-to-1 randomization to treatment or control. And 1-year primary endpoint, 5-year follow-up. It just finished enrolling. These were the inclusion and exclusion criteria basically already discussed. We'll have data probably later this year, and this will be the first randomized data, so we'll be looking forward to that. In summary, patients with ischemic cardiomyopathy, an akinetic or dyskinetic myocardium we know are sick and at risk for increased death and hospitalization. This hybrid approach based on surgical treatment seems to be feasible, safe, and has promising results in well-selected patients. The trial that is currently or just finished enrolling will give us some data later this year. And I think this highlights the way that interventional heart failure toolbox is growing, and that there is really room for everybody on this heart team as we offer more options to our patients. Thank you.
That was great. Let's do the changeover. Any questions from the audience for Dr. Asafin?
Jamil or Steve? I mean, any thoughts?
Joe? Let's give him the mic. Where's the mic? Oh. Ask him now, but he wants the mic. Oh, yes.
It's not on.
Hello? No. There you go. There you go. I understand thrombus is an exclusion criteria because that's a limitation. Because obviously, when you have big scars, you normally have thrombus. So I guess the number of patients that's where you can do this is kind of limited.
Yeah, that's true. That is a limitation. But having said that, they've managed to find a lot of patients. I mean, to the point where, this procedure is approved in Europe. We've been talking about whether we get it here at Monte. I've always wanted to shish about the heart. So to me, it's very appealing, But yeah, I think it's something, in a very specific group of patients, patients with an anterior infarct, probably with a large scar who don't have any thrombus.
Yeah, I was just asking Azim if he's done this in the experience in Europe, because surgically when I place a device in the apex, like an LVAD, if you ever tear or have any disruption in the left ventricle, how catastrophic that can be. I was just asking the success rate in Europe and any experience that he's heard.
In the European study, there were no VSDs. That was one of the things they looked at. It's done under, careful TE guidance, and the actual puncture in the left ventricle is quite small. I think it's like an 18 gauge needle. So I think that's helped to mitigate the VSD risk.
Yeah. I just want to quickly ask, I see Danny standing here, Steve. I mean, the STITCH trial, the senior author, I forget, the senior or the first was Bob Mitchell, who's the chief of cardiac surgery here. So what's the local opinion? How often do you ever do it? Because I think from how I understand the STITCH, there's some controversy in retrospective analyses, or Jamil, I just see Jamil also, some controversy as to, that some patients actually would benefit from it under certain criteria, that no thallium scans were done, blah, blah, blah. Can somebody take the pro position for a second? Everybody should get it, or no? Is it out?
No.
Dan, you want maybe? I don't think maybe I've seen one since I've been here in 7 years, and so I don't think it's part of the armamentarium anymore.
Okay, yeah, fair enough. We also, fair enough, we get to them too early, and we don't see this type of aneurysms anymore. So maybe a historic procedure other than AccuCinch, where you can treat the non-MI patient. Great, thanks so much, Manav. Last talk for this session before a quick break is Shivank Madan. Shivank is the medical director of our clinical cardiovascular research, and he's just going to give us a 3-minute whirlwind. We can have 7 whirlwind or 9 whirlwind presentation of a few trials, just a show and tell to get the spectrum of what we do, which is pretty amazing.
Yeah. Thank you, Dr. Yodi. Hi, good afternoon, everyone. I'm Shivank Madan, heart failure transplant cardiologist and medical director for research. So I'll give you a quick overview of our clinical cardiology research program, since we are an academic center and we do really cutting edge research. I have no direct financial disclosure or any conflict of interest. However, I will be discussing investigational use of certain drugs and devices. So importantly, first and foremost, striving for diversity in research. Unfortunately, study participants in randomized controlled trials are on most occasions not representative of a physician's own clinical practice. And that's certainly true for us who practice here in the Bronx. For example, when I see in my heart failure clinic, when I see a Black patient and I want to start one of the new SGLT2 inhibitors, I do wonder whether I can apply the results of those trials to the patient that's sitting in front of me in the clinic. because if you look at all the HFrEF trials for SGLT2 inhibitors, less than 5% of the patients were of Black race. Well, thankfully, there has been an overall, nationally, there has been more focus now to increasing diversity in clinical trials. And FDA now mandates all sponsor of any new medical product to include and submit a race and ethnicity diversity plan as part of their clinical trial protocol. Both ACC and AHA now strongly advocate a path for increasing diversity in cardiovascular clinical trials. And the same is for all the major journals, both New England Journal of Medicine and JAMA now ask for specific information where the trialists are asked to place the race and ethnicity of the trial population and contrast it with the race ethnicity of the disease power, the disease in the population out there. And this is where we are. We are one of the most top diverse counties in the country. And this is where we practice medicine, and this is where we do research, where 28% of our patients self-identify as non-Hispanic Black, and almost 50% identify themselves as Hispanic. Montefiore clinical research. So we do have research operations at 3 main academic campuses, at the Moses, Weiler, and the outpatient Hutch campus. At any given time, we have about over 40 active randomized clinical trials in across all cardiology subspecialties. And the faculty within the Division of Cardiology produces more than 200 original research papers each year. So we are truly a strong academic center with a world-class research that we do. And this is our core clinical research team. This is the team that helps us run the clinical trials and the clinical research. And then this is the team that helps investigators deal and work with the external research environment, with both the local and the regional IRBs, various other departments in the hospital, the NIH, industry sponsors, whether it's media relations or whether it comes to managing finances for the trials. So a complete infrastructure. Now, I'll give you a quick, as I said, that we have many active trials. I'll try to give you a flavor of some of the important trials that are currently ongoing or recently completed across the various cardiovascular therapeutic areas. Pulmonary hypertension, we do have a talk about PH, one of the most difficult disease to manage. Quickly, if you look at the pathophysiology of pulmonary hypertension, you'll notice that the underlying pathophysiology is vascular remodeling. Yeah. There is endothelial cell apoptosis, intimal fibrosis, inflammatory cells that infiltrate the pulmonary vessels. But if you look at all the current PH treatment, they all focus on primarily on pulmonary vasodilation, whether it's antagonizing the endothelin pathway or activating the prostacyclin or nitric oxide pathways. So where is the disease modifying treatment? Well, this is one of the studies that are currently active, the Sereno CS1 pulmonary arterial hypertension phase 2 study, where CS1 is a novel disease-modifying novel therapeutic molecule that inhibits HTAC and acts as an epigenetic modulator, which is basically trying to alter gene molecular expression without actually causing any DNA changes. And the thought process is that this is supposed to reduce inflammation, supposed to be antifibrotic and reduce thrombosis and really act as a disease-modifying agent. And this is combined with the precise and accurate measurement of pulmonary pressures with the CardioMEMS system. What about type 2 pulmonary hypertension? Dr. Vakulik already showed you the results. This was the all-flow Edwards transcatheter atrial shunt system for patients with one of the subgroups of the trial population is patients with symptomatic class 2 heart failure and group 2 pulmonary hypertension. And because of the encouraging results, we'll soon be seeing the all-flow 2 study at Montefiore as well. What about hypertension? What's happening in the field of hypertension, resistant or uncontrolled? Now, as few of you may recall that about 10 years ago, there was a lot of enthusiasm about renal denervation therapy for blood control, blood pressure control. But then in 2014, the results of the Simplicity 3 hypertension trial were published, which was a 500 patients randomized controlled trial, which compared renal denervation to sham and did not show any difference in blood pressure control in the arms. A lot of disappointment, but this negative trial and all the other trials in the similar time did teach us a lot of things. It taught us that we need to have better patient selection. The therapy depends on both the main and the distal renal artery branch ablation, and also on the number and the circumferentiality of the ablations that can be done. And subsequently, now there have been 5 randomized controlled trials, and all of them have shown consistent reduction in blood pressure with the renal denervation therapy. So this is the Spiral Affirm study, which is a multi-center international study to investigate long-term safety and efficacy of Medtronic's Spiral renal denervation system in patients with uncontrolled hypertension. As I said, this catheter allows for simultaneous ablation up to 4 sites. If you recall the previous slide, I highlighted how the circumferentiality of ablations and multiple sites are crucial for procedural success. And the catheter is flexible, allowing the operator to intervene on the distal vessel as well. So will renal denervation become the new standard therapy for patients with poorly or uncontrolled hypertension, or even our patients with suboptimal medication compliance? What's happening in the field of lipids? Lipoprotein little a is the talk of the town. So last year, the European Atherosclerosis Society published this consensus paper where basically they laid out that now there is enough data to show that there is a causal and continuous association between lipoprotein and atherosclerotic cardiovascular diseases, even in patients with controlled LDL levels. 70 to 90% of the variation in lipoprotein A is due to genetics. And the consensus statement laid out that there is a need for development of pharmacological therapies to provide sustained reduction in lipoprotein A. Well, this is the Ocean A trial, which basically is olpasiran, which is going to a phase 3 trial, which is going to look at the differences in major adverse cardiovascular events in patients with atherosclerotic cardiovascular disease and elevated lipoprotein A. And olpasiran is it's a synthetically generated small inhibitor RNA molecule where basically it's supposed to cleave the target mRNA in the hepatocyte and lead to reduced production of lipoprotein A. So highly specific treatment and only once every 12 weeks injection. Atrial fibrillation. The current Dr. DiBiase in one of the earlier talks today highlighted that the current ablation uses heat or cold. And that creates problems as in that can create complications like pulmonary venous stenosis, atrioesophageal fistula, risk for cardiac perforation, or problems with incomplete ablation. Well, this is the ADMIRE study, which was right now is in follow-up, where basically this is treatment management of atrial fibrillation with irreversible electroporation system, where an electrical field is applied to a tissue, not heat or cold, and it leads to a formation of irreversible pores and to cell death. The advantage is that electrical field can be applied very specifically. There is more control and hence high tissue specificity. And this is expected to lower the rate of complications. And as following the earlier talk from today, that maybe all of us will be more willing to send our patients for ablations. Coming to what's happening in the phase of space of mitral regurgitation. Now, we heard a talk earlier today about transcatheter edge-to-edge repair, which has been the workhorse for working on MR in these patients. And multiple randomized trials have now shown that this therapy is safe, effective in reducing MR. It's FDA approved now for both the primary as well as the secondary MR. And there are several generations of the mitral clip that are now available. However, I think my structural colleagues would agree that there are limitations to this therapy. This therapy needs a favorable valve anatomy. What if your patient has a complex or mixed mitral valve etiology? Or what if the MR has multiple eccentric jets? Well, this is one of the studies, Cephea transcatheter mitral valve replacement early feasibility study, where this is a transcatheter mitral valve that can be deployed via femoral access. The valve has a conformational design which allows it to adapt to various valve anatomies. And it has a modular architecture, which is going to protect the prosthesis from external deformations and lead to probably help with long-term durability. Finally, what's happening in the space of tricuspid regurgitation? Now, orthotopic valve replacement for which basically involves deploying the valve transcatheter on a native valve. I think Dr. Radev would say that has become very standard now, and the field is now also moving towards heterotropic valve replacement, where basically this is now a multicentral trial of the trick valve, where you can place the valve, two independent valves, one in the superior vena cava and one in the inferior vena cava, instead of the tricuspid valve itself to reduce tricuspid regurgitation. And this is probably ideal for our patients who have a severe tricuspid valvular dilation, which is exceeding the size of the available devices, or if there is an unfavorable device or an angle approach. So really exciting where this future is headed in this space. And I think that was the last slide. So thank you everyone for your time.
Yeah, Shivang, that was really outstanding. I see our research coordinators in the back there. Can you guys stand up for a second? Because I think you get a round of applause from us. And Shivang has led the program for what, 2 years now, 1 year? Year and a half?
1 year and 9 months.
And it's really coming into incredible shape, I think. So I think we're all very proud of what we just saw. You can ask a question, Heather, go ahead.
Dr. Madan, in the media recently, there's been a lot of talk about intrapartum, postpartum, and peripartum maternal death, especially in areas where there's a lot of social disparity. What is Montefiore doing about this? Anything at all?
Well, if it's a pretty, I think that's a very important topic to deal with. I can tell you that within cardiology itself, there is a dedicated clinic for OB cardiology. Actually, I would, thankfully, one of my colleagues, Dr. Murthy is present here, who can probably answer your question in a much better way.
So I'm going to twofold things. One is to set up an infrastructure to see and capture these high-risk women, which obviously we know PPCM is probably a spectrum, preeclampsia, more common in African Americans. Certainly there's a genetic predisposition. There's a lot that we're learning about PPCM now. But I think an integral part is Diana Wolf from OB-MFM partnered with the cardiology team, and actually Dr. Chavez behind me runs a clinic with her and sees these high-risk women on a weekly basis. So that's one thing. The second thing is we have access to a very important PPCM trial funded by the NIH, and this is the Rebirth trial, which is looking at the role of bromocriptine in the PPCM women. There's been a lot of data, not all great data. This is the first North American rigorous randomized controlled trial looking at bromocriptine as a way of blocking prolactin, which is thought to be one of the pathogenetic mechanisms of this disease. So there is a lot going on, and I think the bigger structural social issue, we are trying our very best to address this with a monthly multidisciplinary high-risk MFM cardiology meetings, weekly MFM cardiology clinic sessions, where we try to capture all these high-risk women with the development of cardiovascular and pregnancy scores and things like that. So I do appreciate that question, though.
That was really a good question, big issue. I think we're very committed here as an institution. So we're going to take a 15-minute break until 4:05, and then we'll regroup here.
Very exciting for us that Dr. Khalik has come to save us from all these scary proximal acute PEs. And she's going to talk to you guys about the multiple ways that we can deal with this urgently in the cath lab in the middle of the night. Okay, thanks.
This one is.
Hi, everybody. My name is Asma Khalik. I'm one of the interventional cardiologists working for Montefiore. I'm also the director of the endovascular interventional cardiology. So my topic is contemporary management of pulmonary embolism, specifically in the cath lab, though I would like to talk a little bit about everything as well. So without belaboring, just immense burden of disease. About 1 million people are afflicted with venous thromboembolisms, and which includes DVTs and PEs. Close to 100,000 people die from it every year, and it's 25% of them have the first presentation as sudden death, and about a third of them have sequelae like post-traumatic syndrome, and a third have recurrences of their DVTs and PEs over the next 10 years. So, and about $10 billion US are spent, so massive economic cost as well. And it affects everybody, and many famous people have died from it. So just to give you an idea. So I always like to open with this, just a reminder of how PE impacts the RV, and whatever we do for PE, it's basically to sort of cut short this cascade of rapid RV deterioration and hemodynamic collapse. So this is a case that I borrowed from one of my colleagues, Dr. Tapson. So it's a case from a few years ago it's at Cedars-Sinai in their hospital. A 60-year-old male who had an unprovoked PE had basically RV dysfunction, tropes elevated, so every indication that it was a intermediate high-risk PE. So, however, the patient was hemodynamically stable, therefore was treated with anticoagulation. As you can see, proximal PE, lots of clot burden. RV-LV ratio was elevated 1.5, which basically portends a very poor survival and a high mortality. And basically every indication that he was not going to do well. However, so be it, as the guidelines still, which are kind of very deficient, he was treated with AC, and appropriately so. So, and this is him. He was discharged home at day 4. 5 days into it, he was basically on the toilet, and he had a sudden cardiac death. And this is his autopsy showing a massive saddle embolus in his lungs. So with that background, I would like to talk a little bit about the classification of PE. So this is the ESC classification of PE. The high risk is one in which there's hemodynamic instability. We all know about this, basically low blood pressure, less than 90, more than 40 mm systolic drop, which is not attributable to other things. And then intermediate, which they divide into intermediate, high, and low risk, based on the fact that whether you have just RV dilatation or RV injury as well. And the low risk ones are the ones which basically don't have any of those features. Just taking a look at this, if you see the ones that are high risk, they have a mortality, a 30-day mortality of about 30%. And the ones that are low risk have 1% mortality. And the ones in between, depending upon if they have RV injury or not, have their mortalities anywhere from 3 to 15%. So basically more of the same. And these are some of the risk scores we use to classify. This is the PESI score, which is a little bit more complex. And however, nowadays we use the simplified version of it, which is a simplified PESI score. Essentially has these 6 components. If one is positive, it basically means that your 30-day mortality is going to be 10%. And if it's 0, then it's less than 1%. So we sort of use this to risk stratify as to who to take to the cath lab and who to get to earlier. Another risk score we try to look at as well, because if you see the PESI score has no reflection on the RV function or RV injury. So this BOVA score, however, does. It takes into consideration the RV dysfunction and tropes. So we sometimes use that as well. And this is some of the other things that we do look at and that studies have shown is related to a higher mortality. For example, a central clot, large clot, concomitant DVT, especially a proximal DVT, and residual pulmonary vascular obstruction. Another thing that we look at is shock index. Sometimes you'll have patients who are nearly normotensive, but they have high heart rate. So if your heart rate is high and your blood pressure is kind of borderline, so that if you see, in the receiver operator curve, also portends a poor survival. So, but the guidelines, the most recent guidelines are the ESC ones. So for the high-risk PEs, they still, obviously AC, and they recommend giving, still recommend giving systemic thrombolysis, and I'll allude to that a little bit more. And if you have contraindications to systemic thrombolysis, they recommend surgical embolectomy, and catheter-directed embolectomy is considered 2A. And ECMO is 2B for patients who will need hemodynamic support or who have a refractory circulatory collapse. Again, quite similar, not very different for patients who have intermediate or low risk PEs, basically AC being the mainstay. And again, if you see here in, my bad. So surgical embolectomy and percutaneous catheter-directed treatments are kind of to A, and which have been elevated from the prior recommendations where they were 2B. So lytics have been the mainstay for a very long time, which, however, as you can see, lytics are not without a problem. Lytics have a lot of concomitant problems. In this meta-analysis, they looked at patients who received lytics, and as you can see, that the risk of bleeding, risk of major gusto bleeding for systemic lytics was close to 10%. And the risk of intracranial bleeding was as high as 2%. So, and those are mostly catastrophic events. So how do we treat PE in the cath lab nowadays? There's kind of two ways to treat. One is these catheter-directed lysis, which we have kind of moved away from, again, because although the dose of the lytics in these catheter-directed therapies is less, but it's still there. And I will show you in the studies that the risk of bleeding is not insignificant. So they can either be just drip catheters like Unifuse, McNamara, or they can be catheter-directed but ultrasound-assisted, for example, ECOS. So, or Bashir catheter, which basically has a nitinol ring in front of it, and it basically gives localized TPA. So it's kind of pharmacomechanical. Sorry if it doesn't translate very well, but it's just a summary of the data of these catheter-directed lytics trials, which basically shows that, as you can see, the N in these is not very high. And most of these looked at the outcome of RV-LV ratio, which, as we saw earlier, it's kind of a prognosticator of how the patients are going to do. And most of these were successful in reducing the RV-LV ratio, but at the cost of, as you can see in the last section, and you see at the cost of bleeding. Again, this was a pooled analysis of these catheter-directed lytic trials, and all of them, basically come at the cost of bleeding. As I said before, we saw in the systemic lytics, it was around 8%, 10%, and here's around 5%, but still there. And the ICH was around 1.7% in the systemic, here it's around 1%. So again, it's not without risk. So that leads us to the new era of pulmonary embolism treatment, which is basically catheter-based embolectomy. And now we have a myriad of devices and several others in the pipeline that we use to basically evacuate the thrombus. So AngioVac, which is basically a veno-venous bypass, and it has a funnel-shaped tip at its end, basically. And however, it requires a perfusionist, it requires a veno-venous bypass, as I mentioned. We use it for clots in transit, but not so much for the pulmonary PEs per se. So at least in our practice, FlowTriever, Inari's FlowTriever, and the Indigo system of Penumbra are the mainstay of treatment. The Angiojet was used before, but because of the fact that it causes so much lysis of the cells and so many so much release of the substances after the cell slice, it causes hypertension, bradycardia, not very different from when we used to use it to treat MIs. So, basically the same. It gives you what are the various options we have nowadays, and just a myriad of options. And this is kind of another view at the trials. The first 4 are the trials of the catheter-directed lytics, and the last 2 are the FLAIR and the EXTRACT PE trials, which were the earlier device trials. FLAIR is one of Inari's earlier device trial, and EXTRACT PE is the earlier device trial for Penumbra. And in both of these, you can see, the RV-LV ratio and systolic pulmonary hypertension were used as indicators for improvement. I do want to touch upon these new latest trials, which a little bit more. So this is the FLASH registry of Inari, which enrolled around 800 or so patients. It was a prospective single-arm trial, and it looked mostly at the intermediate risk patients. We were actually, when I was at Lennox, we enrolled quite a few patients for this trial. And their objective was actually at that point to look at the safety and efficacy of the device. And their primary endpoints were, any device-related injury or mortality at 48 hours, major bleeding at 48 hours, and any intraprocedural or device or procedure-related adverse events. So this is kind of a look at their baseline characteristics. As you can see, most of the patients in the trial are 76% of them are intermediate risk, and a few of them are intermediate low, and a few of them are high risk. And as you can see, their RV-LV ratios are around mean of 1.5. Looking at the blood loss with and without, now they have this little sieve or filter system which returns the blood. So therefore, that's why when you do it with the flow saver, it reduces the blood loss. So this is looking at how the patients did, and we see it every day in the cath lab. Once there's a successful thrombectomy, you see an immediate drop in the PA pressures, the cardiac indices increase, and the pulmonary vascular resistance also drops. Their heart rate and supplemental oxygen as well. You can see it at immediately post procedure, and at 48 hours, there's a significant improvement, and so do the echocardiographic indices. So this was their safety data. So overall, quite safe. So major adverse events were quite low, just 1.8%, and not 11 significant bleeding events out of 700 and something patients, so just 1.4%, and 3 intraprocedural AEs, and they were just mostly groin related. And the incidence of CTEPH in these patients, because they followed them all the way up to 6 months, interestingly was 1.2%. And as Sandhya will tell you, and Jamil will, that it's in the all comers it's around 3 to 4%. So so definitely an improvement from that. So just in 2019, AHA came out with these came out with this statement paper about, because the data is so, there's such paucity of data about PE, especially high-risk PE, because to do a trial in a high-risk PE population is very difficult because these patients are sick. They have to be rapidly triaged, and there isn't much time to randomize them. So basically what they said was that non-randomized prospective studies with pre-specified performance goals is reasonable, and the best clinical effectiveness measure should be short-term mortality. And that all PE patients should be examined, whatever modality of treatment they are subjected to. So with that in mind, basically they did a literature, and JSky, this paper was published by Silver et al. And they looked at this to see what the data was out there about these patients who were undergoing, basically all comers. So their hospital mortality of high-risk PEs up until now is around 30%, so which is quite high. So 1/3 of the patients who have high-risk PEs, they will not make it out of the hospital. And their 30-day mortality is again very high. Their in-hospital bleeding risk is quite high as well, as is their intracranial hemorrhage risk, because most of them earlier on were treated with TPA. So this was used as the performance goal for the next device trial that Inari conducted, which is kind of a very, it was a pretty positive and optimistic trial for the people who treat PE, and it was just published or actually presented as a late-breaking trial at ACC last year. So essentially what they did was that there was a prospective multicenter non-randomized parallel group trial. So they looked at, there was a flow retriever arm where they used the device, and it was not randomized. It was on the discretion of the physician to choose the modality. And then they used a context arm, which is all the other patients that were treated by some other modality, which in this case mostly was thrombolytics. And then there was a prior therapy arm, which was based on the, on this prior data, which I showed you, which, basically based on the performance measures, based on the meta-analyses. So these patients were followed for 48 days, and these were the inclusion-exclusion criterion, and these were their primary endpoints: all-cause mortality, bailout to alternative strategies, clinical deterioration, and major bleeding outcomes. And then again, their secondary endpoints were, make sure they looked at the any strokes, device-related injuries, access site injuries, and hospital resource utilization, which included ICU beds, ECMO, time to extubation, time to discharge, etc., and where they were discharged to. So, then again, as we saw, the performance goal of 32%, which is what they used as the it is what they compared it to. So, and they were going to stop the trial if it met the pre-specified interim analysis criterion at 50 patients. So, which is exactly what they did. So, this is kind of a look at their baseline characteristics. And this is a look at their, the clinical characteristics, their shock, their location of PE is quite comparable in the FlowTriever as well as the context arm. And again, the composite primary endpoint was reached only in 17% in the FlowTriever arm, and the context arm, which got other therapies, they actually did significantly worse. They had 63%, and I'll break it down to you. So the in-hospital mortality, as you can see, in the context arm and in the performance goal was quite similar to what that meta-analysis showed. But in the patients who actually did undergo thrombectomy with the FlowTriever, it was significantly less, 1.9. And again, less bailout was used, less clinical deterioration as compared to the context, but kind of similar to the performance goal arm, and less bleeding as compared to the context arm. Because remember, all the context patients received thrombolytics, so obviously they're going to bleed more. Again, less ischemic and hemorrhagic strokes in the NRE arm, and less, and they had some device-related injuries, mostly, but none of them were significant though. None of tricuspid valve injuries, cardiac injuries, pulmonary vasculature injuries. They were just basically groin hematomas. And all the other measures, the patients who did receive mechanical thrombectomy with NRE, they did significantly better. So essentially what the implications of this was that large bore mechanical thrombectomy is safe, it reduces mortality. I know, people who are skeptics will say that it was not a randomized study, but, in terms of comparing it to the context, it did reduce. So, and it quickly reverses the obstructive shock, and it improves oxygenation, and it also significantly reduced the, resource utilization as well. So, and a care pathway similar to STEMI and stroke is now being thought of and is being developed in many places, and we are also looking at developing our own here. So this is one of the other trials of Penumbra, which is ongoing, but they also published their interim data of 87 patients, which also showed, improvement in the RV/LV ratio, and also in the Brock dyspnea score, and overall quite safe. And I just want to, before I end this talk, I just want to talk about this normotensive shock, because all of us are clinicians and we see these patients. And this was, Shripal just presented this, it just came out literally last month. They looked at a subset of patients who were in normotensive shock in this intermediate risk group of FLASH trial. So seemingly patients who we would have thought are doing okay, but when we went in and did right heart caths on them, their cardiac indices were pretty low, of less than 2.2%. So they were about 35% of these patients who we thought were intermediate low risk and or intermediate risk, and they were actually in shock. So then they came up with this score, just for you guys to look at and just have in the back of your mind when we are assessing or evaluating these patients, just to look at them outside of just their blood pressure and heart rate, just to look at the whole picture. If they're tachycardic, if they have a concomitant proximal DVT, if it's a saddle PE, if their RV is looking not great, if they're elevated BNP and TROP, that basically means the RV is suffering. So, and patients who who got thrombectomy and who got, who were treated in this subset of patients, they actually did very well. Their, PA pressures improved, their cardiac indices improved. They just published this article, and with that, there came this wonderful editorial, and basically talking about if there's a paradigm shift happening in the treatment of PEs, and it's probably prime time for that. And I think I'm running over time, but I do want to mention that ECMO also has a role, and we have started, using it. We are concurrently with our surgical colleagues. In many cases, either we will use it preemptively for high risk or patients who are at the verge of hemodynamic deterioration, or we will have them on backup because ECMO basically reverses all of the changes of that the RV is suffering during that RV spiral shock. And these are some of the other devices. We can use RV Impella, Tandem Heart, VV ECMO, and VA ECMO if you need both oxygenation and hemodynamic support. And this is MGH's data. They showed that between pre and post ECMO data, ECMO era, there was a significant improvement in the mortality of these patients with the use of ECMO. And this is Texas Heart's data also showing similar improvement in mortality. And this is some of the, obviously we don't put ECMO in everybody. Obviously, we cannot put an ECMO in somebody who we cannot decannulate. So some of the contraindications to think about before we go that route. And the last thing that I do want to mention is that, and this is an ongoing thing for us as well, and we're actively together working on it, is the development of Paryt teams. And it's also a class 2A indication according to those ESC guidelines, and, just basically working in conjunction with all the subspecialties and all these smart people here. And that's basically it. And this is our Paryt activation algorithm. That's all I got.
Okay, I have personally many questions, but I think in the interest of getting everybody out at 5, what we'll do is kind of go through the talks, and then we'll save time at the end, hopefully for the. Now, do you have a case presentation?
I do have a couple of cases. If you guys can.
Maybe if we could just do one case and then
sure, absolutely.
move on.
Yeah. That's good. All right, so real quick, 59-year-old female with your usual risk factors, obesity, who came into the ER with acute onset of palpitations, chest discomfort, dyspnea. This was her EKG. Most of these patients, interestingly enough, are presented because their tropes are elevated. Our cardiology fellows end up seeing them, do an echo at bedside, have an RV dilatation, and it's a very convoluted way of diagnosing a PE, but regardless. Normal chest X-ray, and this is quickly going through their scan. As you can see, pretty significant proximal thrombi bilaterally. So RV, as you can see, in both the 4-chamber and the parasternal long, RV is hypokinetic as well as dilated. Okay, sorry. So basically, her tropes were elevated, her RV was dysfunctional. We decided, a Paryt team convened over the phone, and we decided to take her to the cath lab. She was young and she had proximal clots and intermediate high risk patient. So, okay, how does this work? Okay, sorry. So this was her left side, just a pulmonary angiogram of the left and of the right side. As you can see, lots of clot. Okay. I think I don't know how to turn this to next slide. Okay, got it. Yeah. So basically, we went in with a 24 French Inari catheter. We did several pulls, basically 3 suctions on the right side, and essentially got a bunch of clot. And similarly on the left side as well, On the left side, it was a little bit more complicated. And, as you can see, there's not significant perfusion in the left lower lobe. So we had to use some tricks. We went in with, we had to use a mother and child technique. We used a 20 French inside of a 24 French. And then we also had to eventually use discs, which kind of, this is the 20 French inside of the 24 French. So this gives us a distal reach. And then we still felt there was more quad to be got. So then we went ahead and went with these discs that help us to extract more quad. I don't know if I have those or not. Yeah, as you can see, there's still more residual quad. And these are the discs. It's the FT12 discs, which basically literally just helps to scrape the clot out if there's any, if there's some chronicity to it, just helps to scrape it out. Say that again. I mean, it's sometimes we just suck and you can just see like a cast of vein comes out. Sometimes it's like a jello-like clot. Other times you literally feel like you've taken a fibrotic material out, and sometimes it's a mixed picture. The ones that are chronic, especially like if you have higher pulmonary systolic pressures more than 70, then you know that there's some chronicity to it. So then those are not that easy to remove. Yeah, every so often we don't get much, and then I send them to Jamil. So yeah, then this is this is after all of that. So pretty good distal perfusion, and this is what we got. And these were her pressures. It was a significant improvement in the in the PS systolics, went from 54 to 30. The mean went from 28 to 20, and she did well. She recovered. She was discharged on Eliquis, and I actually saw her in clinic. She's doing very well. I have another case, but I think we don't have time for that.
Yeah, that was amazing. Thank you for showing us that. So I think what we'll do is just kind of run through these, save your questions for the end, and hopefully we'll be able to have some good discussion here.
Slide. That's why you started the PERT protocol at Island.
Yes. So it's basically we are prime time in Byler, and here also I've been getting PERT consults from pulmonary folks. So basically we're doing cases at both places. Yes. Yeah. But at Byler, like we have EDs on board, pharmas on board.
Okay, so we're going to switch gears just for a second. I promise we'll go back to the cool stuff, but I wanted to talk a little bit about PAH drugs, not so much about this slide, where, these are things that you may or may not have heard about as far as the classic pathways of treating PAH. I want to talk about just focus on two of the most exciting drugs that are coming up. And Dr. Madan touched on this, but basically, all our therapies, this is kind of the complex pathophysiology that we know about for PAH. You have a normal pulmonary artery right here. And then when the maladaptive processes happen, you have vasoconstriction, fibroblasts, inflammation, hypertrophy. This is it. This is all we're targeting with all our medicines. So I won't go into the details of, our 14 different therapies, but they all focus on doing this one thing, and that's to block this vasoconstriction pathway. Here's another way that we can display this, but we have these three major pathways, and no matter what drug you give, the end result is calcium handling and basically altering calcium reuptake to allow for smooth muscle relaxation. All our drugs do the same thing in the end of the day. So all roads lead to this. So not surprisingly, this is not it for us. This is not the way out of this horrible mortality and morbidity. So I want to talk just briefly on two major drugs coming out in the next couple of years, hopefully. So Tadalafil is scheduled to launch sometime early next year. It deals with BMPR2, and we have imatinib and seralutinib coming out probably in the next 2 years. We'll talk a little bit about each of those. So Tadalafil, this is kind of the hottest thing, in all the PH talks now. So what it does, there's a delicate balance between anti-proliferation and pro-proliferation within the smooth muscle cells. So BMPR2, which is associated with development of pulmonary hypertension, is a loss of function mutation. So basically, you lose your ability to anti-proliferate. So what you have is an excess of the pro-proliferation signal. So that's what leads to the smooth muscle hypertrophy. It's in about 70% of the genetic cases and even about 30% of the idiopathic, but it's one of these strongly implicated mechanisms in the development of smooth muscle hypertrophy. So what sotatercept does is it works through this pathway to upregulate the pro-proliferation pathway and sort of just reverse the balance of block the pro-proliferation pathway. So it works more towards restoring the normal homeostasis and in fact, promoting more anti-proliferative effect by means of blocking the pro-proliferation effect. So it's a very novel mechanism, does not deal with vasodilation or vasoconstriction, and is basically a reverse remodeling agent for the pulmonary vasculature. So this is the big landmark trial that was published earlier this year, looking at sotatercept sub-Q every 3 weeks. Now, the one thing to point out here is this was a sick group. They were 40% on IV prostacyclins. And what they were able to show that in this very sick group of people, there was a very significant improvement in 6-minute walk distance, about 40 meters, which, you know, as you guys learned from the heart failure literature is quite significant. And more importantly, the Kaplan-Meier curve show the time to clinical worsening or death was much better with sotatercept compared to placebo. So exciting for us as that this is the newest mechanism. We have some incremental benefit, and not to even mention this, but the PVR decrease with sotatercept was something like 3 or 4 Wood units. So it was a very impressive PVR decrease, as well as hard clinical outcomes that we can relate to our patients going through the completely different pathway. Of course, there was adverse events. So paradoxically, increased the hemoglobin level, yet more bleeding events. Unclear how this happens. But epistaxis, dizziness was common, and bleeding events were common, although not significant. Okay, so briefly, the imatinib and seralutinib mechanisms. This works more with vascular remodeling. This is the phosphorylated form of the platelet-derived growth factor. When it's phosphorylated, it causes this smooth muscle hypertrophy. The vessel looks thick. So what imatinib does, which is an oral tyrosine, basically a PDGF blocker, it dephosphorylates this and reverse remodels the pulmonary vasculature. The problem was in 2013, they did a phase 3 trial, and it was very impressive PVR decrease, about 6 Wood units, but an unacceptably high rate of subdural bleeds. So this trial was stopped, and the drug was abandoned for many years until seralutinib, which is inhaled form of this. So it has greater efficacy than imatinib, and actually the preclinical trials which show greater PVR decrease, and we're not seeing that systemic effect of increased bleeding events. So there's an ongoing phase 2 trial now, and this is probably the most exciting thing for us, that finally we're at a point where we're all the way over here. We're just working with the imbalance of vasoconstriction and vasodilation, but we're actually touching the surface on all the other mechanisms at this point. And there's a lot of exciting things happening over the next couple of years. And I just wanted to point out, you guys heard about the Sereno trial that we're doing here that deals with this epigenetic dysregulation and using an old drug, valproic acid, as a rebranded purpose to look at, with strong anti-fibrotic effects, as well as this epigenetic modification effect of this, which can really hopefully change the trajectory of the disease outside of the box of anything we have so far. That's all I want to say about pulmonary hypertension. Let's get back to the cool stuff, and we'll have Dr. Borgi tell us about some PTEs.
Not this one.
So Paryt just a couple weeks ago.
It's not yet approved completely. It's going through the fast track phase, but they're ready for, they're giving us a date for 2024 as a rollout, basically global or early 2024.
All right. Along the same spectrum of discussion, I'll try to talk about cool stuff. I was asked to discuss the surgical treatment of chronic thromboembolic pulmonary hypertension. I have nothing to disclose related to this topic, but I'll cruise quickly through it quickly, and then I'll discuss treatment options. As you all know, this is the CTEPH belongs to Group 4 pulmonary hypertension, according to the WHO classification. It is defined by thromboembolic occlusion of the distal and proximal pulmonary vasculature. Now, to label someone as having CTEPH, they have to have pulmonary hypertension, meaning that they have to have a mean pulmonary artery pressure above 25 millimeter of mercury, associated with a low wedge under 15 millimeter of mercury. But they also have to have a mismatch on the VQ scan, showing at least one large perfusion defect in one segment or two subsegments, or evidence of vascular lesions on CT, pulmonary imaging, MRI, or pulmonary angiography. And this should be proven after at least 3 months of anticoagulation in order to differentiate this entity from the more common acute pulmonary embolus. A little bit about epidemiology. Dr. Kalik discussed the prevalence of acute PE, which, according to her, it's 1 million per year. Supposedly, 3% of those patients should develop chronic thromboembolic pulmonary hypertension, which gives you an estimate of around 3,000 cases of CTEPH generated every year. However, much less than these numbers are being diagnosed and treated definitely by surgery, which gives you an idea about the underdiagnosis or misdiagnosis of this disease. A few words about the pathophysiology. There are multiple theories, but the most accepted theory is basically a fibrotic transformation of the unresolved pulmonary emboli with distal stasis and thrombosis, leading to increased pulmonary resistance and pulmonary pressure. In turn, and this in itself will lead to increased stress on the wall. And back to the pathways that Dr. Murthy was discussing, will lead to muscularization and hypertrophy of the arterial wall. So basically, it's a transformation from a proximal large bore artery disease to more distal microvasculature. And it's important to be able to treat this disease when it's still proximal and not distal. Quickly about the presentation. Again, this is a very frequently misdiagnosed or underdiagnosed entity because of paucity of symptoms in the beginning. And it's documented that it takes around 14 months between the initial PE and the development of symptoms of CTEPH. But basically, symptoms are those of right heart failure with ascites, lower extremity edema, fatigue, exercise intolerance, and then it progresses to lightheadedness, presyncope, and syncope, which are ominous signs of end-stage disease, and arrhythmia and sudden cardiac death. Now, historically, and dating back to 1980s, it was shown that patients with this disease, or the typical progression, is that to a more aggressive right heart failure and death. And the mortality is really associated with the degree of pulmonary hypertension, with the survival as low as 20% at 2 years when pulmonary artery mean pressure is above 50 millimeter of mercury. Also, studies from some time ago showed that patients who are treated with anticoagulation, which is the basic accepted treatment for acute PE, also progressed to end-stage disease and death with a 3-year survival as low as 30% when the mean pulmonary artery pressure is more than 30%. So it was accepted back in those days that medical therapy is not curative and the effect is relatively modest, and that the surgery, which was shown to be virtually curative, is the only definitive therapy for CTEPH. So there was never a head-to-head study or a randomized controlled trial comparing pulmonary endarterectomy, which is the surgery for chronic thromboembolic pulmonary hypertension, with any kind of medical therapy. But the best level of evidence we have is from prospective international registry data. And in this one published in Circulation in 2016, where around 679 patients were followed. 404 received pulmonary endarterectomy versus 275, which received best medical therapy for multiple reasons. And it showed a clear survival benefit in favor of surgery, where survival was around 90% at 4 years compared to around 60% for best medical therapy. It also showed that those who received the best medical therapy, those who received pulmonary endarterectomy, they looked at those and they found out that those who received bridging therapy compared to those who did not receive any bridging therapy did not have any survival difference, with a trend toward better outcomes for those who did not receive bridging therapy. And the explanation for that was that patients who received bridging therapy got delay in their definitive treatment, which is surgery. Also, for those who received medical therapy or did not receive surgery, those who did not receive any kind of medical therapy other than anticoagulation did the same as those receiving any kind of medical therapy. So again and again, surgery is considered to be the gold standard treatment for this. And in the most recent guidelines from European Society of Cardiology, it is considered the treatment option with class 1 evidence. However, other treatment options like medical therapy and balloon pulmonary angioplasty, which I'll talk about briefly, are considered class 1 evidence for the recommendation for patients who did not meet the criteria for surgery or were not considered surgical candidates, or those who had persistent or recurrent pulmonary hypertension after surgery. So balloon pulmonary angioplasty, and I hope Dr. Kalik will pick up on this, will adopt this technique soon. For us here is a complex and tedious procedure, really that started with multiple morbidities and mortalities in the initial trials, but becoming more efficient with new technology. It consists about dilating the webs and obstruction and restoring flow into the smaller arterial branches. And as I said, it's reserved for patients who do not meet the criteria for surgical treatment, or patients who fail surgical treatment or redevelop pulmonary hypertension afterwards. So now there's multiple discussion or multiple talks about dividing patients between those who have disease in the proximal arteries, and those for those surgical therapy is obviously indicated, as compared to those who have more distal disease, where a balloon pulmonary angioplasty may have a role, versus those with microvascular disease, where medical therapy is the only option. And obviously, if everything fails, double lung transplantation is the last resort for patients who are not candidate for any kind of the above therapies mentioned. So what is thromboendarterectomy, and how do we select patients for that? So the purpose of the evaluation initially is to first prove that the patient has CTEPH, to identify where the burden of disease is in terms of proximal versus distal disease, and also to prove that the burden of disease, if removed, will lead to a significant drop in PVR. And this is probably the most tricky part. In the world of CTAF surgery, there is a Jameson classification, which came from Dr. Jameson, who was a pioneer in pulmonary endarterectomy in San Diego, and classified the disease into 4 types. Type 1, basically, in the main pulmonary artery. Type 2 in the lobar branches. Type 3 in the segmental and subsegmental branches. And type 4 is in the very distal arterioles. Echocardiogram is one of the studies that we obviously do, but usually patients come with this as the first diagnostic mechanism. And different, as opposed to acute PE, you will see a hypertrophied right ventricle with what we call a D-shaped ventricle that is enlarged. Also, we see enlargement of the right atrium and a collapsed LV. It also gives you an idea about the presence of PFO that we generally close during the procedure. And most patients will have some degree of tricuspid regurgitation secondary to dilation and pressure overload. VQ scan, also not frequently used as it's supposed to be used, is a test with a high sensitivity and specificity, and is usually considered one of the best screening tests. And in that, you'll see segmental and subsegmental defect, perfusion defect, that will lead you to the diagnosis of CTAF. Pulmonary angiogram, Sasha will tell you how difficult this is, but to actually perform and to interpret. But characteristics of CTAF on pulmonary angiogram include pouch defects, webs and bands, abrupt narrowing or occlusion of vessels, loss of peripheral arborization, and delayed filling of segmental and subsegmental vessels and zones of the lung. And the images here, the one on the top left is a normal angiogram, as opposed to the one in the top right with a, I would say, stage 2 to 3, CTAF. The one on the bottom is peripheral disease. As you can see, there is a loss of peripheral arborization or a peripheral perfusion, and a patient as such is not considered a surgical candidate. Other studies that we do are right heart cath and a left heart cath, just to right heart cath, obviously to identify the hemodynamics and the amount of pulmonary vascular resistance that the patient has. Left heart cath to understand any kind of concomitant coronary artery disease. PFTs are typically low normal, and ABGs can be normal in this disease. CT scan are getting better at diagnosing CTAF, and we rely on them to understand the proximity of disease, like the picture you're seeing here with a big thrombus in the proximal pulmonary artery. And it also can show recanalization, like the one you're seeing in this picture, and what we call mosaic pattern of perfusion, which is the result of differential perfusion. So speaking a bit about the surgical technique, so this is different than surgery that is performed for acute pulmonary embolus, which is much, much easier. This operation requires opening the chest and putting the patient on cardiopulmonary bypass, accessing the pulmonary artery and opening it, as you can see in this picture. But it also requires creating a plane between the subintimal plane. So basically, you're resecting part of the artery which became hypertrophied secondary to chronic disease, and following it all the way to the peripheral branches, carving all the clots and the endothelium with it. And this is why it is considered a very difficult operation. It also requires cooling the patient all the way to 18 degrees Celsius and stopping the circulation in order to obtain visualization of the distal arteries. And this is the kind of specimen that we remove, which, as you can see, is difference from the clots that were shown in acute PE situation. And you know that you did a good job when you get to the distal branches and you see tethering of the ends of the specimen. So what is considered acceptable outcomes? Centers of excellence and obviously surgeon and center experience matter, and what is accepted is less than 5% 30-day mortality. It has been shown again and again that hemodynamic profile normalize in the vast majority of patients with normalization of PVR, normalization of pulmonary artery pressure, improvement in the functional status as shown by the 6-minute walk, improvement in the NYHA class and quality of life indicators, and also RV reverse modeling. And I hope Dr. Murthy has a case to show that. Most common cause for mortality is unrelieved pulmonary hypertension, either from an incomplete resection of the specimen or from really microvascular disease that was unidentified before surgery. We also worry about obviously bleeding and pulmonary edema, which is something that we face all the time or frequently or worry about all the time, which is the result of reperfusing an area that was chronically deprived of blood. We use ECMO for rescue when necessary. And in the ICU, the job of the intensivist is probably even more difficult than the job of the surgeon, is to care for these patients and try to minimize pulmonary vascular resistance as much as possible, usually by avoiding any hypercarbia or hypoxia. We administer nitric oxide for all of these patients. We try to avoid inotropes so that to avoid flooding of the lung with or pumping a newly opened lung. We attempt at early extubation, but the majority of these patients remain intubated for more than 2 days. We try to keep them dry with diuresis, and we start anticoagulation as early as 12 hours after surgery. And with that, I will stop my talk.
Make it sound so easy. I'm going to put all of that in about 5 slides of all your hard work in the OR. Okay, so I just wanted to show you this case that Dr. Borgi did last year, a couple months ago maybe. Okay. All right, we're going to, a lot of this, you know, he talked about, so we'll skim through the history, 46-year-old young woman. So, and other than smoking and fibroids, which is important because of the hormones that they usually get to stop the bleeding, had a PE in 2021. This is late 2022. Also had a DVT at that time. She was on apixaban. She comes in complaining of worsening hypoxia, shortness of breath. She needed a high flow nasal cannula, admitted to the heart failure service. And here's her echocardiogram. What's fairly obvious is that the right side is dilated. And this is that D-shaped septum that Dr. Borgi was talking about, the TR velocity. I'm sorry, this doesn't really translate, but it's over 4 meters per second. So, which is basically, you know, about a PASP of about 70 or 80. That's important because it's not an acute phenomenon. I wanted to show you a couple CT still images. This is that mosaicism that Dr. Borgi was talking about, where you see this kind of, it almost looks like regional edema. In addition, the CT scan is invaluable for looking at the right side, from RV to LV dimension. Here you see the right side, confirming what we saw in echo. You're starting to see issues with this left lower lobe here. And then, you know, on the CT imaging, what you see is these, it's hard to translate here, but you see the left lower lobe has some webs forming here, even on the right middle lobe up here. And the pulmonary angiogram, I didn't do the whole cine for you, but what I wanted to show you, and this was probably the clearest shot, is that we see normal vascular tone, vessels, pardon me, in the left upper lobe. But when we look at the left lower lobes, what we see is this paucity of vessels, paucity of filling. You see this dilated vessels and an abrupt tapering to nothing, basically. So there's big problems here with the left lower lobe. Also with the right, this is more obvious, where you see the right middle is basically missing. The right upper is filling weakly, also a problem. And just to put it in perspective, this is a normal, healthy pulmonary angiogram of the right side. So we have disease on the right, we have disease on the left. Right heart catheterization, severe pulmonary hypertension. We have a mean PA of 52, an RA of 12, an index of 1.8, the wedge 15 to 20, which does not explain this level of elevated pulmonary pressure, PVR of 9.7, all pointing to a chronic pulmonary hypertension process. You cannot make pressures like this acutely. In addition, we do everything else just to be sure. Autoimmune was negative, hypercoagulable panel is negative. The VQ scan is integral to this, where this is normal homogeneous ventilation, and comparing it with the perfusion in the second and fourth column, what we see is patchy areas of perfusion with a relatively homogeneous ventilation. So that's the so-called VQ mismatch that, again, is 99% sensitive for PE if you have a normal, for chronic PE rather. So if you have a normal VQ scan, you do not have CTEPH. So we always have three options for some reason. We have medical therapy, surgery, and percutaneous balloon angioplasty. Let me just go through quickly. Riociguat, only for inoperable patients. You get maybe a 40 millimeters more on a 6-minute walk test, but this is not the drug to change the disease. Percutaneous balloon angioplasty, Dr. Borgi showed you some pictures, but this is highly done and should be done in specialized centers with a lot of experience. There's a high complication rate. The mortality after this is about 3%, which is equivalent to surgery. We're still dealing with the same issues, reperfusion injury, reperfusion edema rather, vascular injury. It's not there yet, but it is a very promising tool that maybe in the next 10, 20 years we can talk about as a reasonable alternative. But right now it's not quite there. So this is this particular patient's case. I want to point out to you the starting PA pressures, 103/44, and you can even see Dr. Borgi in the background here in the reflection. And then, about 40 minutes later, no, I'm just kidding. It's probably longer than that. But we see that this must be the most satisfying thing to see in the OR, where you see an initial pressure of 103/44. Now we're ending this case after a wonderfully done thromboendarterectomy to 45/21. So you're dramatically improving this while maintaining the blood pressure. So this is a really great result in what we expect and why it's the only curative issue here, curative option here. So first line approach PTE made it look so easy, but there it is. This was actually the patient's thromboendarterectomy, and this is basically the endothelial layer of the pulmonary artery being denuded. This is not clot, so this is a very nice result. And 6 months post PTE, we see that septum is back to normal. The RV is back to normal, maybe slightly dilated, but it was actually read as a normal echo. You wouldn't have known. And the TR velocity is not there. Okay. I think that, 10 minutes after 5, not bad. We wrapped everything up relatively quickly. So if anybody has any burning questions, we'd be happy to entertain it. We have also Dr. Mansour here, who's the director of our pulmonary transplant program and is an advanced pulmonologist and is brave enough to sit here with a bunch of cardiology and cardiothoracic surgeons.
I have a few questions for all of you.
Yeah.
So thank you for all these talks. They're very informative. So is the pulmonary angiogram a standard of care after doing these interventional procedures for pulmonary emboli? Because I've seen some other interventional procedures that don't do that.
So, oh my God, yeah. So yes, so mostly because to see that, we are there with pretty stiff wires, and as you saw, like the catheters are huge, they're like 24 French. So mostly to see that you haven't caused any damage and also to look at the result. Sometimes the clot dislocates, it'll go to another lobe that loses perfusion altogether, and maybe you have to chase after that. So basically for that, to just basically to make sure you don't have any complications and also to look at the result. And I do routinely do them. And most of the people that I know routinely do a completion angiogram. Many people don't do a starting angiogram, especially the CTs, if they're recent, like if they're within 1 or 2 days, they're so reliable that you can just base your treatment off of a CT. But most of the people that I know do a completion angiogram.
Ali, also there's a difference between interventional and surgery, because in surgery you never look mitral valve is perfect.
Is there a cutoff BMI for your?
No,
for
actually.
ECMO, there is. After a certain BMI, you cannot go on ECMO. So I'm just wondering, just take any BMI?
Yes, actually, it's interesting. I have had patients with a BMI of 55, but because it's so interesting, especially the young people. One of their main risk factors is they were an obese patient who just got sick with a flu or a cold, and then they were homebound for a couple of days. No other risk factors. I've had young 30s, 40-year-olds with this presentation and with very high BMIs. So seems to be that's the usual population. So no, I don't have a cutoff.
So that brings me to my next, just a segue to that is what do you, in the middle of the night when you get called for an acute PE, is there anything that you could hear that would make you not want to offer catheter-directed therapy or, mechanical thrombectomy?
So if they're low risk, if they're yes,
risk, yeah.
If their vitals are stone cold normal, they're satting 99% on 2 meters, their heart rates are low. So one is that, and the second is if last night actually I just got called about somebody who had a intermediate low risk, I think, but they had metastatic cancer with unknown primary and including brain mets. So I did not take
futility.
Them. Yes, futility basically. Yes.
First, thank you, Asma, for taking on the responsibility of being the first responder for all the acute PE calls. This, I'm sure, is not an easy task. Second, the first generation of these devices, and I remember Angiovac was one of them, they were criticized by the fact that they were not capable of removing clots from distant vasculature. That's number one. Also, they caused somehow trashing of the distal vasculature with the fragments of PE. Is this something you're seeing with the new technology or something that doesn't exist anymore? And my second question, do you see any remaining role for surgery for these patients, for any patients with acute PE?
So let me answer the first one. So the second generation devices, they're actually very, very good. So I have not used Angiovac for PE per se, but I've used it for clot in transit. And to be honest with you, they don't even have a real PE indication anymore. They have their new iteration, which is called an AlphaVac, which doesn't require a circuit. So, and it's a little bit more flexible. So that's the one they now are using also on just a trial basis. It's only a part of the trial right now. But then the other two devices we have right now, they're actually, they're pretty good. They're flexible, even they go up very tortuous, big dilated right hearts and right pulmonary arteries, which sometimes can be very tricky to take devices to. The part about, distal embolization after fragmentation of clot, that we still see. I mean, that's just the nature of the pathology more than so much related to the device. So, but there has been a little bit of a paradigm shift in how we treat PE now. So initially when I began this, which was 4 years back, we used to go after every little nook and cranny and try to get every little piece of clot. Now the way we do it is we try to get most of the proximal clot and make sure that all the lobes have perfusion. And so that, and along with if there's improvement in hemodynamics, your SATs improve, your heart rate drops, and then we check the pressures quickly if those are good, because the rest of it we know is going to be cleared by, with anticoagulation, and body's own lytic system would come into play. So we don't worry that much about it. If there's a little bit of dyslembolization, we don't make ourselves crazy over that. And then regarding the role for surgical embolectomy and acute PE. So in my own experience, I mean, the devices have gotten so good that, for someone to get a sternotomy, I think we should have failed percutaneous embolectomy, especially even in the high risk ones. We do them in conjunction with ECMO first, and then either we do, embolectomy the same day or the next day. If in those cases we fail, or if there's a lot of residual clot, I would say those would be the cases. But I don't think, at least in my opinion, I don't know if you have different opinion about that.
Well, classically, there has been a lot of resistance from surgeons to operate on acute PE. They initially, the thinking was patients are too good for surgery and they will be okay with anticoagulation, or too sick for surgery because they are dying. But I've done a few pulmonary embolectomy, or what is called the Trendelenburg procedure. And the results are very actually rewarding, and because you will be able to remove the clots easily. They're not chronic, and you can flush the lung backwards and remove everything from distal. But I honestly, I don't know the answer or whether there will still be any role. And I am not sure there will be any study that could be designed in order to compare such a population of patients.
On that note, I think we'll wrap it up. Thank you all for participating. Fantastic talks. And there is wine and cheese somewhere, so.
Let's find it.
I think that there's a big crowd at White Plains and NIAX.
So that they also can hear me. Are we on? Okay, great. Excellent. We're just waiting for our panel. Whoever's on the panel, if you see your name there, why don't you start to sit down? I'm going to give a short introduction and hope that Dr. Ho can make it during that time from the parking lot. He's going to make sure he knows where he needs to come. You know where to come? Are you near? Okay, excellent. Okay, great. Okay, we can start. So thanks everybody for making time this evening. We have had a good day today. We have about 360 people registered for this, but maybe 100 people at Moses the whole day, and then 150 on Zoom. We still have like 80 right now on Zoom, and maybe you saw maybe 40, 50 people in the auditorium. So we're quite happy. It's the first time we're doing this system-wide to also to showcase Montefiore as a health system, and kind of as one example, the heart failure initiative. I don't know if you had time today, but we went through medical therapy of heart failure, a lot of structural heart disease, which we felt was the most important for here. We have heart failure clinic here, as you probably know, once a week now. We're here on Wednesdays. We see patients up there on the 7th floor, and also see inpatient consults. For the next 2 hours, we're going to go over a couple of structural heart failure problems. So why don't you actually, can you change the sequence of talks and make my talk first? Jorde, J-O-R-D-E. Then I might as well get the show on the road here with medical therapy. Get that out of the way, so to speak. Oh, there we are. Okay, you know what? You can stay in the lane actually with Dr. Ho. Dr. Edwin Ho, Director of Structural Imaging at Montefiore. Just came up from the other meeting. Azim Latif, I think everybody knows, Director of Intervention. And we're going to start with Edwin, and Edwin is going to give us an overview over tricuspid and mitral, identifying the lesion or characterizing the lesion.
Okay, and is someone able to start up the slides? Are they? Oh, it's over there. Okay. Can we go back to the beginning? Maybe I touched the wrong button, sorry. Okay, there we go. Okay, so I'm going to try to have a look from the side here so I can sort of see what the next slides are. So thanks for the introduction. So we're going to discuss a series of cases related to structural heart disease as it relates to heart failure, of course. So what the objective over the next about 10, 15 minutes is actually just a little bit of a primer, just so we're all on the same page. So I apologize, it's probably going to be a little bit basic for some of you, but it's really just to make sure that, again, we're all sort of coming into these discussions at the same level. These are my disclosures. And then these are the learning objectives. So of course, it's too short to talk about every single structural lesion or valve lesion. So really going to focus on three. I think some of the cases will go through some of these details as well. First, we'll talk about aortic stenosis, then MR, and then TR. So starting with aortic stenosis. So as most of you know, of course, or all of you know, we care a lot about aortic stenosis because of the impact on prognosis. So in lots of observational studies, we know that definitely severe is bad. And of course, symptomatic severe is very bad. And we also know in observational studies, actually, that even moderate is not exactly as benign as we think it is. So that's what that image on the right actually is, which is from a meta-analysis that our group published with a very large number of patients. And if you look at overall mortality, there's a little bit of a gradient between sort of when you go from mild, moderate, and severe. So we really do think about this valve lesion, even if it's not sort of the classic high gradient severe that we're used to seeing. And then, so I'm just trying to advance this. It seems to be frozen, so let's try from here. There we go. And then, of course, the risk factors for developing significant aortic stenosis, we can divide it between congenital and acquired. Congenital typically, of course, are variants in terms of the actual underlying valve morphology that are usually very obvious from an imaging point of view. And then acquired come from either rheumatic changes or fibrocalcific changes. So I'm still trying to advance here, and neither control is working. There we go. Okay, so just examples of some of the different variants of the aortic valve, of course, in terms of the number of cusps that definitely increase our risk of developing stenosis. And then the next slide is just an example again of some of these acquired changes, of course. And then the other thing that I often highlight is that oftentimes once we acquire significant disease, it can be a little bit hard to tell the underlying morphology. CT can help us a lot, but obviously, once the leaflets become severely calcified and start to fuse, sometimes it's hard to tell what the underlying morphology actually was. So that's where those old studies can really help us. Okay. From a severity point of view, of course, the classic ones that, again, we worry about, we all learn this in medical school and our sort of respective training programs. Definitely the gradient and velocity cutoffs for severe, everyone's familiar with. Those are usually the more straightforward cases. I did want to sort of launch forward and talk a little bit about low flow, low gradient, because that's usually the situation when it becomes a lot trickier and is especially relevant in the setting of heart failure. So we tend to see low flow states, of course, because of different reasons. So either it's because the EF is, of course, low by itself, or the EF can be normal, but the ventricle very small. So then the stroke volume is still very low. Or sometimes it's because of lesions that cause blood to go elsewhere. There's also rare situations where we actually see normal flow, but the flow rate is actually reduced because of the ejection period. And that can also sometimes underestimate gradients. And then that tends to cause, of course, discordant findings from an imaging and evaluation point of view. And then we have to start to troubleshoot troubleshoot and sort of think about what that means for this patient. So usually we're trying to differentiate, of course, between true stenosis and pseudostenosis. So is it, a myocardial or flow problem? Is it an actual valve problem? How do those sort of interact with each other? And then the really important piece, of course, is also just to rule a diagnostic error, because that's oftentimes may also be the situation. So things that we think about, especially in our valve program. So of course, we error check first, make sure it's not a problem just on the echo side of things. We also want to make sure we're really catching the peak gradients. So in terms of the echo evaluation, using non-imaging probe, really optimized imaging planes. And then in some situations, we will use stress echocardiography. So usually we use low dose dobutamine studies. That's particularly helpful when the EF is low in these so-called paradoxical low flow gradient, or in patients with atrial fibrillation, that can be a little bit more challenging. We also often will use invasive gradients in our valve clinic, just as another correlate, so that we sort of understand how we underestimated is something a little bit different than what we expected. And then if it's still very unclear, we can look at really sort of more direct anatomical evaluation. Usually that's done by CT or TE. Planimetry helps, calcium score can help as well. So that is the quick primer on aortic stenosis. I'm just going to advance. Let's move on to mitral regurgitation. So mitral regurgitation, of course, we again care about because of the prognostic implications. So we certainly know that the more severe your MR, of course, is, especially with symptoms, correlates with poor outcomes. And then these slides, most people have seen these graphs before. These are from COAPT. We also know now that treating MR in the right patients actually does help their prognosis, and in multiple dimensions. So if we think about sort of how we look at MR, first I'll look at sort of some TTE views. We usually care first about where the lesion is, and then we think about sort of what the lesion is. And so these views are the ones that I often go to for the where, so the peristernal short and the apical 2, because they really scan across the valve from commissure to commissure. And then once we identify where, then we think about what, and that's usually, of course, at the site of regurgitation, and usually the long axis views are a lot more helpful for that. So most of the time, we can actually already tell exactly what's going on just by the TTE alone. But of course, we will usually still evaluate by TEE, because we usually think about it being high resolution. We can do 3D and everything else. And I did just want to also show that by TTE, with modern equipment, you can actually get really, really good 3D evaluations that are almost TE-like. So these were images that I took just last week, actually, with a new GE system. So moving on to TE, so of course that ended up being our gold standard for imaging of the mitral valve. So we usually look at it first again in 3D, just to give ourselves an overview of what's going on, where that lesion may be, so that we can dig into exactly what that pathology is. And then if we are thinking about sort of how we then look at that in 2D, usually our first go-to view is this intercommissural view, which is the equivalent of sort of an apical 2 chamber, because that again shows us commissure to commissure. So it really helps us identify again that sort of where, and then starts to give us some hints on the what. From that view, what we will usually do is we'll usually biplane across from end to end, just so we have the corresponding long axis views, and then we know exactly, again, what the leaflets look like and the type of pathology it is. So that way we can grade sort of the lesion again, look at severity, and also start thinking about even intervention or therapy. In terms of thinking about that, what is the lesion? So we usually try to divide it into etiology, because that can help us in terms of thinking about potential therapies. So of course we have primary abnormalities and primary MR where there's true leaflet abnormalities. And I usually think of that in terms of either there's excess motion like prolapse, Barlow's type valve, and we also see a lot of patients who have, fibrocalcific changes, and that can contribute. And then when we think about secondary, we usually kind of lump them all together, but in reality, there's lots of different phenotypes of secondary MR as well. So there's annular dilation, or usually this atrial secondary, where we see leaflets coapting very horizontally. And then there's this apical tethering, which is usually more of a ventricular disease and ventricular secondary. Just very brief examples on these different etiologies, especially the secondary ones, since those are most relevant in the context of discussing heart failure cases. Annular dilation, like examples here, again, horizontally coapting leaflets close to the annular plane. And then ventricular type of morphology, which is much more tethered towards the apex, usually because of significant ventricular disease. And that can be symmetric or asymmetric. This is not meant to be exhaustive about severity, but it's just to show that sometimes evaluating severity can be very complex. We use multi-parametric methods to try to decide whether a lesion is actually severe, moderate to severe, or just moderate. And it can be quite challenging in many situations, especially with secondary MR, because they can be discordant. Of course, you're all familiar with PISA. That's our most commonly used method of trying to quantify MR. There are lots of potential errors in this situation, but the reason we still like it is because studies use it and actually correlate it well with outcomes. And studies like COAPT will still use PISA. So even if it may be wrong, it still correlates well with the clinical side of things. A quick just mention about multimodality imaging for the mitral valve. It has become very important for us from just a structural point of view, because we get a lot of anatomic information from the CT, so very detailed measurements of different structures or procedural planning. And then the MRI tends to give us a lot of functional data, especially because we can measure volumes very accurately and evaluate flow, for example, through the aorta or the main PA if we need to understand quantification. Moving on to the last lesion, which is TR, which has become sort of the talk of the town recently in structural, just because of the new things that are happening. So again, we care about it because of prognosis. We know that the more severe the TR is, the worse that it is. We still don't have robust data that treating it is going to rapidly change that. We had a discussion about Triluminate earlier. We know patients feel better, but we haven't proven hard outcome changes just yet. These are just, again, some select images from that Triluminate paper where we know that, again, we can achieve good reduction in a lot of patients and we can achieve good symptom improvement, but that does seem to correlate with how much you're able to actually reduce the TR. When we think about the tricuspid valve, some of you who have tuned in earlier will sort of recognize this. I always like to remind people that, the tricuspid valve is not always 3-leaflet. Most of the time, actually, I find it tends to be more 4-leaflet, but there's a lot of variability. And even within each subtype, the exact morphology and geometry of the valve is highly, highly variable. And so it's really important for us to evaluate that. We have lots of different TTE views that will give us this information. It will tell us morphology. It'll tell us how much tethering there is. It will tell us what the annulus looks like. And we're not going to go into detail, but really it's an underutilized modality, I think, for evaluating the tricuspid valve. We tend to still jump into TEE in most of these situations, just because, again, we're able to do the same type of biplane mapping that I mentioned for the mitral, but there's the equivalent version of that on the tricuspid, which, again, will just show us from commissure to commissure what's actually happening in the valve and what those leaflets look like. Very similar to the mitral valve, we really try to define TR in a very similar way in terms of mechanism. So again, we have the same primary and secondary, but there is an additional category which is really important to think about, and I think we'll talk about it further in the cases today, which is CIED related. And that's really referring to essentially pacemaker at ICD lead related TR. And sometimes it can be highly variable in terms of how that presents. So I just have a couple of examples of that. Before we do that, I want to talk about secondary TR because we see that most often in these heart failure patients. So there's, again, just like mitral, the atrial secondary morphology, which tends to be more annular dilation, atrial dilation. Leaflets close very flat, close to the annular plane. And then there's the ventricular secondary, which you see significant tethering and more of a sort of myocardial disease. Very late stage TR patients can be very confusing because oftentimes the RV is starting to fail and then it can start to look a little bit like both. So it can be tough to tell in those very late stages. Primary TR is, of course, relevant, and we do see in heart failure patients. That's when, of course, we see leaflet abnormalities. In this case, this was an endocarditis case with a partially missing posterior leaflet, and we think about that from a device therapy point of view. But again, thinking about sort of the heart failure patients tends to be a little bit less common. CIED related TR. So this can be really tough to evaluate, but echo really does help us out a lot. This is a TTE example where there was actually lead adherence of the septal leaflet to this pacemaker lead. Sometimes it can be very easily seen by TTE, but sometimes we have to really do modified views and sweeps to be able to understand that perfectly. And it does have some implications on therapy for us. From a severity point of view, this again is coming from our ECHO guidelines, looking at our multi-parametric evaluation for severe TR. A lot of these numbers are kind of borrowed from the left side. There's been sort of less validation on the right side, but we do know, again, the numbers tend to correlate with prognosis. So for the most part, they tend to be quite valid. And of course, the kind of go-to, even though mathematically it's probably incorrect, is actually PISA for quantification of the EROA and the regurgitant volume. A quick additional note about severity. So in many situations, you may see sometimes a report from our valve clinic, for example. We talk about this massive and torrential TR. We kind of joke about it, and sometimes we call it tsunami TR. But it's the reason we subdivide is because we actually know that severe is not always the same as another severe. Really, the valve is so big that you get this very, very wide variability. And this was developed a little bit from a research point of view to help sort of understand these different grades, but it does actually correlate with prognosis. So we do try to quantify into these subgroups as much as we can. And then lastly, I do want to mention RV systolic function again, because it's so important in especially these heart failure patients. And when we're thinking about therapies on the structural side, because different therapies will affect RV function in different ways. So most commonly, we of course will evaluate these longitudinal regional functional parameters. We know these can be severely, significantly affected actually by certain types of valve replacements, for example. So we do really care about them, but there's more to the story. So usually we try to do free wall strain in all of these patients that we see in the valve clinic, just to make sure we're understanding more than just the basal translation, so we can understand a little bit about the longitudinal function of the free wall. And then where we really need to go with this is more three-dimensional evaluation, because it'll give us more of a global evaluation of RV function. A lot of this is still sort of in the early days. It's hard to grade, exact RV function and sort of understand what it means when we see it drop after we intervene on the valve. But I think the more data we have, the more we'll understand moving forward. So that was a little bit of a whirlwind, but hopefully I covered 3 of the valve lesions that are going to be relevant for the discussion moving forward, and 3 of the common ones that we really see in the heart failure population. Thank you.
Any questions for Dr. Ho? We can sit here pretty much. Yeah. Okay, I just needed a few minutes to sit and really take this in. I just have to comment on, for those who don't see this room, what an exceptionally beautiful facility this is that we're in right now. And I'm glad there are about, I think, 40, 50 still at Moses, and we have 80 people on, or 70 on Zoom. And all of this is recorded on YouTube. If you were busy today, you couldn't make it, all the lectures can be viewed later on. So can you bring up my presentation? I was at TVT last week with Dr. Latif and Dr. Ho, and this is what is basically broadcast to, around the country and the world. And Edwin is one of the premier structural imagers, maybe the premier structural imager, I think. Okay, I'm just going to give a quick, how did you run this from here? Okay, quick overview over the medical therapy that is very important in heart failure, probably the most important thing, even though it's much more interesting to look at valves, and why patients, this is the wrong presentation, I think. It should be optimization of medical therapy before interventions, something like that, interventions. Can also talk about AccuSync, but also my name on it. Okay, excellent. So this is about optimization of heart failure therapies in patients undergoing structural interventions. These are my disclosures. And I'm going to focus my comments on secondary or functional lesions, both for the mitral and the tricuspid valve. And I think we understand the mitral valve much better in that we've studied it for a long time, and we all realize that there is a time to intervene. We know when it's too early, we know when it's too late, and we know that we need to be in the right window. There's a lot more to learn for the tricuspid valve. So can you click this to play? Okay, very good. So this is a patient who I saw maybe 2 years ago or 3 years ago at Montefiore. Is 55 years old. He came in with an echocardiogram that even the uninitiated can recognize as severe AV dysfunction, severe MR, and he was on 50 of metoprolol. And the question that we ask is it, how early should we intervene on a lesion like that? And how often do we see this? And we actually looked at this. If you saw 100 patients coming in to White Plains, which would take, I'm going to say, about 2.5 months, you have about 40 heart failure admissions a month with acutely compensated heart failure and an ejection fraction less than 50%. How many of them have at least moderate to severe MR? We don't have the audience response system active, but I'm just going to tell you it's about 20%. How do we know that? We looked back at Montefiore recently and looked at about 2,800 unique heart failure admissions. We excluded some of them for various reasons, but we saw that about 20% of patients admitted with acutely compensated heart failure at the time of decompensation also have more than moderate mitral regurgitation. Half the patients have at least moderate. So you think, oh my God, this is great. There's going to be a lot of clips that we're going to place. But that may not be the answer here. What we also reported, this is in JAHA recently, is that if you have moderate to severe mitral regurgitation at the time of admission, this is a bad prognostic sign looking down the road for heart failure admissions or mortality. So when we see this, we need to pay close attention to these patients. This is 1 in 5 patients coming in with a low ejection fraction and acute decompensated heart failure. We know how functional regurgitation happens. We know that if the patient decompensates, the heart gets bigger, the mitral annulus gets wider, and you develop a dilated annulus, and you then have mitral regurgitation of varying degrees. What we not know so well is if we relieve this, if we relieve the congestion, the mitral regurgitation can actually do better. And we don't know this because we do a lot of Twitter nowadays, but we don't read circulation from the last century, where this was published 25 years ago. It was a nice study by Lynn Warner Stevenson. There were only 14 patients with severe MR that were treated with Lasix and vasodilators. The MR went away, and you can see hemodynamics, of course, acutely improved. We know that very well. But I'm not sure, I didn't really know that they also measured the mitral annulus, that the mitral annulus acutely gets smaller if the patient is treated with diuretics and a vasodilator. And of course, if that happens, the MR will go away. And this actually happens in most patients. So back to my patients that we saw here, about 3 months later, he came in with severe MR, ventricle of 7.3 at 15%, diuresed, got ANI, got a beta blocker and aldactone. And then about 3 months later, the ventricle had gotten smaller, still not normal, 15%, still bad, but the MR was gone. Okay, so now transplant evaluation, maybe, maybe not, maybe just initiate proper medical therapy now that the lesion is gone and the patient has a better blood pressure. And this is not the typical story, but it is a true story. A few months later, the patient was on now appropriate. Today, we would give him an SGLT2 inhibitor, but in 2019, we didn't have that. And you have now what's a normal ejection fraction and essentially no MR. That is why the patients need attention when they come into the hospital and need to be properly diuresed, which doesn't happen in most hospitals, because on average, the patient loses 2 pounds and goes home and remains congested and remains with MR. So we have to be better doing that. We oops, can you go back one slide? Oh, here, I don't know, maybe here. We have, if you want to review this, we just published a paper recently in Circulation Heart Failure, where we go through all the various modalities we have nowadays to improve mitral regurgitation. And first of all, diuretic, underutilized, okay, the oldest drug. But of course, we improve the loading conditions with that. We can also resynchronize the ventricle and do that. We can directly improve angiodilatation. We can treat ischemia, and there will be actual changes to mitral valve leaflets if we remove the mitral regurgitation. But I don't have time to go into detail here. But it's a nice review article written by one of our fellows last year. So why not just fix the valve in the patients that came in? Why give guideline-directed medical therapy? Dr. Ho just showed you the triluminate study, showed you that 95% of patients, the tricuspid lesion normalized essentially, but it didn't impact, at least in the first year, mortality or heart failure hospitalization. It will hopefully do so later. There may be other effects. But medical therapy is shown here. I wrote this almost 20 years ago, just looking at the mortality in patients with class 4 heart failure annualized, how beta blocker ALDO and ACE inhibitors over a time period during the neurohormonal hypothesis time ended about 2001, went from 50% one-year mortality to 11%. This is why you want to put the patient on neurohormonal therapy. And here is a beautiful paper from the Lancet where they said, what if we initiate old style, and we still see this all the time, lisinopril, metoprolol, and aldactone, or this, which is conventional neurohormonal blockade that's practiced by many people, or contemporary neurohormonal blockade, which would be an ARNI, or it's only one ARNI, so I can just say Entresto, and an SGLT2 inhibitor. And what they show in this paper is that if you have a 55-year-old patient who is naive to therapy, if you start them on conventional, old style, community hospital style, or contemporary, right, Montefiore health system style, you will save 8 life years for this patient. If you do a 67-year-old, still 5 years. This is why before I send the patient to Dr. Lateef, who is a good friend, I'm going to make sure that this patient will live longer first. So, and only if they are treated properly, then we can think about interventions. In HFpEF, not so simple, but also evolving SGLT2 inhibitors. You can see here the empagliflozin studies also work, treat 30 patients, treat 30 patients to save a life or hospitalization. These are really altering therapies. HFpEF, now diuretics are indicated. SGLT2 inhibitors and HFpEF are now a 2A recommendation. I think should be a class 1 recommendation for both HFrEF, where it already is, and HFpEF. Everybody should get it for various reasons. But will this therapy, to get back to the title of my talk, affect the tricuspid lesion? And here's something, a paper that Edwin Ho and Azim Lateef and others, and I'm somewhere in the middle, put together and published about just a small case series, not a case report because it's 2 patients, not 1, but it's a small case series where patients came in with severe TR and volume overload. They were then admitted, and the heart failure team helped with that, Dr. Murphy, and we diuresed them, 40, 50 pounds. And we then reassessed their tricuspid lesion, because when they came in, they were not candidates for clip because the coaptation gaps that Dr. Ho showed you before were way too wide. And the tale here is that we were able to diurese them. We were able to reduce the TR from probably torrential to severe, but we were also able to narrow the mitral annulus to a coaptation gap from 9 millimeters to 3 millimeters. And at that point, we can hand the patient over for a clip. And at that point, the patient got a clip. Of course, it's much more relevant to diurese, not somebody you really want to clip and get them there because you missed the boat before, but there are probably many patients where you can just improve the TR with appropriate medical therapy. The other thing we need to do more, and we haven't really started to do this here, but we have the capability, and we should do it more, is right heart catheterization in patients with severe TR to assess the loading conditions. When you think you're done, often you're not done. You need to assess the hemodynamics. We need to identify why is this patient not making urine, And we need to characterize pulmonary hypertension. What type of pulmonary hypertension is this? Is this precapillary? Is this postcapillary? Is this mixed? To then appropriately address the pulmonary hypertension. Why is that? Because appropriate treatment of pulmonary hypertension will lead to a reduction in tricuspid regurgitation, as very nicely shown in this case series. So in conclusion, the assessment of functional regurgitation severity, which Edwin just beautifully showed you how it's done, with the intent of valve repair, should only be made after the patient is medically optimized. Medical optimizations focus on preload, volume status, and also afterload, also recognizing the substantial survival benefit of neurohormonal blockade. And future studies, this is the future, we're about to do this probably in COAP2, where yes, you treat the patient, yes, it went away, yes, Dr. Latif said it had nothing to do, but now we say patient comes back 3 months later and has again severe MRTR. Now, should we have clipped this patient? Should we have done a right heart cath and exercised the patient and identified the patient as at risk for recurrence and then clipped them? I think the answer is yes, but that's something that will be studied in COAP2. And once that, if ever happens, we will certainly be a part of that. So that's setting the stage for a couple of case reports. And I want to invite Mario for a second to say a few words about our great ambitions and how this is better than AHA.
Thank you, Uli. And
no lecture. He's just.
I'm not giving any lectures. I'm certainly here to congratulate you and the organizers of this meeting for putting together a remarkable program and making us forget about the 2 years of COVID that we just endured. It's wonderful to see you all here, and it's wonderful to see not only how our mothership in the Bronx has emerged, but also how we are spreading now throughout Westchester County and a facility such as this. I will maybe remind you that about 12 years ago, I was offered a position to become the chief at Monte, and my boss, who is at one of the large institutions in Manhattan, told me that is a very difficult job that you have. It's something that's going to be very, very challenging. When I came here, I thought that the center of the program that we wanted to build needed to be heart failure. We had very strong programs at the time in interventional cardiology, even in EP. But heart failure, I thought, was the area where we can establish our mark. So we started by building upon heart failure, and we were lucky to recruit Dr. Jordi at the time. And I don't have to convince you of how amazing program he have created. Following that, everything came in place. We had a remarkable electrophysiology program that had been built and has been fed through the heart failure population that we have. As you heard in the lecture this morning from Luigi, he's one of the national leaders, as you already know. Just recently implanted the first artificial intelligence monitoring device in the world. And follow more recently by structural procedures with Dr. Latif, another incredible international leader who have built a remarkable program. And as you heard in the prior lectures, now with a new generation of superstars like Edwin Hall, our next step, which we are now spreading throughout Westchester County, is building our imaging program. You probably know that here at White Plains now we have cardiac MRI available. You will see more advanced imaging being performed here locally. We have programs also all the way to Nyack. And you will see more and more in that area. And I just wanted to say that a few things that I think have been very important to build a program. One is to have great partners in cardiac surgery. And we have here May, and we have Danny, we have Bill, and Steve, I saw over there, which are all remarkable surgeons who have been great partners for our faculty. I think the key is has been building a team around leaders who can articulate a vision and who are driven to succeed, to provide guidance and support, but at the same time preserving their independence, taking pride on their accomplishments of those who are your colleagues, but also believing that everything is possible. And even from the Bronx, we can create something fantastic. And you will see the same thing here at White Plains in this wonderful facility. So congratulations on a wonderful program, Uli, and I would like to continue watching the rest of this great program and lectures today.
Thanks, Mario. Okay, so let's go to some action. We're going to do a couple of cases. We'll start with Dr. Bliagos. And then this is supposed to be really interactive. We'll make that happen. But if you have questions, I'm not sure how closely we can monitor the chat. If there are questions in the chat, can you see them over there? In the audiovisual team? Okay. Let's get your case going.
Okay, great.
See how we can monitor the chat. Can you see it on there? We keep going. 2 milli? Yeah, excellent. Okay, good. We keep going.
Okay.
We'll answer them into the top. We have Dr. Bliagos.
Okay, great. Thank you very much for the opportunity. And thank you to Dr. Latib and his team for letting me present this case. How do I go forward?
You have the controller?
Where is that? Oh, yeah, got it. Yeah. So the clinical history of this patient, 56-year-old man with hypertension, end-stage renal disease, COPD, overweight, had a renal transplant in 2011. His cardiac history has advanced heart failure, multiple readmissions for heart failure, persistent atrial fibrillation. He's on metoprolol, Eliquis for his AFib, amiodarone. And he presented with recurrent heart failure with swelling, fatigue, shortness of breath. So he had an echo, and his echo, baseline echo, showing an ejection fraction of 25%, dilated ventricle, mild to moderate aortic regurgitation, moderate to severe aortic stenosis, severe TR. And his baseline gradient was 40 over low 20s with an aortic valve area of 1. So what do we do next? Anyone want to say what they would do from the audience? Any of our cardiologists want to chime in? Heart failure consult. Excellent. Right heart cath. Okay. The heart failure consult was not done, but a right heart cath was done.
So maybe I can ask a question,
please,
just for discussion, right? I mean, this is a problem we often face. These patients with lowish gradients, their valve areas come as significant. And so maybe I'll ask Mario and then Edwin, I mean, the utility of doing a dobutamine stress echo in this case versus invasive gradients and with a right heart cath.
So, I mean, this patient is, even though I don't see the entire cycle there, the ejection fraction doesn't look to be normal. I'm not sure that it's 25%, but it's clearly depressed. The cavity is not small, so this is the type of patient that are more likely to manifest a contractile reserve if you stimulate it with dobutamine. So I think dobutamine would be reasonable as long as you already know the coronary anatomy and are sure that he doesn't have critical three-vessel or left main disease that would put him at risk for dobutamine.
We're up to left and right heart cath, I think.
Excellent.
So, Edwin, anything to add to that?
Yeah, no, I agree. The other thing that I often look at is also the rhythm, because patients who are in AFib, when you give the dobutamine, it can be very hard to evaluate. Sinus rhythm, this is actually a nice one.
I would schedule this patient for cardioversion, and I will have the opportunity to do TE to check the clot, but to view the valve very well. So I have a TE to look at the valve and restore sinus rhythm, and then reassess with the same TE the valve so that we can move forward to valve intervention if needed, but for sure in sinus.
Actually, I want to make a comment about relevant to atrial fibrillation. So if you have an irregular cycle length on AFib in these patients, post a long pause, the following cycle will give you a potentiation on your contractility, so it can increase the grading, and that's the one that you want to pay attention to.
So post-extrasystolic potentiation, which for those of you who've been around for a while, remember Edmund Sonnenblick, that was something he would talk about every day. Okay, great. We're getting a good flavor of our routine conversations when we have a case like this. So go ahead.
Right. So that's exactly what was done. So the patient did have an invasive study, did not have any obstructive coronary disease. The mean gradient on invasive hemodynamics was 22, and the valve area was reported as approximately 1. The patient also had a dobutamine stress echo, which did show augmentation of the ejection fraction, as well as increase in the aortic valve gradients and a reduction in the valve area to 0.9. The patient was then referred to the structural heart team for evaluation. And
did you show the right heart cath or no? Did I miss that?
No, there was I didn't have the right heart cath. Sorry.
Okay, just checking.
So the heart team met with the patient, and after evaluating their risk factors, the patient's risk factors, was determined that a TAVR was the appropriate method for replacing the valve. The patient had a CTA TAVR to determine the angular dimension of the valve as well as the vasculature. And the team also thought that this was a patient that would potentially benefit from balloon pump support during the intervention, during the TAVR intervention. And the plan was to implant the balloon pump on the left side, on the left common femoral, and use a 26 Sapien 3 valve for the intervention on the right side. So here is the procedure as it was proceeding. You'll notice the balloon pump is inflating at a 1-to-1 ratio, and the valve is being advanced over the stiff wire up the aorta around the arch without really any interaction between the balloon pump and the valve. Which I thought was quite interesting, that this was the balloon pump did not have to be stopped for the valve to be advanced. And as the valve is deployed, the balloon pump augmentation is stopped, and a nice schematic here overlaying the aortic tracings with the balloon pump off, with the aortic tracings with the balloon pump on, and you can see nice diastolic augmentation prior to the TAVR implantation. During TAVR implantation, the balloon pump is stopped, and also there's really no blood pressure as the patient's being rapidly paced and the balloon the balloon valve is being inflated. And then post TAVR implant, you'll notice two things. One is that the patient's systemic blood pressure is dramatically increased from essentially a systolic of 100 up to about 140, as it shows in the diagram. And there is still some a diastolic augmentation of the balloon pump after the TAVR valve is deployed. So this, the patient did very well. The balloon pump was removed at the end of the procedure, and the patient went home 2 days after the procedure without any issues. So some things to consider, that having the balloon pump in place is very useful in case mechanical support is needed during the procedure. The balloon pump can be paused anytime throughout the procedure if there's any suggestion of acute severe aortic regurgitation, if there needs to be a predilatation of the valve prior to the TAVR being implanted. And on the left-hand side, you'll see a nice diagram of how the team thought this through in terms of who could potentially benefit from balloon pump insertion during such a procedure, and using hemodynamics post-TAVR to determine whether or not the balloon pump should stay in after the procedure, if it can be removed. In this case, the patient did very well, had a nice increase in their systolic blood pressure, and hemodynamics improved. And so the balloon pump was taken out. But you can imagine a scenario where if someone is really decompensated, they still remain hypotensive, you can leave the balloon pump in and assist in the intensive care unit with inotropes to wean the balloon pump out over the next day or so. So really a very elegant strategy. And this was published by the team, prophylactic balloon pump insertion for transcatheter valve implantation, and their experience published. So the take-home message here is that TAVR is a life-saving procedure for patients with severe AS, especially those patients with reduced ejection fraction who are at even higher risk for mortality. The balloon pump, this experience, this pilot experience really demonstrates how it's easily feasible to use a balloon pump in case of patients with low EF and severe AS during TAVR, and there's really no issue with the balloon pump and interacting with the procedural device. Thank you very much.
Any questions from Danny? Actually, let me give you the mic. People can hear.
Questions. What happened to the severe TR? If you remember. Number two, same patient, EF of 15. Is there an option for a Impella CP? Is that a feasible option? You think balloon might not be enough? You really want to unload and get the benefit of more loading?
So great questions. The patients, any patient like this with TR comes back to see us in clinic because we have so many options for the TR. So we will, with that severe TR, reevaluate 30 days later, and usually it's still severe, and then we'll try and enroll them in a clinical study for TR since there are no approved devices. When it comes to supporting a patient with a 15% ejection fraction, I think it really depends on a couple of things. I mean, it depends on if they've got severe pulmonary hypertension, do they have aortic regurgitation, and also what their gradients are. So if I have somebody, for example, and we had a couple, especially post-COVID, because they didn't come to the hospital, with 15% ejection fraction and a gradient of 45 mean. There, I'll just try and stick a valve in pretty quickly because that patient will just bounce back, right? The ones that worry me are these low flow, low gradient AS patients who are going to struggle. And so if they've got a lot of AI, I would say if they don't have AI, we might consider ECMO and putting them on temporarily on ECMO, because then there's no interaction with the valve. We have had a couple of maybe just one or two where we've done them on Impella. And so we've had to get
bilateral access and cross the valve twice and literally come around with the valve. And at the time we're ready, pull out the impeller quickly and go with the valve, implant the valve and get them through it. And then maybe recross again and put the impeller back in if they needed the support. But it's become more and more rare. What's been interesting is, the balloon pump we've had it forever, right? The first balloon pump wasn't it at Monte?
Yeah, what's it there?
And contaminants, okay. Okay, so it's become in the interventional community, the balloon pump, this thing that you don't use anymore. Everybody's become so focused on impeller and ECMO, but I think it's still very useful. And so that's why we did this experience, because we had this series of patients with ejection fractions in the low 20s, low flow, low gradient, and we got them through the procedure really well with the balloon pump. And I think what the balloon pump really does is the worst time for this patient is when the valve goes in, because you for a while either pacing them or you're obstructing flow and they struggle to recover. So often what would happen in the past, we'd pace them, put the valve in, we stop pacing and there's no blood pressure. They just don't come back. And then you end up on ECMO or you end up giving them lots of inotropes and vasopressors. So by having the balloon pump there, the minute we stop the pacing, we start up the balloon pump and they just recover so much quicker that it's been, this old device, so-called old device, still being very useful clinically.
Yeah, we discussed that. I'm going to get to you in a second, Joe. We discussed that actually this morning, if you were on, that we just submitted an NIH grant, one of our junior faculty, on balloon pump use in shock. So published a paper, you can identify super responders. So that you put the balloon pump in and the cardiac output goes up by 3 liters. And we just don't know how to identify these patients. So Joe Gonzalez, just from a quick introduction, is our guest speaker from Barcelona. He's the director of the transplant program there and the outgoing president of the Spanish heart failure section of the Spanish Society of Cardiology. And he has a question.
Yeah, great case. I would like to ask what happened to the left ventricular ejection fraction? And you started him obviously on neurohormonal treatments.
Yeah. So, I think the interesting about this patient was the dobutamine stress echo. So they had contractile reserve. And so this patient's ejection fraction improved. It's not normalized, but he went from 25, I think is probably 35, 40 right now. The question is, what do you do with the ones without contractile reserve, right? So say we'd done the dobutamine stress echo and the ejection fraction didn't go up, the cardiac output didn't go up, the gradients didn't go up. Should we do nothing? I think the whole issue of contractile reserve is more important for surgery. So a patient who has no contractile reserve will do very poorly in surgery, but we could still TAVR that patient. There's some data showing that they'll still improve as far as quality of life. How much you're going to increase their mortality, I don't know. And then the other thing we'll often do is work closely with Luigi and his team and make sure they have no indication for CRT afterwards, because the ones who really improve well. So if this patient ends up with a pacemaker, I'm going to push Luigi to immediately do CRT rather than just give him right ventricular pacing, because otherwise they won't recover.
Great, terrific. I think we'll move to the next case. Dr. Ochlani is going to present a mitral case. Yogita is one of our partners in the heart failure group. And actually of particular relevance here is credentialed at White Plains Hospital and is one of 4 of us that come and see patients here and is the director of the sarcoid clinic. Gave a great talk also this morning. So sarcoidosis, don't call anybody but her from our team. If you have a patient with sarcoid, she's really an expert, just gave a state-of-the-art lecture at ACC, I don't know, 3 months ago. But Yogita, take it away.
Thank you, Dr. Yodi. Good evening, everyone. I'm going to talk about a patient of ours that, we are trying to debate advanced heart failure, mitral clip versus LVAD. I want this to be more of a discussion, so feel free to stop me, chime in. I am going to stop and ask questions. This one? All right. And how do I go forward? Just okay.
Green.
Okay. All right. Thank you. All right. So this is the case here. This is a 40-year-old woman who has a history of a non-ischemic cardiomyopathy since 2010. Her EF for the longest time was around 35%. She's been on medical therapy. And for the past year, she's been getting sicker. So she's had multiple hospitalizations. Her EF is now 25%. Her ventricle is about 7.6 centimeters in end diastole, and she has severe functional MR. Her BMI is 37, and her blood type of relevance to transplant cardiologists in the room is blood type O. Her other medical history, she has a history of hypertension. She has this posterior cerebral artery aneurysm, which the neurosurgeons have been following for a few years. It has been stable. And you'll know later why this is of any relevance here. She also has had AVNRT, for which she's had ablation before, has an ICD, and has had 3 prior pregnancies, also of relevance to transplant cardiologists in terms of sensitization status. So she comes to the office now and has had 3 hospitalizations in the past year, complains of declining exercise tolerance, orthopnea, fatigue, and has NYHA class 3 symptoms. Despite all this, she is tolerating a good amount of medical therapy. So she's on very high doses of GDMT, and I can't actually see what's written on the last. On exam here, her blood pressure in the office is 130/90, and she seems I can't. Her end organ function is normal, and she does have the hormone that goes with MR. So this is her transthoracic echo, which shows the dilated ventricle, severe MR. As you see these clips play, her end diastolic dimension for the ventricle is 7.6 centimeters, and systolic dimension is 6.3 centimeters. Let me go back there for a second. How do I go back with the red button? Okay. And of note, she also had CPET, although not very recent, in the past 6 months or so, where her peak VO2 was 14.9, which was 50% of predicted. Her EKG shows normal sinus rhythm and a narrow QRS, and this is just to state that she might not benefit from a CRT device. So we do a TEE to characterize this MR better, and it looks like she has severe functional MR. The posterior leaflet does appear very tethered. Sorry, I'm not sure why this is just progressing without me hitting the button, but so here I want to actually stop and ask everybody, what would you do next? So you have a 40-year-old woman, long-standing cardiomyopathy, dilated ventricle, decline over the past year, severe MR. How should we proceed?
Right, Kath, very good. One of our major teaching points of this meeting, whenever something's wrong,
everybody needs a right.
do right, Kath.
Behind you.
Yeah.
Too high. Do you consider vericiguat or maybe hydralazine and nitrates, just the old style?
Right. That's a great point. And I was actually worried somebody was going to ask me, why don't you just control the blood pressure? But so in reality, this was her blood pressure in the clinic, and you'll see what it was during the right heart cath. But we did try hydralazine. She started feeling dizzy at home. So her blood pressure at home is not always 130. It is probably 130 when she shows up to the clinic because of how anxious she is. But that's a very good point. And that's the reason why also she's on amlodipine, not hydralazine, because she didn't tolerate it at home. So right heart cath, as we wanted. So here her right heart cath numbers. I'm going to lean over to look at them again. So her RA pressure is 8. MAP is 110. Again, she probably didn't take her Entresto that morning and was very anxious about the procedure. RA pressure is 8, PA pressure is 57/23 with a mean of 35, and the wedge pressure was 22 with a V wave to 35. And her cardiac output and index here were pretty low, cardiac index of 1.3, and the PVR comes out to be 5. So based on this right heart cath, she has elevated filling pressures, high afterload, and moderate to severe pulmonary hypertension. Now, we know that this is not a great hemodynamic study to make any decisions on because, there is afterload that you can control. And in order to test that in the cath lab, we decided to do that. We decided to do a nitroprusside study. So her MAP came down to 70, and her RA pressure didn't change a whole lot, but the PA pressures came down, the wedge came down. She still had a significant V wave, and the PVR came down, and the cardiac output and index improved quite a bit. So she had good response to vasodilator therapy, but the challenge with these patients sometimes is you don't know how this translates into the real world when they're at home and they're not tolerating any more vasodilator therapy when you prescribe it to them. So the next question is now, we have a 40-year-old woman, dilated cardiomyopathy, non-ischemic, severe functional MR. We know her hemodynamics. Is she a coapt patient? Does she fit in the coapt criteria? She does have an LV end systolic dimension of less than 7 centimeters. She does have an ejection fraction between 20 and 50. Her RV systolic pressure, after you correct it with vasodilator therapy, is less than 70. She's NYHA class 3, and she is on maximum tolerated guideline-directed medical therapy. So this is the kind of patient where we think a mitral clip might be beneficial, but this is also the patient who's had heart failure for over 10 years with several features that might suggest that she has advanced heart failure. So this is a graphic that demonstrates how the different societies classify advanced heart failure. And if you look at this, this patient of ours does have quite a few features that fall within the definition of advanced heart failure. She has multiple hospitalizations. She has NYHA class 3 symptoms. I think the only thing that doesn't fit is how much medical therapy she's actually tolerating at home. So now we're at a crossroad. Is this truly an advanced heart failure patient? Should we go down the route of mitral clip for functional MR, or should we just consider her for an LVAD or transplant? And I want to pause again and poll the audience and see what everybody here thinks.
Okay, I think this is a great question.
Excellent question.
Who wants to weigh in? Everybody's shy. Oh, Joe. Wait.
I mean, do you have Vericiguat here?
We do. We do. I think we rarely ever use it, but yes. Not on formulary. That's right.
Because that is actually, it's actually a patient that would also fit in the type of patients that, at least from the Victoria trial. But yeah, I mean, with this severe MR, although the ventricle is dilated, I mean, it's worth a try, I think, before going down the LVAD avenue. So yeah, I might give it a try.
All right. So we have one vote for.
Mario had a comment.
One vote for mitral clip.
Mitral clip.
One more drug, and I forgot a little bit about her renal function, but
No.
how about pushing spironolactone to the antihypertensive range therapies, 100, 200 milligrams a day?
That could be done. We didn't do it, but possibly.
It could be done. I think, we tried I mean, I wasn't involved, but I would have given a very cigarette. No. We tried the antihypertensive therapy and she didn't tolerate it. This is a very dilated heart. Patient has severe MR. I have to say that she's tolerating a lot of meds. I would be very hopeful, actually, that if you relieve the loading of the left ventricle, and she can generate a mean arterial pressure of 110 if she doesn't take any meds in the morning because she comes to the cath lab. This patient, if we treat her with antihypertensive further, I think it's just going to keep going like this. And if we clip her, this might be a very good. Why not LVAD right away?
Yeah. So I was going to talk through our options here that we have for this patient. So, for advanced heart failure, we could consider transplant. It's the gold standard treatment for end-stage heart failure. Risks are infection, rejection, malignancy. In her case particularly, it's going to be hard to get her a transplant. One, because her BMI is 37, so she doesn't meet our current criteria. And she might be very sensitized because she has 3 kids. And after all that, even if you were to list her wait time given her blood type and her blood pressure, is going to be a long time. So she's going to continue to remain symptomatic, come to the hospital every few months with decompensated heart failure, like she has for the past 3 months. LVAD, 5-year survival, now parallels transplant. So a pretty good option. She has good anatomy for LVAD, so it can be done. Her PAPI was 4 after you, lower the PVR, you give her a vasodilator. There are risks of bleeding, infection, stroke. In her case, though, she has this posterior cerebral artery aneurysm, which we don't really know what happens to that with a continuous flow device. We did check with neurosurgery. They have no idea. There is no literature on this. And they said, well, you can do cardiac surgery on her, but nobody knows what's going to happen if you leave her on an LVAD for a few years. So, that comes into consideration a little bit. And then the last thing is mitral clip or transcatheter edge-to-edge repair, where, the pros would be, if this works, you might actually buy her more time and make her feel better, and extend her overall lifespan. One possibility is remodeling, but I'm not sure in somebody who's had heart failure for this long a period of time, it's actually going to remodel. You could actually buy her more time, and the risk is just LV afterload mismatch. And what if she goes into progressive LV failure, and then are we ready to have any of these advanced therapy options as backup for her? So we thought about this a lot. We thought, given her hemodynamic profile, she may actually tolerate transcatheter edge-to-edge repair, and decided to go ahead with that. But before we go into her images, I wanted to, talk a little bit about, do we have any data to support this decision making? Do we know, in this advanced heart failure group of patients, how should we approach this, or what happens to them if they get transcatheter edge-to-edge repair? So I'm going to talk about 2 studies. The first one is the MITRA Bridge Registry. This was in Europe, where they had 119 patients. The mean age was 58 years. The mean EF was similar to our patient. The LV dimensions were similar to our patient. Mean PA pressure was 35 and PVR was around 3. And this was a sick group of patients. They had, over 60% had been hospitalized within 6 months prior to the procedure. And about 40% of them actually had required inotropes. But they were Intermax 5/6, just like this lady is. So, in this study, what they saw, and the idea of this mitral clip in these patients was essentially to bridge them to an advanced therapy, which is either make them a candidate for a transplant, which they weren't because of either their social situation or their PVR or something else that precluded, or their wait time was so long for transplant that they needed some sort of a bridging therapy to get them to, stay well in the meantime. And what they saw in this study was that, after they did the transcatheter edge-to-edge repair, about a third of these patients got worse. But there were 7 or 8% of patients who became candidates for transplant because their PVR got better, or they were able to correct their A1C or whatever it was that was precluding them from getting the transplant. But then there were about 20% patients who actually got better, who didn't need the LVAD or the transplant anymore. So there's definitely a population of patients that might benefit from this therapy, and we should talk a little bit more about how to hemodynamically profile them, but we don't understand that very well ourselves right now, and we do it on a case-by-case basis, really. This is just from COAPT. So what do we know from the 5-year follow-up of COAPT? If you just look at panel C on this graph, the thing I want to highlight is, we see the curves diverging, and we see that the patients who got transcatheter edge-to-edge repair do better than the patients who just got GDMT. But even in the patients who got transcatheter edge-to-edge repair, the mortality from any cause was still very high at 5 years. It was still over 50%. And, all that, what I want to highlight by saying that is that the mitral clip here, or transcatheter edge-to-edge repair here in these cases, may not really be an alternative to advanced therapies, but it may be a bridge. I'm not sure why this is just going ahead, but it may actually be a bridge to delay advanced therapies. And this was the case. Sorry.
Go back, John.
Yeah.
Go back one more.
One more.
Okay.
Right. So this is our patient here. So you see to the left, you see the images that show you severe MR. This was the pre-clip. I apologize. I'm not sure what's going on with this, but anyway, so on the left, you see images where you see severe MR. And on the right, you see that her MR improved to mild to moderate. So she had a very good result. To give you follow-up, this is now 3 months post her mitral clip. She continues to tolerate medical therapy. She continues to follow up with the heart failure clinic and is doing quite well. But that said, her EF is still 25%. And there may come a time in the future where she might need advanced therapies, and we'll keep a close eye on her for that. So just to conclude, so transcatheter edge-to-edge repair should be considered in patients who have an EF of over 20%, who have moderate to severe or severe functional MR with symptoms despite optimal medical therapy. It is, however, very important to recognize advanced heart failure in these patients. Advanced heart failure and transcatheter edge-to-edge repair can be tricky together. So it's important to be cognizant of the hemodynamic profile. And I think somebody like her, I think that was a great point where we know she has a blood pressure of 130 and she's tolerating all these medications. So she has some reserve that she may be able to tolerate it. But I think as a community, we need to do a better job of defining, who these patients exactly are. And thinking of the structural therapies more as a bridge rather than an alternative. So it's not really a fork in the road. You're not going down one path or another. You're going down a path the mitral clip may be a pit stop on your way to advanced therapies in the future. That's all I have. Okay.
That was great, Yogita. Any questions? I like the picture of the fork in the road. And then I'm going to go to Steve, because of what you said, it's not really a fork in the road. It's really a stop along the road of a patient. And you have to be ready for the next step if you do a high-risk procedure.
Yeah, that was great, Yogita, and not an uncommon patient that we see. I had two comments. One was that in your mitral clip is a bridge to advanced therapy. 10% of those patients are dying in that data. And because those are patients who it looked like from the data set that they are intended as bridge. Do we know those characteristics of those patients? Number one. And number two, when you offer a patient, you say we have two options. You have LVAD or a much less invasive mitral clip, knowing that LVAD has a superior 5-year survival. If you're to sort of globally compare the two devices, obviously the complications, infection. Do you talk to the patient about the lifetime plan of, we'll start with a clip, then we'll talk about LVAD, then we'll talk about transplant, lay down the next 20 years of what you're going to treat them with?
I think that's a great point, Steve. So, we should talk to the patient in those terms. I think we have to carefully choose the patients we even offer this therapy to. And once we do, we have to know if we have a backup option or not, right? Because the risk of this afterload mismatch and progressive LV failure is real. And so I think, and that's why I think getting advanced heart failure involved, and which is we do a great job of in our system, is to carefully make these decisions together so that, the patient, if you think about the valve therapy, I think it's a great therapy to help extend their lifespan, right? So there was the net quantity of life that we alluded to earlier today. I think prolonging that, it might help. It might buy you more time, fewer symptoms, fewer hospitalizations. But if it doesn't, we have to be ready to do an LVAD or a transplant. And the patient has to be aware of the risk of, this and be ready for that. So I think, we do try to have these discussions with the patients before we go down the track.
Yeah, I think there's some nuances here that you mentioned that I want to make sure everybody understands. Here's a young woman who has a brain aneurysm that Yogita, casually mentioned. There's already been a workup. The neurosurgeon has weighed in and all that, only because the neurosurgeon was called and we said, look, this is what we're going to do, but we may have to go to a surgery where we need cardiopulmonary bypass, either a transplant or an LVAD, or we may have to go to a left ventricular assist device that will induce bleeding diathesis from Willemant deficiency, and we have to give anticoagulation. Is this patient a candidate for that? That's the proper workup. I think you said that. I just want to
Yeah.
reinforce that. The fact that she's a blood type O means that she was overweight also, I think.
Yeah.
This transplant is not going to happen for that reason, or not for a long time, unless she and you know this, I'm just telling this to everybody. And the fact that she's a mother of 3, we know before we do the clip whether she's sensitized. That's not going to happen at most centers that do mitral clips. So I think the great messaging here about patient like that needs to be evaluated comprehensively for all future steps, so that if she crashes, we know what to do. And the patient has learned what we can do if something bad happens. So Azim, you were going to say.
Yeah, no, I just want to talk, I mean, your comment about the mitral bridge data. I don't think the mitral bridge data is reflective of this patient. It was a much older patient group. It actually comes from my previous center. Most of the patients were treated where there was no transplantation in-house and no LVAD in-house. And so that changes a little bit, right? When you work in a center where you can offer mitral clip, but you don't have a heart failure team in-house that can offer also LVAD or transplantation, you try the clip and then you see what happens. I think what's really distinguishes us as a group is the fact that we have all those options on the table in one place. And so we can try and figure out, what's in that patient's lifespan, how are we going to extend their life and decrease their symptoms using the different options, because we have them all available. So I'm a little worried when I see the mitral bridge data that people make a lot of conclusions from a data set that is not reflective of the Monte practice, because most of the centers that don't have an advanced heart failure team.
Okay, great discussion. Let's move to the next case. I don't think I need to introduce Dan Wang here locally, but since we have still maybe 80 people on the internet, I'm going to just say Dan is the director of electrophysiology here at White Plains, and he's going to show us a complicated case of tricuspid regurgitation.
Thanks, Uli. Thanks for the opportunity to share a case with everyone. Thanks for the opportunity to speak at this amazing conference. So the title of my case is RV lead-associated tricuspid regurgitation, repair or replace. This is a little bit of a show and tell, but it's indicative of some of the issues that we deal with daily in EP. So I've started to call CIED or transvenous right ventricular lead, whether pacing or defibrillation lead, associated TR, an inconvenient truth, because the more it's studied, the more we see that it's very prevalent. Of course, this is association and not causation, but there's about a 10 to 30%, 10 to 39% incidence of new or increasing TR after CIED implant. And furthermore, we are learning that moderate to severe TR is not benign, and it's an independent predictor of mortality and heart failure, especially if there's pre-existing or worsening RV dilatation associated with worsening tricuspid valve regurgitation. And what are the mechanisms? Well, they're diverse, multifactorial, and they are, some of them are just hypotheses, but there's been case reports, dramatic case reports of leaflet impingement, of malcoaptation, of perforation of a leaflet, oftentimes a septal leaflet by the lead. Medium to long term, we see fibrosis. And we see that the subvalvular apparatus can be interfered with by the lead. And then furthermore, chronic RV pacing leads to not only left ventricular cardiomyopathy, but in turn can result in tricuspid annular dilatation and worsening TR from that standpoint. And then to make matters worse, even if TR is not acutely worsened at the time of implant, some have reported using echo-guided pacemaker implant just to see that you didn't acutely worsen the TR. Lead-associated TR may develop late. Okay, so here's a patient that we encountered frequently, and this is a 75-year-old woman with permanent AFib, prior stroke with residual deficits, poorly controlled diabetes, and a history of recurrent infections, who was admitted with symptomatic bradycardia in AFib down to the 30s, ultimately requiring a dopamine drip in order to sustain her rates. And so we're consulted. And here's a long axis view showing that at baseline, she's got at least moderate TR. And so more often, the question that I was asked to talk about is, well, what if the lead causes severe TR? What should we do? But a bigger question that we have is, well, what about the much larger denominator of patients who have TR to begin with and are going to need a pacemaker or a defibrillator? What can we do, if anything, to not worsen that natural history? And in this patient, might a transvenous pacemaker lead complicate her candidacy or logistics for future tricuspid valve repair or replacement? Okay. And as we know, sometimes when patients get tricuspid valve repair or replacement, we get lead entrapment against the TV annulus, which oftentimes doesn't hurt the valve itself, but precludes the ability of future transcatheter lead extraction if that's needed. Any comments here on from the audience on what to do about this common scenario? Yes. Micra. Okay, leadless pacemaker. The Micra is something that we are very enthusiastic about. It's a leadless pacemaker, and you don't have a lead that permanently traverses the tricuspid valve. It's implanted deeper in the RV, and this has become very appealing for patients with all kinds of tricuspid valve. Either they've had an intervention or they might need an intervention, and that is what we decided to do. Well, when we say Micra, I'm talking about a leadless pacemaker. It turns out now we have two different commercially available leadless pacemakers. This one happened to be manufactured by Abbott, and it involves putting a 27 French sheath in the femoral vein. And through that, we put our delivery catheter, we give contrast for mapping in the right ventricle, and then you can see the delivery of the leadless pacemaker. Okay, and it's in EP, we're very much, we try to avoid apical pacing as much as we can. And we've been doing that a lot with our Micras. We like to put them high on the septum, sometimes approaching the RV outflow tract. And you can see here, the chest X-ray post-implant, you can see it's not in the apex, it's approaching the RVOT. Oftentimes we'll do pace mapping before we deploy the pacemaker to look for a Q wave in AVL or Q wave in lead 1 to show that we're not apical and that we're septal. So she got a leadless pacemaker. And this is something that we commonly feel is something that is a good option in patients who have TR or have had tricuspid valve interventions. But there's a reason I'm showing you this case report, which is that sometimes we have unintended consequences of good. We have, our good intentions have unintended consequences. And I showed you a pre-image, and what we see is that after the pacemaker was implanted, the TR got much worse. You can see on the left-hand view that there's clearly malcoaptation of the leaflets. This is the RV inflow view. This is in the long axis, and you can see it's really, but just by color, qualitatively, you can appreciate that the TR is significantly worse. On the 4-chamber view, you can actually see this non-apically implanted leadless pacemaker directly interfering with the septal tricuspid valve leaflet. And so this is a case of where implanting a leadless pacemaker actually made things worse. And it not only was the pacemaker hurting the tricuspid valve, but the tricuspid valve was also hurting the pacemaker. How do we know? Well, about 1 million cardiac cycles later, in other words, 10 days later, the patient had loss of capture of pacing, and we saw dislodgement of this leadless pacemaker to the RA-IVC junction. And it's probably the severe TR that prevented it from going into the pulmonary artery. Okay, so thankfully with our very talented colleagues here, we did a team-based approach, and we had 27 French sheaths in the right IJ and 1 in the right femoral vein, and we were able to successfully snare it from below and then recapture it from above. Okay. And then we implanted a new leadless pacemaker more apically. So you can see on the left, that was our initial location, and we decided to implant the new one more apically. The other learning point here is that not all leadless pacemakers are the same. We have 2 FDA-approved manufacturers here, And they're different in thickness and they're different in dimensions. The one that the first one that she was implanted was actually available in Europe for years. It was called the NanoStim at that time, and it's been modified heavily. And this is the Abbott Avir, and it's about 50% longer. It's thinner, but about 50% longer than the other leadless pacemaker, which is the Micra. Okay, so and case in point, it turns out that unfortunately, the after dislodgement, after this is a TEE before the new pacemaker was implanted, the TR remained torrential. So removing the insult did not help the matter here. Okay, so it turns out management of lead-associated TR is complex, and there are quite a few proposed algorithms and decision-making trees on how to manage it, depending on whether the patient has tricuspid annular dilatation, depending on whether the patient has developed severe pulmonary hypertension. But I found these decision-making trees rather unsatisfying because it basically, it leads to either leaving the patient alone, removing the lead, or trying to repair or replace the tricuspid valve. But we lack prospective data to tell us whether removing a tricuspid lead, a transvenous lead, actually will improve the TR. We know there's a strong association with leads and worsening TR, but we don't have a good prospective data on whether removing the insulting factor will improve the TR. Okay, so that's why when we implant these leads, sometimes we find that prevention is greater than treatment, and traditionally we've thought that leadless pacemakers are that prevention. Well, what are our other options for preventing the problem? Here's a patient with severe TR. You can appreciate her right atrial enlargement, where she was undergoing evaluation for tricuspid valve repair, and she developed an indication for a pacemaker. So we opted not to put anything across the tricuspid valve in the first place, put in a bi-V pacing lead through the coronary sinus into an LV branch. So essentially, she's got a right atrial lead, and she's got a left ventricular pacing lead. So this way, she hasn't needed an intervention yet, but if and when the time comes, or Dr. Lateef or whoever else may need to intervene upon her, she'll have a virgin tricuspid valve. Okay. What about avoiding RV pacing altogether? Here's a patient who's had a bioprosthetic tricuspid and mitral valve replacement, who developed symptomatic pauses, sinus bradycardia, and sinus arrest. And she has an implantable loop recorder, and we've seen that she hasn't had any RV pauses. So we implanted a single chamber AAI pacemaker and kept her implantable loop recorder in. And we've been monitoring her for 3 or 4 years now. And we've seen that she hasn't yet developed any indication for RV pacing. And then the final example, here's a patient with permanent AFib with RVR who needed a blatant pace strategy. In him, we did an AV node ablation and implanted a HIS bundle pacemaker. On this TEE, you can see that we're taking advantage of the fact that the AV node is a atrial structure, and that the proximal HIS bundle is also accessible from the atrium without crossing the tricuspid valve. So you can see this 4 French lead in the on the low interatrial septum, and you can see the nice narrow QRS pacing on the right from HIS bundle pacing. You can see that in this case, the lead did not traverse the tricuspid valve. Thanks very much.
That was terrific, Dan. Before we start the discussion, Susan, can you just come up for a second? Just saw that Susan Fox is here, who here needs no introduction, but we have the Moses Auditorium. We have maybe 70 people on Zoom in Nyack. Susan is the CEO of White Plains Hospital, and also for the system in charge of strategic planning. So she just came from a board meeting, making 2 minutes, but we are very happy you get to see us in action. And thanks for just greeting everybody for a minute.
This is very exciting to see all this come together, and very impromptu. I wanted to be here just to be supportive, obviously. Lots more interesting things for you to be looking at. But just to say that as a health system, I think that we're at a point in time where things are really evolving very quickly. And whether it's sitting in this room over the last year with Dr. Jacob Leff and Dr. Bichler and other leaders in the room talking about the new cardiac open heart surgery program, or just sitting here across the board and talking about all of the disciplines within the cardiovascular services, it really is proof of, what we can do together. And I know that there's, everybody is on the camera in their disciplines, and it's really challenging to balance what we do every day and being together. But where there's a will, there's a way. And I think that there's a big will here to work together and bring best practices. I heard you say, right? I listen, I multitask. So may have been on my phone, but I was listening as well. Bring those best practices, elevate the standard of care across the board. And it's just having been part of the health system for 8 years, it's really heartwarming to see this moment come together. And I just thank everybody for being here, taking the time, and for everybody's leadership. And it's really exciting and to be continued. But thank you for the microphone for a few minutes.
Great. Well, thank you for making time. Great. All right, back to tricuspid regurgitation. Any questions for Dan on this? Luigi.
Great case. Yeah, it was great. Just no comment. The comment is more for the panel. Like, he showed 2 provocative cases and all the options there. So there's not much to say. The problem is sometimes when there is a valve that may be corrected with structural or with surgery, sometimes we feel we should implant the pacemaker before and not after. And many times, especially with structural, sometimes post-procedure, the patient will need the pacemaker. So going through that new valve or through that corrected valve, it's even worse than what Dan showed. So can we, what can we do to identify more patients that maybe don't even have a strong indication, but are more likely to benefit from the pacemaker before the valve got, worked out in any way?
Yeah, it's so once again, congratulations on the cases, Dan. But it's a really challenging problem, Luigi and Dan, because when you put the lead there, you take away options for me, all right? Because depending on where the lead's going to end up a few months later, is going to end up in a commissure or not, and the mechanism of the TR, what we can do from a transcatheter option is limited. I mean, Danny Goldstein and Bill, their options are not as much guided by anatomy, because when you open the chest, you have all these options available, whereas transcatheter options are very much dominated by what the anatomy is like. So you take options away from me. So when I get a patient who has a lead in, and I'm trying to think, what am I going to do? Can I do an edge-to-edge repair? Maybe I can, if the lead's away, if the lead is maybe in the posterior septal commissure, where it is very often. But if it's not, and the lead's impinging, okay, then I have 2 options, right? Either it's ask you to do a lead extraction, okay? And some of these patients are 80 years old, the lead's been there 20 years, and it's a challenge. Or it's me jailing the lead with a new valve, and that's okay. But what happens, like you mentioned, if the patient were to get endocarditis, right? We've taken that option of percutaneous lead removal. So it's really challenging. If the patient has TR, if you can not put a lead across and either do the leadless or CS, it gives the patient so many more options.
My point was identifying patient where we can put the leadless pacemaker, not of course with the wire is not a no-go for you, but if we can put it, because many times after you have done your valve, then we need to go with a leadless through an operated valve or through a valve that has been corrected. That is even worse for us, because we don't want to cross with that big French sheet through the valve. So can we create, something where we put the leadless before the leadless, of course, pacemaker before, the valve is replaced? I don't think we do much of this, but I think we can do more.
I think we should do more, Luigi, because if there's a leadless there, it doesn't take away our options. We can pretty much either replace it or repair it, because I can find space next to the leadless to go with the delivery system for a new valve. I think that would be much better than the option we have now, because if you look at some of these valves we put in, their anchoring system is maybe like a row of tines, It's a 27 millimeter valve in the middle. And now you're going to try and cross 2 days later with the 27 French sheath. And the only way to do that safely is with TE, right? So now it makes your job so much harder. So I think it would be great if we could kind of collaborate to make sure we don't end up in those situations.
Great.
Mm.
When you talk about lead extractions, I've been there many times. Those leads are not flopping in the air. They're mostly stuck, pushing the septal leaflet down. Can you extract those leads? Or you can only extract the ones that are flopping, because once it's stuck, there's fibrose. You can't shave that off, can you?
Yeah. So the it's here. You know, it's highly variable where the binding sites are when we do lead extractions. There's no rhyme or reason, but we do find that thanks to the excimer laser sheath, by the time we get down to the tricuspid valve, we try not to laze. We just try to use the mechanical tools. But we probably know a lot more if we were visualizing it on TE, but we find a way.
And you don't destroy that septal leaflet?
Yeah, I mean, it's, you know, the most common indication that we extract the leads are for infection. So, you know, it's hard to know how much that affects the tricuspid afterwards.
Okay, excellent. Great discussion. And maybe you come up with some new Montefiore system specific prophylactic pacemaker placement strategy. Azim Latif is going to bring us home with what should be an exciting short overview of the investigational pipeline. That's what we're interested in, to push the envelope. So Azim, I know it's going to be exciting.
Yeah, I'll try and be brief and maybe just show you some of the things we're going to be doing in the near future as a health system, because I think it highlights kind of how far we've grown as a team here at Monte, bringing together, you know, EP, heart failure, imaging, and interventional cardiology together to be able to offer our patients really a vast array of technologies. And I'm always proud of the fact that I think a patient now doesn't have to leave the Bronx or Westchester to get any procedure done. And when it comes to a structural heart procedure, they can have it all done locally. And so that's something I think we should all be proud of. I'm not going to go through the vast array of current clinical studies. You saw that earlier, but maybe I chose one device in sort of each valve that I think was worth sharing or discussing with you that we're going to be seeing in the future. So let's see if we can get this to go. So everybody thinks that TAVR is done and aortic is done, but it isn't really. So, you know, Danny, Goldstein, we were talking earlier today about we need to think about patients' lifespan and how do we do procedures on patients that will last much longer. And so TAVR has been a huge success. And for many of us, we think, well, you know, it's as good as it's going to get. But I don't think so. We're currently working on ways of making better valves. So here's an example. This valve comes from a company called Antares. We're going to start doing, we'll probably do the first case in the United States at Montefiore in the next month. And what's unique about this valve is instead of it being 3 leaflets, it's a single leaflet bovine valve that's been 3D printed and 3D shaped. And what they're able to do with that is have hemodynamics on a valve that I've not seen before on a balloon expandable valve. So what we're going to see, and here you see some examples, hopefully the videos are working. Yeah, they're working. So on the left is what we're currently implanting is a SAPIEN 3 valve. On the right is the self-expandable core valve, and in the middle is this new valve. And what we're seeing with this valve, because of the way they've shaped the leaflets, we can probably get hemodynamics that are better than we've ever seen before. We think also that this will lead to better durability. I mean, one of the things when we do a TAVR valve that we just pushing the old valve to the side, right? We don't take into account the fact that we're not respectful of aligning our new valve with the old valve and with the native commissures. And maybe if we could do that, we would have a valve that would last longer, that would not have a risk of thrombosis, and would have better hemodynamics. So with this valve, besides the fact that it has this unique leaflet shape, we could also, before implanting, rotate it and try and align it with the patient's native commissures. And so what's been interesting, and here's some sort of MRI data looking at, on the top left, what a healthy aortic valve looks like. And you see how that color is very similar and homogeneous. That's what laminar flow should look like through a normal healthy aortic valve. And then when you look at patients with aortic stenosis or implanted with the current valves, we don't see laminar flow. We see flow that is often non-laminar eccentric. And if you look at the Dura AVR on the top right, we're starting to see flow that looks like it's a native aortic valve. So to me, that's pretty unique. Can we create a valve that will very likely mimic a native valve? And if it does, will it potentially have a lower risk of thrombosis? Will it have better hemodynamics? And will it have better durability? So I thought that was interesting to highlight, particularly since we kind of leading this study at Montefiore, both as the national PIs, but as probably will do the first cases in the United States. What about mitral? Mitral, if I had to talk to you about mitral devices, we'd spend all evening and we'll talk till Monday because there's just so many unique devices that are being developed. This is just sort of a device landscape. I think what's interesting is in just about every one of those groups, edge-to-edge, annuloplasty replacement, posterior leaflet enhancement, we have a clinical study right now or a device here at Monte to be able to treat patients with the most complex anatomies. But I thought what I'd highlight is, I'm just going to go forward just to maybe one device, sorry, because time's late, so I'm going to not take you through all of these, but I thought I'd take you through one device. This is the device that me and Edwin Ho have helped kind of develop this procedure, which is which is trying to do what Danny does with open heart surgery, which is to deliver cords to a prolapsing mitral valve leaflet, but to do this on a beating heart. So we'd go transeptally, implant 2 cords onto a prolapse leaflet, and then anchor it into the pulmonary muscle, cinch it, and essentially correct prolapse the way a surgeon would do, but do this on a beating heart. Sounds kind of far-fetched when you see it on the animation, but I thought I'd share with you. We've done a number of patients now, me and Dr. Ho. This is the first patient we ever treated who's like out to a year. So you see on the top picture, this P2, focal P2 prolapse with severe mitral regurgitation. And then you look at the bottom, the prolapse is gone and there's no mitral clip. There's no edge-to-edge device. There's nothing obstructing the valve. We've done a surgical-like repair, except for the annuloplasty, Danny. I'm gonna do that soon too. Don't worry. But we essentially doing a surgical-like correction with catheters, right? And so this is the patient a year later. You see that anchor in the pulmonary muscle, the screw-like anchor, and you see how his ejection fraction is improved, and he still has really a great result at 1 year. So again, trying to mimic what surgery does, but maybe trying to do it in a transcatheter option. Sorry? That's moderate. So the great part about what we do with transcatheter is we don't have to do everything at the same time. We can stage it. So then next we'll bring him in for his TAVR. How about that? So I'm going to choose now one from tricuspid. How about that? So this is the array of tricuspid devices that are available. We can do annuloplasty. We can do edge-to-edge, bring the leaflets together, improve coaptation, and we can replace the valve. And we can replace it with a biological valve in the position, or we can do orthotopic replacement. I'm just going to take you, I had 2 cases I wanted to take you through. I'm just going to take you through the ones. I apologize for going really quickly here, but I'm just going to go forward and just show you one case because I think it's pretty late in the evening. And I'm going to still go forward some more and show you something that I think is pretty, maybe too far. I think interesting, different, and sparks a lot of controversy, and that's why I'd like to talk about it. So here's a patient we treated recently, a 62-year-old male, lots of background medical history, prostate cancer, lots of GI bleeding, cirrhosis. He's had lots of open heart surgery, an aortic dissection, a mechanical aortic valve, then a cabbage. He's got an ICD, and he's had for a while now severe secondary TR. very symptomatic. He's got ascites and recurrent ascites, and has really been very symptomatic. He's a patient with really minimal options available. He's not a great surgical candidate. He's not going to do well surgically. He's going to spend a long time in hospital and probably do poorly. We calculated there's these new scores to calculate these patients' mortality, and his mortality in hospital is probably going to be in the range of 20% or more. So we evaluated him for a lot of different options. Here, just showing you his anatomy. We're talking about leads. That's why I wanted to look at this case. He's got no coaptation of the leaflets. His RV is not looking great. It's dilated and it's hypokinetic. And he's got severe TR with a right atrial pressure of 15. Like I mentioned, he's also a little bit cirrhotic with recurrent ascites. So we evaluated him. He's not a great case for edge to edge because of that big ICD lead there in the middle, plus the fact that there's no coaptation. We also didn't want to jail the ICD lead and put another valve there. We thought that would be bad. And we're also concerned that he wouldn't tolerate the fact that we replaced his valve. So we worked him up for something kind of more unconventional. Here again, just showing you the ICD lead, which seems mobile, but really is in the center and makes putting a device there much more challenging. So what we worked him up for was implanting valves in his inferior and superior vena cava. It's a procedure that's been around for a while now. It's actually now approved in Europe. We're starting to do clinical studies here in the US. I thought I'd highlight it just because it really is kind of very different to what a surgeon would do, right? I mean, normally in surgery, you'd replace or repair the native valve. Here we're saying, you know what, we can't repair or replace the native valve. So what about if we put a valve in the cava to get rid of the negative effects of the TR on his liver, on his kidneys, decrease his ascites. So that's what we did. It's actually a fairly easy procedure. It probably takes about 30 minutes to do. We start by putting a valve into the superior vena cava, making sure it anchors and that we don't obstruct the confluence or the left brachiocephalic vein. We then go through the same access. Here you see the valve being delivered. Actually, probably one of the easier procedures we do in structural heart. We are jailing the lead, but in the SVC, not in the tricuspid. And then we look at where the hepatic vein is, and then deliver a second valve in the IVC, making sure we don't obstruct the hepatic veins, because you wouldn't want to obstruct the hepatic vein flow, and then releasing it. And then also looking at this patient's hemodynamics before and after, which are really interesting. So here you see us delivering that second valve. And that's what it looks like in the end. You see his mechanical valve, you see his ICD lead, his atrial lead, and you see these two valves in the cava. For a patient who really had no other options, since we've done this, he's certainly felt better. His ascites has not reaccumulated, but we still don't understand what the long-term consequences of doing this is, because we're not really changing or treating the valve. But what's been interesting, by actually not allowing the patient to regurgitate into their vena cava, in some of the clinical studies, you actually see remodeling, which is something I would not have expected. Why would you get RV remodeling when you decrease the TR? But it's probably got to do with the fact that you're decreasing the amount of regurgitation volume. Because before, this patient had huge CV waves up to his ear, and now there are no CV waves anymore. So the only place he can regurgitate into is the atrium and no longer into his IVC and SVC. So I just thought we'd highlight that a couple of new things that are coming on the horizon that are a little bit unusual to the sort of more standardized things that we usually show you, which are clips and valves in the tricuspid space. But this is a little bit different. I'll stop there. Let's see if there's any question.
That was outstanding. I don't think there will be. Are there any questions in the room? I'm not sure. It was really incredible end to this day. Thanks everybody for coming. The spirit today was really that we sometimes you go to meetings at places and they talk about what the cutting edge is because they have read it in the New England Journal of Medicine. But today we had at least 7 technologies where we said, this is a cutting edge and we're doing it. Or we did the first one, which is extremely exciting. So we're only 7 minutes late. So I'm very proud of that. We still have people on Zoom. Thanks everybody who can see us wherever you are. And we're going to close now and go have a glass of wine somewhere. And we'll see you tomorrow morning, 7:30 sharp. So thanks everybody. Thanks for coming.